Good morning. I'd like to welcome you all to Seattle. I'm Ben Wilfond. I'm the director of the Truman Catt Center for Pediatric Bioethics, and I'd like to welcome you to our 10th anniversary conference. It's great to see some familiar faces as well as some new faces. We have about 104 people registered, including approximately 70 from outside the state of Washington, so I'd like to welcome all of our out-of-town guests and hope that you enjoy the 2 days in sunny Seattle. It's like this every day of the year, and very happy to have that. This year, our conference is on ethical issues in research, and as typical for our conferences, we have a few sub-themes that are running through different portions of the conference. This morning, you'll be hearing about research in the developing world. This afternoon, we'll be talking about research related to standard clinical practices. Tomorrow morning, we'll be talking about issues in genomics and biobanking. For those of you who have been here in the past, you also know that one of the things we try to do is end every day with something special. And I think this conference, we have two very special things in different ways. The conference this afternoon will end with a talk by Eva Kor, who is a survivor of the Holocaust and who is a subject in the Mengele studies in Auschwitz. And for those of you who have not heard her speak before, it's one of the most moving things to hear her story and her journey through her life, both during that time and afterwards. And finally, at the end of the conference tomorrow morning, we are very fortunate to have Alex Capron, who is, this is his first time, I think, coming to Seattle for one of our conferences, and we're very excited to have him here. He has been one of the leading thinkers in bioethics for decades and has been heavily involved in issues related to human subjects research, and I'll be looking forward to his comments. Besides our talks, we also will be having a series of panels where the audience can interact. We also have one of our highlights of the conference is a session that Doug Diekema will be doing this morning, where he will be leading a conversation with many of our panelists. That'll be very interactive. And finally, tomorrow morning, we'll have some breakout sessions. I'd also like to do a couple of thank yous, and actually the first thank you I'd like to do is to Doug Diekema. Doug is our Director of Education for the Truman Catt Center. Doug is responsible for organizing these conferences. I also want to mention that this year, Doug is also the recipient of the American Academy of Pediatrics Bartholomew Award, which is an award given by the American Academy of Pediatrics every year. And we're very excited about that. It's a huge honor. And Doug, again, thank you for your work with this conference. I also would like to thank a number of other people, and I won't go to too many thank yous right now. I'll save a little bit of that for later. But there are the three Ks, Kathy Cohorn, Kathy Fennell, and Kate Landry, who are the people who do all the work behind the scenes in making this conference happen. And this conference could not happen with all of their help, and I really very much appreciate them. Please thank them. So, just a few more. The only thing I want to mention before I get on to the next part of my comments is to mention that we already have our conference for next year scheduled. It'll be not this weekend, but this next weekend in July. It'll be July 24th and 25th. The tentative conference title is Provider, Patient, Parent Relationship, Duties, Responsibilities, and Challenges. And that should be a very interesting conference, really getting into some of the challenges of interpersonal interactions. Because today is our 10th anniversary conference, I thought it'd be worthwhile to pause for a few moments and talk a little bit more about the history of the conference, but you won't be hearing this from me. What I'm going to be doing is inviting Kathy Randall up in a few moments. Kathy was the chair of the Board of Trustees in 2004 to 2006 when the center was developed, and we've been talking with her, and she very graciously agreed to come up and share with you some of her perspectives of how the conference started. After I have Kathy come up, I'll then introduce Norm Fost, who will be our first speaker. And Norm has probably the record of being at the most number of conferences over the years, and also was involved with working with Doug Diekema and Jim Hendricks and Bruder Stapleton 10 years ago to develop the center. So Norm will also share some of his insights as well. But Kathy, I'd like to have you come up and say a few words, and really glad to have you here today.
Good morning. Thank you, Ben. It's a real honor and a pleasure to welcome you to the 10th Annual Conference of the Truman Katz Center for Pediatric Bioethics. The center is the first program in the country to focus on pediatric bioethics. It was established in November of 2004, and in September of 2005, the Board of Trustees named the center in honor of Truman as a fitting legacy of his 26-year tenure as president and CEO of Seattle Children's Hospital. It's wonderful to have Truman and his wife Sue Ellen with us today, and I'd like Truman to stand and be recognized, please. His continued support of the center is invaluable. The center was Truman's vision. He strongly believed, and I know he still does, that the center would be central to the hospital's commitment to the highest ethical standards in clinical care, education, research, and advocacy. He further believed that it was privilege and an obligation for Seattle Children's to develop the center dedicated just to pediatrics. The conference has become a vehicle to take this commitment to promote policies and advocacy for best practices beyond the walls of Seattle Children's and to national and international recognition. Initially, the center received federal funds, and the hospital dedicated some startup funding. The board then designated $3.5 million in endowment funding when naming the center upon Truman's retirement. Philanthropic support continues to be very important to the center. I want to thank those who have made significant donations to honor this 10th anniversary, including Truman and a number of trustees and staff who had the privilege of working with Truman during his 26 years at Children's, and many of whom are here with us today. Through the generosity of Children's benefactors, this year donations to the center are being matched 2-for-1. Please consider joining Truman and me in supporting the Truman Katz Center. Additional information will be available following the conference, I understand from Ben. So on behalf of the trustees who were fortunate to work with Truman during those 26 years at the hospital, thank you for being here today and for all you do to add to the successes of the center. Thank you.
Thank you very much, Kathy. You know, it really has been an honor to serve as director of the center, and it's really has always been, I'm not quite sure what the right word for it is, but it's just been phenomenal the way the entire hospital has supported a program like ours. It's a real pleasure for me to introduce our first speaker today, Norm Fost, who I think at this point holds the record for the person who has attended our conference the most number of years as a speaker. And he comes back every year because there's no topic we can do that he doesn't have something interesting to talk about. For those of you who are new this year, I will tell you a little bit about Norm. Norm is at the University of Wisconsin, where he has been for the last 40 years. He has been the chair of their IRB, the chair of their ethics committee. He has written in a wide range of areas related to bioethics. He served on many national committees, presidential commissions. He's received probably every single award in bioethics that exists. In addition to the Bartholomew Award that we heard about with Doug today, he also has received the Patricia Brown Award, as well as the Nellie Westman Prize for Research Ethics, and also a Lifetime Achievement Award from the U.S. Department of Office of Human Research Protections. He also is on many TV and radio shows, and is has really provoked many of us to think more about bioethics. And finally, he was one of the people that Seattle Children's reached out to when they were thinking of developing the center 10 years ago. And so Norm will begin by actually sharing some of his reflections on that time too. So Norm. And, okay.
Thank you, Ben, and thanks to you and Doug for inviting me out year after year. The main thing is that I be invited out more than Lainey Ross, and I think I'm still one ahead of her. So if I can maintain my lead, that'll be good. I also appreciate the opportunity to reflect on the privilege I had to be involved with the origins of this center. It was probably 13 years ago that Jim Hendricks gave me a call and said he wanted to learn more about how to upgrade their IRBs, is my recollection of what the original project was. And I said, glad to help. I was chair of our IRB at the time. And Jim came out to Madison, spent a considerable amount of time learning what we did, listening very carefully. And then the conversation expanded. He told me about the interest that the Children's Hospital had in developing a Pediatric Bioethics Center. And I said I'd be glad to help with that too, and that led to an invitation to come out here and spend a few days meeting other key people, including Truman Katz, I'll say more about in a minute, and the board of directors. And what I said, it was a very amazing set of conversations, because I said, everything I said, they sort of not just wrote down, but said, yeah, we can do that, we can do that, we can do that. And I said, you know, this is not simple. You can't just have one person, he or she needs colleagues. You're really going to need 2 or 3 or 5 people. You're going to need to have one of these ethicists be head of the IRB, because that's really where the ethics clinic is. That's where you get a steady state. You're going to need a training program. You're going to need to be connected with the university. You're going to want fellows to have young people stimulating you. It's going to take a few $1 million to get this off the ground. But that's no problem. That's no problem. And then I met the board of directors, which at the time was an all-female group. I understand that's been changed, but that was an amazing experience too, sitting in a room having 12 or 15 women listening to me. At home, I have trouble getting one woman to listen to me. And having this dozen or more group of people not just listening, but writing down everything I would say and nodding their heads and say, yeah, we can do that. It was like a dream come true. And then best of all, when Truman put his money where his mouth was and came up with a substantial amount of money to get this on the ground, and they initiated a national search and looked at really all the best people in pediatric ethics, and wound up with 2 of my former residents. I was head of the residency program when Ben Wilfond and Doug Diekema were training in Madison, and got them to come out. Ben eventually as director, Doug as chair of the IRB, head of the education program, and so on. That was just immensely gratifying and ensured my continued connection with the center. But best of all those memories was meeting Truman, who was CEO at the time. And it's just one of those rare moments when you meet somebody and you just know, as Malcolm Gladwell would say, within a blink, that this is somebody you connect with, somebody who you're thinking on the same level with, and who you resonate with. And Truman did everything he said he was going to do and more. This conference is just, the whole center is just far more successful than I ever dreamed could ever be achieved, and he really gets the credit for it. One of the things I told him and the board is that to have a bioethics center succeed, you need buy-in from key institutional leaders, because you can't have key figures in the institution thinking this is just a bunch of meddlesome people who are annoying us. And what I had in mind when I said that was chairs of major departments. And Bruder Stapleton, the chair of pediatrics, definitely bought in. But you need other powerful figures. But what I never really dreamed was that the most powerful person, the CEO of the institution, would not just buy in, but just have the vision to see that this was a necessary part of a national children's hospital. So Truman and I have often talked about how we both regret that I wasn't able to come out here and head the center, because it's really what I would have wanted to do, but I had other family ties in Madison and so on, and it was at a point in my life where I couldn't move. But that would have been that's the only disappointment I have about the whole thing, because it would have been great living out here and working with him. But Truman, it's always great to see you, and thanks for making all this possible. With that now, let's move to some comments about international research ethics. In 1300 BC, after the inhabitants of Gilead inflicted a military defeat upon the tribe of Ephraim, the surviving Ephraimites tried to cross the Jordan River back into their home territory, and the Gileadites secured the river's fords to stop them. In order to identify these refugees, the Gileadites put each of them to a simple test. Whenever an Ephraimite fugitive said, "Let me cross," the men of Gilead would ask, "Are you an Ephraimite?" And if he said no, they then said, "Very well, say shibboleth." The pronunciation of the Hebrew word shibboleth was used to distinguish Ephraimites whose dialect lacked the sh phoneme, such as in shoe, from Gileadites whose dialect did include such a phoneme. So if anyone said sibboleth instead of shibboleth because he could not pronounce it, they would seize him and kill him by the fords of the Jordan. 42,000 Ephraimites fell on this occasion, unable to use the word shibboleth, to say it. So shibboleth has since come to mean, or to refer to an old idea or opinion or saying that is commonly believed and repeated, but that may be seen as old-fashioned or untrue. Shibboleths are, in the modern parlance, also has come to mean saying something because it sounds good, because it will get you where you want to go, get you to cross the river, or get you into the halls of bioethics and make you sound like somebody who knows what you're talking about. Shibboleths are common in bioethics. Here's just one famous example in research ethics. You can't discuss or write about research ethics without quoting this one, the first principle of the Nuremberg Code, namely that the voluntary consent of the human subject is absolutely essential. Well, this is a shibboleth. It's something that sounds good to say it, but really is quite off the mark, as we all know. If that were true, that the informed consent of the human subject is necessary, we could not have any research on children. We can't get meaningful consent from children. We couldn't have any research done under the waived consent provisions of the common rule, which most people think are a fairly sensible exception. We couldn't have research in emergency settings, such as research on cardiac arrest, where consent from the patient or his or her surrogate is usually impossible. None of this would be possible, and yet all of these kinds of research go on with generally wide acceptance. So to say that the informed consent of the human subject is essential is a shibboleth, and yet it's repeated over and over again, and you see people saying it. What I'd like to do today is to go through 4 or 5 other shibboleths in international research, statements that sound good and that are constantly regurgitated, but which I think are shibboleths and really can't withstand scrutiny. So here's a short list. Number 1, if it's wrong to do a study in the US, it's wrong to do it everywhere. If you do it elsewhere, particularly in a developing country, then you're using different ethical standards. Another one is that subjects in the control group should receive the best proven therapy. That's what it says in the Declaration of Helsinki, or did for much of its life. But if effective treatment exists, that a placebo should not be used. Third, that a randomized trial should be in equipoise. You should be really uncertain about which arm is better. Fourth, that the benefits of a trial should be available to the host country. You shouldn't do research in a developing country just to benefit people elsewhere. And maybe the worst shibboleth of all is this notion that the Helsinki Doctrine is a coherent guide to ethically responsible research, and yet everybody salutes it. The FDA requires you to pledge allegiance to it as a condition of doing clinical trials. So to explicate why I think these are shibboleths, I'd like to go through 2 very famous, or infamous if you like, studies and examine some of the criticisms that have been made about them. So a shibboleth is an old idea or opinion or saying that is commonly repeated but that may be seen as old-fashioned or untrue. To do this, I'm going to be daring. John Paris tried this at this conference a few years ago. I'm going to try to to use the methods of Socrates and be a little bit interactive and ask you to participate a little bit just to get some ideas flowing about common ways of thinking about these problems. So I'll be asking a few Socratic questions in a few minutes. My goal is that by the end of this session, you will be in a situation similar to the king of Siam, who famously said, "There are times I almost think I am not sure of what I absolutely know." I don't insist that you agree with me about the points I want to make about these shibboleths that I mentioned, but I hope you will at least be unsettled, that you'll be less sure about what you previously thought about these common so-called truisms. So the first trial I want to talk about is the famous maternal-fetal transmission trials in Africa and Asia in an effort to try to reduce maternal-fetal transmission of HIV. And to get at that, we need to just spend a few minutes on the background trial that led to the Third World trials, which was the famous 076 trial in the US. So at the time, in 1994, AZT was the only approved drug for HIV/AIDS. Maternal-fetal transmission in the US was around 30%, but it's important to note that the range was from 5% in upper New York State. In rural parts of New York State, there were centers, populations in which the transmission rate was only 5%. In Harlem Hospital, it was 40%. AZT had been approved only for patients with clinical AIDS. It had not yet been tested or approved with people who were just HIV positive and had no clinical manifestations. So the benefits and risks for HIV asymptomatic patients was unknown, and the fetal effects were totally unknown, so whether it was safe to give it to pregnant women was unknown. So this trial called 076, because it was the 76th trial done on patients with HIV/AIDS, was a trial giving this drug to, excuse me, I'll take a drink in a minute if this continues, giving it to HIV asymptomatic pregnant women who were randomized to receive either AZT or placebo. The regimen involved a daily oral AZT from about the 5th month of pregnancy, a single IV dose during labor and delivery, on the theory that that was a peak time for transfer because of all the blood and broken skin of the baby, and then 6 weeks of oral AZT to the infant. So this was the proposal for the 076 trial, to randomize HIV positive but asymptomatic pregnant women and to randomize them to this AZT regimen and a placebo. So let me pause there and ask if anybody in the room has any concerns with that trial design, ethical concerns. The idea of withholding a, yeah.
One thing, although I understand that AZT was only approved for people who were showing clinical symptoms of AIDS, it does seem like the problem is so serious that in some ways I worry about a placebo group.
Great. So the comment was made that she's concerned, as many people were, that even though the risks of AZT to the fetus were unknown, the risks of HIV transmission was certain death at the time. Virtually all affected infants died, and usually very young. That that risk seemed much higher, and therefore given placebo. So what that concern led to was the proposal that that we just study a large cohort of women and give all of them AZT. A single-arm cohort study. That sound. Say it again. That sounds to me like giving AZT to a large group of HIV-positive women. Well, this was a common suggestion at the time, and it's not just an ethical issue; it's a scientific issue, because here is the design that this woman is suggesting, and thank you for being brave and participating. Forget the placebo part. That would be ethically problematic. Let's just give AZT to a cohort of HIV asymptomatic pregnant women. And the scientific problem that was raised from that, apart from the ethics, is suppose you got that number. What do you, let's assume that was the result of that trial. What do you know now that you didn't know before?
I see your point. However, the one thing I would say is, I'm not just saying randomly just pick people. I think you would have to start with some defined population. For instance, if we know at Harlem Hospital that the rate is about 40%, I believe as you suggested retrospectively.
Right.
And we got that number with a group of women from Harlem Hospital randomly selected. Then, I mean, it wouldn't be as rigorous as if we had two arms and you could say, yes, here's your P of 0.05. But
So first, sorry, thank you. So first, I hope it's clear that if you did this study that's on the screen right now, you would know nothing that you didn't know before because you would have no idea what the rate of transmission would have been in that population that you're studying. And what our colleague is suggesting here is, well, maybe if you did it in a defined population where you, quote, knew, end quote, the transmission rate was 40%, then 20% would look pretty good. But so this is using a historical control, and we know that generally in clinical trials, that's beset with all sorts of problems. We later learned that the factors that affect transmission is not just where you live, but many, many things, which could vary enormously in any one hospital. So what your viral titer is turned out to be very important. What strain of the virus you had turns out to be important. When you acquired it, before or during pregnancy, when in pregnancy you acquired it, whether you had associated, particularly sexually transmitted diseases can affect transmission rate, your nutritional status, genetic factors, the mode of delivery, C-section versus vaginal delivery, breastfeeding versus formula. We later learned that that can be an important transmission factor, and then totally unknown genetic factors. So even if we did this study in a defined population, as you suggest, we would have no idea about all these other factors, and that's the magic of randomization, to try to neutralize all those factors. So for all those reasons, and the objections you raised were raised by many thoughtful people, and the suggestion you made was made by many thoughtful people. But cooler heads prevailed, and the study was done as a randomized controlled, placebo-controlled trial, and that trial was stopped before it fully enrolled because the difference was so dramatic, with not a complete ablation of transmission, but a dramatic reduction from 25% on the placebo group to 8%, with a p-value with 4 zeros after it, and 0.7, so the trial was stopped, and 0.76 immediately became the standard of care in the US and Western Europe. So that's the background. But this was a study done in a country that, while HIV/AIDS was a serious problem, affecting 1 in 1,000 people, which is a lot of people, this was child's play compared to the problems in Africa and parts of Asia. So let's just go to Uganda as one of the countries of great concern, in which the incidence of maternal HIV was 40% in some villages and districts of Uganda. 40%, almost half of the women in this country were destined to die, including pregnant women. Giving the 076 regimen to this cohort of women was a non-starter. First of all, the cost of it was approximately $1,000. The total healthcare budget of Uganda was less than $10 per person per year. AIDS was very important, to understate the case, but there were many other crises that they were facing in healthcare. There was no prenatal care in Uganda. Many people, most women did not show up anywhere until they were in active labor. So finding them and getting them to start taking a drug from the mid-trimester on was a non-starter. You'd have to develop a whole new healthcare system. The stigma of HIV was even greater in Africa than in the United States, so the idea that these women would come in and get tested in an American-sponsored trial was wishful thinking. A trial sponsored by the US all by itself made it problematic. So there was a need for an inexpensive, deliverable intervention, and the 076 regimen was not it. So a very bright idea surfaced as a result of subgroup analysis of the 076 trial. Namely, there was a group of women who started in the trial and then dropped out. But they showed up for labor and delivery at the healthcare center where they were getting their care. So they had had a few doses of oral AZT, some for a week or two, some for a month or two, but very variable, and none of them had the whole course. But they all got the IV single dose during labor and delivery. So this later euphemistically came to be known as the short course. And it was noted that the transmission rate was lower in the women who got this short course than in the placebo group. The significance of this is uncertain, as it always is in subgroup analysis, because this was a statistically small sample. You couldn't do meaningful statistical analysis on it. It was possibly a bias sample. Why did these women drop out? Maybe they were richer, poorer, better nutrified, had more or less other STDs. You couldn't tell if they were really similar to the placebo group in the trial. And they received widely varying amounts of oral AZT. So what the subgroup analysis did was generate an interesting idea that maybe a short course, maybe just a single intrapartum dose might accomplish something, because they at least all had gotten that. So the proposal was to try this short course out in Uganda and dozens of other countries. So this was the proposal, to somehow identify women who were HIV positive and randomize them into a trial in which half would get just this intrapartum delivery. All you had to do was identify them at the time of labor and delivery through their equivalent of midwives, and give this single dose at the time. This could be done in a tent with attentions to privacy, the best standards of consent that could be applied, and see what happens. Does anybody have a problem with this design? Anybody? Yeah. Great. So she said it doesn't offer the best proven available. We have now a proven effective therapy. The Declaration of Helsinki said that that's owed to everybody in the trial, later modified to everybody in the control group. Yeah. So she's disagreeing with the first woman who correctly points out that this, ethics aside, this is a violation of the Declaration of Helsinki, to which virtually all researchers pledged allegiance. So Dr. Sidney Wolfe and Peter Lurie wrote a blistering editorial in the New England Journal of Medicine, accompanied by an editorial by Dr. Marcia Angel, the editor of the New England Journal, both editorials strongly condemning this proposed design, which was stimulating a lot of public debate at the time, and said that instead, because of this duty to make sure that at least people in the control group got the best proven treatment, this was the design that should have been done. The short course should have been compared to 076. So suppose you did that trial and you got this result. Both groups turn out to have 18% transmission. What do you know now that you didn't know before? It's just as good as 076. Is either of them any good? You have no idea, because this lacks what Bob Temple, the most important figure at the FDA, it lacks what is called assay sensitivity. You just don't know what the rate would have been if people had received nothing. And in fact, if you look at the actual results of I'll come to that in a minute. So the problems with giving 076 to anybody in Africa was, first of all, you couldn't do it logistically. It was just physically impossible to change their healthcare system so you could diagnose these women and deliver this drug for mid-trimester. Second, even if you did that, which you couldn't do, but even if you did and it turned out to be better than the short course or even better than placebo, so what? As this woman over here is suggesting, this would be of little or no use to the women of Uganda because it would not be deliverable. You might prove it in a study. You might be able to get enough money to somehow do this study, but if the purpose of a study is to help the people in the population that you're studying, 076 was not going to be that. Bill Gates was not interested in subsidizing a $1,000 regimen that would require change in their healthcare system. It might be useful to women in the U.S., but that sounds like exploitation of Ugandan women. It would require a much larger sample size, which would take longer to do, and more children would die while you were studying this because of the larger sample size. And in fact, this is a slide summarizing the outcomes of the short course trial. The short course trial was done, that is short course versus placebo, in 20 or so countries, and the results ranged from 10 to 18% transmission in the short course group and 19 to 26% transmission in the placebo group. Not as dramatic as 076 versus placebo, but statistically significant in some centers. And in fact, if I put the actual numbers on the board, you'll notice on your left in the short course group, there were some countries in which the transmission rate, the highest recorded, was 18.9%. And in the placebo group, there were countries in which the transmission rate was, in the population they studied, was 19%. That's no difference. That is, if you did not have a placebo group, you would not know, you might have the same transmission rate with the short course or placebo. So it worked in some places, but not others. And it depended on all these other factors that were difficult to evaluate. So the short course placebo design, which was harshly criticized by these writers in the New England Journal, including the editor, went forward. The criticism of Dr. Angel and Drs. Wolf and Lurie for writing these, the tone of the editorials and the absence of any opposite point of view at the time, having two editorials on one side of the issue and no counterfactual editorial, led to the resignation of David Ho, the Nobel laureate who invented antiretroviral treatment. He was on the editorial board. And Catherine Wilford, who was the country's leading expert on neonatal HIV/AIDS. They resigned in protest over Dr. Angel's and Wolf's and Lurie's handling of that, which led to an invitation to Harold Barmas, head of NIH, and David Satcher, the Surgeon General, to write an editorial providing the rationale. The criticisms of the short course study, as I said, or as was mentioned, were first that proven effective treatment should not be withheld, that it was wrong to use a placebo if effective treatment exists, and that if it's wrong in the US, then it must be wrong in Uganda. These were the main points of Angel, Lurie, and Wolf. Let's just look at those criticisms in a little more depth for just a couple of minutes. This claim that proven effective treatment should not be withheld, or as the Declaration of Helsinki said at the time, and the declaration has been revised many times over its history, but the version that was in effect at the time of these African Asian studies said, quote, in any medical study, every patient, not just the control group, every patient, including those of a control group, if any, should be assured of the best proven diagnostic and therapeutic method. Just think about what that means. Let's just take a much less controversial kind of study. Let's say a pediatrician here at Seattle Children's wants to test a new antibiotic called wondermycin and compare it with the standard of treatment for otitis media, amoxicillin. This would be the traditional way that he or she would set up this trial. This is what the FDA would require, an equivalency trial or a non-inferiority trial with the proven effective standard treatment. But the Declaration of Helsinki says that every patient must receive proven treatment, and therefore what the trial would actually have to be, since everybody would have to receive proven effective treatment, the children, even in the experimental group, the new intervention group, would have to get wondermycin plus amoxicillin. This is a zany way to do a trial. This is a regimen that neither the company nor any sane pediatrician is interested in learning about. Nobody wants to have a double regimen as a first-line therapy for otitis media. And more important, this trial would tell you really very little about what wondermycin alone would do. You would have no idea without having it tested as a solitary drug. So this principle of the Declaration of Helsinki would prohibit almost all clinical trials that had been done in the U.S. and elsewhere over the past 40 years. Moreover, another section of the declaration says that the reports of experimentation not in accordance with the principles laid down in this declaration should not be accepted for publication. This would have prevented the publication of most clinical trials that had been done under FDA oversight of the last 40 years. It would have prohibited publication of the AZT short course trials in Africa. So it not only forces investigators into an untenable scientific position, forcing them to do studies which you can't learn what you're trying to learn, but it prohibits the information from those studies from being disseminated. So this notion that proven effective treatment should not be withheld obviously is problematic. It's important to note that no one in the short course trials was deprived of treatment as a consequence of the study. Women in the placebo group did not get any treatment, but that wasn't as a result of being in the study. They would not have received treatment whether they were in or out of the study. So the study didn't result in anybody being worse off than they would have been without the study. Maybe if there's to be any kind of principle, it should have say something like that no one should be deprived of available proven effective treatment. But as we've seen, even that would be a problematic principle, as the otitis example suggested. The criticism that it's wrong to use placebo if proven treatment, effective treatment exists. Again, a placebo group was not deprived of treatment due to being in the study. There was no risk of harm of being in the placebo group. You might be harmed, your child might get the disease, but it would not be as a result of the investigators who are being in the study. The women in the AZT group might be harmed, or their babies might have been harmed, but there were high standards for consent as best could be achieved in that population. That is, nobody was deprived of information, and they presumably joined the study willingly. And then this final criticism that if it's wrong in the US, then it must be wrong in Uganda. You certainly could not have done the short course trial with a placebo control in the US. It would have been clearly ethically problematic to withhold proven effective treatment from women in the US for whom 076 was widely available, paid for by Medicaid. And this parallel claim that Dr. Angel made that if you do a trial in Uganda that you would not do in the US, you're using different ethical standards. Well, the ethical standards are the same, and this is the key point, but it's the facts that are different. And as the title of this talk suggests, when you see studies being done in the third world that are ethically indefensible in the US, or at least problematic, it's not different ethical standards in the two places, it's different facts on the ground. What are the ethical standards? Well, Zeke Emanuel and colleagues have written an excellent series of papers on what makes research ethical, including a paper on what makes international research ethical. And here's his list. It's one that I think everybody subscribes to, including me. There should be a collaborative partnership. Any research should be involved not just the investigators, but the population that's being studied. The research must have some social value. It should be important. Must have scientific validity. It should be designed in a way that you can learn what you're setting out to learn. It should be fair selection of subjects, favorable risk-benefit ratio, institutional review, high standards for informed consent, monitoring for adverse events, publication of results. There are a couple of others, right to withdraw and so on. All these principles were followed in the African AZT trials. The ethical standards were exactly the same, if these are your ethical standards. What was different was the facts that made it inappropriate to do that study, even by these standards, in the US, because these criteria would not have been met. Now, let's move on to a second collection of shibboleths in the Declaration of Helsinki and cited elsewhere, raised by a different study, much more difficult than even the ethical issues raised by the AZT trials. So the Declaration and other international codes of ethics all say pretty much the same thing on this point, namely that medical research is only justified if there is a reasonable likelihood that the populations in which the research is carried out stand to benefit from the results of the research. And at the conclusion of the study, every patient entered into the study, including those in the control group, should be assured of access to the best proven prophylactic, diagnostic, and therapeutic methods identified by the study. Well, it's a little unclear why this is a requirement or should be, but the value of this principle, or the coherence of it, was dramatized by an infamous, if you will, highly controversial for sure, study involving a form of surfactant called surfactant. So as background for this, surfactant is a chemical that improves outcomes for hyaline membrane disease, also called respiratory distress syndrome, which is probably the most common cause of death in infancy in the United States. The most common cause of death in infancy is prematurity, and the way prematures die is mainly from premature lung disease. And surfactant, due to inability to manufacture surfactant at early gestational ages, and this can now be made in a factory and sufflated into the respiratory tract with improvement in outcomes. There were several different forms of surfactant. This is a very large worldwide market, and so several companies were interested in having their own Me Too versions of surfactant to get part of this market share. And a US company called Discovery Labs wanted to join the party and sought to get part of this market with a new version called surfactant. The FDA insisted on a placebo-controlled trial, which they virtually always do, even with a very serious life-threatening disorder. And the reasons they do is mainly because of Bob Temple's insistence that this problem of assay sensitivity leaves you in the dark if you don't have a placebo group. So for rightly or wrongly, surfactant could not get the FDA to consider this drug without a placebo-controlled trial. Doing it in the US was a non-starter. No US investigator was willing, appropriately, to withhold proven effective treatment from children with a life-threatening disorder. So it was considered unethical in the US to do that. But in countries like Bolivia, where there was minimal availability even of neonatal intensive care units, inability to afford surfactant, the healthcare budget of Bolivia at the time was about $100 per person per year. So this was a drug which was largely non-deliverable in Bolivia. The investigators, the sponsor, the Discovery Labs, saw this as an opportunity to do a placebo-controlled trial in a country where they thought it could be ethically justified. So the proposal was to find a group of premature infants with respiratory distress syndrome in Bolivia. They would all get Cadillac NICU care. That is, what the company would do would be to build an ICU that was state-of-the-art, staffed with highly trained people who they would train, arrange a transportation system, helicopters, and so on. So everybody in the study would get standard of care that was, or a level of care that was far above what they would have received without the study. And half of them, in addition, would get surfactant. So the design was NICU plus surfactant versus NICU plus placebo. Does anybody have a problem with this study, with the design of this? Yes, ma'am. Glad to have at least one foil. Yeah.
Well, my one issue with you is the following. I think it's not so much, I can see their point. What I think you have to think about is the long-term outcome. So let's say we find out surfactant really works. Is that really just going to become an issue so I can get FDA approval and make money in the US?
That's exactly it.
It's great to put infrastructure in place with the study, but like, are we going to make surfactant available to Bolivia? So we have less of a problem with it if that was the end goal, kind of like the short course in Africa.
She said her problem is not so much with the design of the study, but with the aftermath of the study. If surfactant was not going to be available generally in Bolivia, that this would be some sort of exploitation. And that's exactly what the sponsor agreed to. I mean, he acknowledged that it would be unlikely that the country of Bolivia would have the money to do this generally, because it wouldn't have the NICUs. she says that even if it were available generally in Bolivia, you don't know if it's going to work elsewhere in Bolivia. That's a problem with all clinical trials, because you can't do a clinical trial on everybody in the population or every village and town in the population. So there are always going to be questions about generalizability. Armand, one more comment.
So why is the FDA only willing to accept a randomized placebo-controlled trial as opposed to a non-inferiority trial?
Dr. Anna Maria is asking, why did the FDA insist on a placebo-controlled trial? We don't have time to go into all that. I mean, there is a coherent answer, and it's related to the one that, for various reasons, an equivalence trial or a non-inferiority trial, Bob Temple thought, would not give you the information. That it had a high risk of producing misleading or useless information. But in the readings, there is a reference, I think, to Bob Temple's long article about this, providing a detailed answer to that question. So there is at least a coherent answer. So the trial was done. The suggestion that it be done without a placebo group had the same problem that the AZT trial had, namely if you just took a bunch of premature infants and put them in a NICU plus surfactant and they did better than historical controls, you would have no idea whether this was due to the NICU, which was a new thing for most Bolivians, or due to the surfactant, because you have two interventions. So you needed to control for those factors. So the study was done with excellent neonatal intensive care plus surfactant. Everyone in this study had not just a reasonable, but a likely prospect of being better off. That is, even if you're in the placebo group, your chances for survival were going in, thought to be higher, because you were getting Cadillac neonatal intensive care, which you otherwise would not have gotten. No one would be worse off as a result of being in the study, unless surfactant turned out to be risky, but that's true of all studies, and there were high consent standards. There would be infrastructure benefits for the country. There might not be surfactant for Bolivia, but there would be now a functioning ICU. There would be physicians trained in this. There would be a transportation system. There would be new jobs. It would put Bolivia in a position to do other studies in neonatology from which they might reap further benefits, studies that might be of greater use to the citizens of Bolivia. So there were indirect benefits. One way to think about this is to compare it to a more common phenomenon in this era of globalization. Namely, what if Toyota had proposed to build a factory in Bolivia and assume the following, that this factory would create many jobs, maybe 1,000 new jobs. There would be generous wages and benefits far above what would have been available to any Bolivian heretofore. There'd be safe working conditions. There'd be an increase in employment and expanded infrastructure, roads, restaurants, healthcare for the employees of the factory. Assume no one in Bolivia would get a Toyota other than the prime minister and his cronies. And assume that the factory closed after 2 years. Once that model of the Toyota had run its course, Toyota said, we're going elsewhere to build factories elsewhere for different reasons. Maybe we can do it more cheaply elsewhere. So here you have an intervention in a country that produces some short-term benefits to those people working in the factory, but no benefits to the people of Bolivia other than this development in some infrastructure. Many citizens would be better off during the life of this factory. No one would be worse off. There could conceivably be an accident in the factory, but they were willing to take that. So is this wrongful exploitation, or is this a good opportunity for at least some Bolivians? And if you're the prime minister of Bolivia, do you say no to this kind of exploitation, or is this something you seek out to at least one factory at a time, try to improve the well-being of your citizens? And more importantly, is this different? If you're okay with the Toyota factory but not with the surfactant study, are these good? Is this a fair analogy, or is the Toyota story different from the surfactant story in a morally important way? How might it be different? Well, some people might say that physicians have obligations to patients that car manufacturers do not have. First of all, the sponsors of the surfactant study were not physicians. They might have been had MD degrees, but probably not. The CEOs of these companies are often not MDs. But even if they do, they're not acting as physicians when they do studies. They're acting as researchers and as Steve Joffe, who you'll hear from later, has written eloquently with Frank Miller and others. A researcher is not a physician, and a researcher's obligations are different from those of a physician. The company sponsoring the surfactant trial had no clear duty to fix the healthcare problems of Bolivia. It's not clear why they should be responsible for solving Bolivia's problems. They do have clear duties to their shareholders to make money. They have duties to the subjects in the study, the ones outlined by Emmanuel and others, which were fulfilled. They were completely adherent to the widely accepted principles of ethically responsible research. Well, the claim is still in the air that exploitation is wrong, that taking advantage of Bolivians to help Americans or other people in Western society is wrong, and that undue inducements are wrong, that offering this ICU is an inducement that turned the heads of these Bolivian parents to something. It was an offer they couldn't refuse, and that this kind of undue inducement is wrong. I just want to say a few words about these shibboleths, that exploitation is wrong and that undue inducements are wrong. And we just have a few minutes left, so I will just make these points briefly. That is, the claim was that the Toyota factory was not an undue inducement because you could decide or not decide to work in the Toyota factory, but if you're the parent of a sick preemie or if you're in premature labor, you can't decide not to go to an ICU. It's an offer you sort of can't refuse. Well, as Alan Wertheimer has written most eloquently, exploitation is one of these shibboleths that really requires re-examination. Exploitation is not implicitly wrong. Exploitation is ubiquitous, widely accepted, and appropriately so in all societies. Physicians exploit the fear and suffering of their patients. I'm a pediatrician. You bring your child to me with a fever and a headache. You're terrified that he or she may have meningitis. I exploit that fear by doing a good history and a physical and making appropriate care. I make money, not a lot of money, but more money than I actually ever dreamed of. And there's nothing wrong with me exploiting your fear in that way if I do it in a way that's otherwise ethically responsible. I do a good history, a good physical, I'm honest with you, and so on. Cancer researchers are even worse. They take patients who are dying, who are terminally ill, and exploit this horrendous fear of not just death but suffering to recruit them into studies which will promote the careers of the cancer researcher, get him or her money, promotion, trips like places like Seattle, and advance his or her career. There's nothing wrong with that if he or she does that in an ethically responsible way, follows the rules. In fact, we want people in academic centers and elsewhere to exploit suffering cancer patients to advance knowledge about cancer. All blue-collar work involves exploitation. The person who owns a coal mine in an area of wide unemployment, such as Appalachia, is exploiting the poverty and the suffering of people in Appalachia by inviting them to work in a hazardous place for relatively poor wages. We require that the mine have at least have some standards for safety, but we don't say it's wrong to open a mine in such a place if it's run by acceptable standards. So the issue is not whether anybody's exploiting anybody. The issue is whether this is wrongful or unfair exploitation, whether the employment has a fair wage or not, or other benefits. In fact, limiting payments for research subjects or workers is what is really exploitative or wrongfully exploitative than high payment. That is, we have it exactly backwards. Elsewhere in life, what are called, let me just say a couple words about undue inducements and then we'll close. So Zeke Emanuel, again, has referred to this concept as nonsense on stilts. That is, if by an undue inducement we mean something that would lead a person to do something that he or she otherwise would not do. I'm not going to work in that coal mine for nothing, but you give me money, then I'll work in that coal mine. To say that this is an undue inducement because it leads somebody to do something that he otherwise would not do is nonsense on stilts. The purpose of an inducement is to change behavior. That's what an inducement is. So if it's wrong to offer somebody something that will change their behavior, then all inducements are wrong and all pay is wrong. We shouldn't pay anybody to do anything because it leads them to do something that they otherwise would not do, whether it's a coal mine or a construction job or to be a research subject. What's problematic is when the inducement is not proportional to the risk. That is, minors getting low wages is what's more problematic than high wages. The moral problem is not if you offer him $1 million and he says, everybody wants to work in that mine. The problem is if you offer him $8 an hour, him or her, then you have something that is morally problematic. In the military, it's called combat pay. They get it, that if you're asking a soldier to expose himself or herself to higher than normal risk, they should get greater reward, not less. And the view of many IRBs have had this backwards for decades by buying into this shibboleth that undue inducements are wrong. That is, things that lead people to join a study which they otherwise would not join but for the money. If we think it's wrong to give coal miners low pay or combat soldiers, then why shouldn't research subjects in risky studies be getting more money, not less? And I'm proud to say at our IRB, we broke records for tolerance for high pay. We had one clinical trial, a non-therapeutic clinical trial, in which subjects got $13,000 for joining a very uncomfortable and slightly risky trial, one that we thought the risks were at least within the range of acceptability. So the problem in Bolivia with surfaxin maybe was that people weren't getting paid enough to be in the trial, but they were getting a tremendous benefit. That is, everybody in the trial, including the control group, was getting a huge benefit, which was first-rate intensive care with at least a very good likelihood of being better off than they otherwise would have been. In closing, just because everyone agrees with a statement doesn't mean it's true. And the 5 shibboleths that I put on the screen at the beginning are statements that, if not everybody, at least an overwhelming majority of people in the world and in bioethics seem to agree with. Research ethics, particularly international research ethics, has been burdened with these shibboleths, repeated in numerous guidelines, codes, and articles, distracting attention from critical thinking. Unlike the shibboleth in the days of the Ephraimites and the Gileadites, where saying the word didn't cause any harm, pronouncing shibboleth correctly there got you to cross the river and get safely to where you wanted to go. In the modern era, these shibboleths do cause tremendous harm, because by repeating these things over and over again, it makes it very difficult to do studies that are in the great interest of people in the developing world and elsewhere. The Lurie, Wolf, Angel shibboleth, that if it's wrong here, it's wrong there, had it prevailed, would have prevented the saving of what has turned out to be millions of lives with a very safe and reasonably affordable intervention. So reciting these shibboleths in the modern era, unlike in the ancient Middle East, is often to the detriment of many people. Using the standards of ethically responsible research does not imply the same response to a study in different settings. Good ethics starts with good facts, and if we stick to the standards outlined by Emmanuel and others, we'll be on the right path. For those of you for whom this is very upsetting, you can only agree with the person who said, if all the ethicists in the world relate end to end, it would be a good thing. Thank you very much.
Thank you, Norm. That was a terrific way to start our conference. It's my privilege to introduce our next speaker, Lainey Ross, who is the Carolyn Matthew Bucksbaum Professor of Clinical Medical Ethics at the University of Chicago. She is the Associate Director of the Center for Medical Ethics at the University of Chicago. She, like Norm, has written on a wide range of areas in pediatrics and human subjects research. She has been to our conference less than Norm because one year she had to Skype in, so she only gets half credit for that. It was actually, but she did and Lainey also is a really a long-standing not only contribute to our conference, but also to the field of bioethics. She recently got a fellowship from the Guggenheim Foundation for a book with a fascinating title, From Pea Pods to Whole Genomes, Incidental Findings and Unintended Consequences in the Post-Mendelian World. It's my pleasure to introduce Lainey. Thank you.
So thank you very much. I'm always happy to be number 2 to Norm, although it is a little humbling to have to follow him. So you'll notice the first thing is that I changed the title. After I heard what Norm was talking about, I decided we had to make this sort of a little bit more controversial. And so I'm going to talk about the role of ethics and ethicists in international case studies, and I'm going to argue for a reflective equilibrium approach, and I'll explain that as I go through it. So I want to examine 3 case studies, which means I have to talk 33% faster than Norm did. But anyway, so the first question is, how many people have ever heard of the neonatal sepsis research in Gadchiroli, India? Okay, so I see very few hands. How many know about the Haemophilus influenza B research that was done in the Gambia in the late 90s? More hands. Okay, and the last one is, how many know about the Bucharest Early Intervention Project in Romania? Okay, so these are not well known to people who are interested in bioethics, and that's going to be an important point as we go through these 3 cases. I want to look at 3 ethical concerns. I want to look at the standard of care debate, which Norm has beautifully covered. I want to look at the equipoise debate, which relates to the standard of care debate. And I want to look at data safety monitoring committees as well as stopping rules. And I want to ask 3 questions. Could the study be done in the US, and does it matter? What role did ethicists play in the study's evaluation? And what lessons can we learn? So let me start then with the standard of care debate, just go through the 3 issues that we're going to be dealing with from the ethics perspective. As Norm pointed out, the Declaration of Helsinki is very clear that in any medical study, every patient must be assured of the best proven diagnostic and therapeutic methods. There is a clarification in Article 28.9, which allows placebos, but in very limited circumstances, and would not fit for either the cases that Norm used, nor in the cases that I'll be presenting today. The CIOMS, actually, which is another set of human subjects protection regulations internationally, actually does allow for more wiggle room. It says another reason that may be advanced for proposing a placebo-controlled trial is that using an established effective intervention as the control would not produce scientifically reliable data relevant to the country in which the trial is to be conducted. And Norm showed that very beautifully in the HIV studies. They also then wrote, one reason could be that the disease or condition manifests itself differently in different populations, or other uncontrolled factors such as nutrition, malaria, and things of that sort, as we find in the HIV trials. So that's one issue. The second issue that I want to be thinking about is equipoise. Charles Fried brought this up in the concept of individual equipoise, which means that any individual clinician researcher is uncertain as to which arm is going to be better, A or B. And Benjamin Friedman made that more general, saying it doesn't matter if any particular clinician researcher has equipoise. What really matters is that the community of clinician researchers have equipoise, so that at least, whatever percentage, let's say 1/3 of the room thinks arm A and 2/3 think arm B, then it's still ethical to enroll your patient because clearly there's clinical equipoise. In contrast, Jason Karlowitz and John Lantos actually wanted to argue for a concept of community equipoise, which argues that you have to have uncertainty within both the medical community and the public. Bob Beach has sort of shown why that's probably unrealistic. But then we have Frank Miller and Steve Jaffe, who argue that equipoise is not always even necessary for clinical trials. And in a sense, you're using some of the same positions that we saw in the CIOMS, that even if there's not equipoise, overall it may be in particular circumstances that you don't need equipoise. The last concept, so the 3 are going to be standard of care debate, equipoise, and the 3rd is going to be about data safety monitoring committees as well as stopping rules. So there's an agreement that clinical trials need to be monitored to ensure patient safety, and that at some point that the need for formal procedures to cover early stopping for safety reasons must be encouraged. And so when should you stop a trial? When conclusive evidence of harm has been established, or when the potential for harm exceeds an acceptable limit of comfort for an oversight body. So as we saw with the HIV both the 076 trial as well as the short course versus placebo, many of those studies were stopped early because it was shown that the treatment arm was so much more effective than the control arm. But when should you have caution and have to think about and possibly, but not necessarily, stop a trial? When early alarms warn of possible harms, but the data are too preliminary. So one of the concerns, if you stop a study too early because you're seeing a trend, it may be that you're just seeing a trend, and that if you continued to study further, that trend would be disproven. So you don't want to stop too early, you don't want to wait too long, because then you're doing harm. You got to be in the Goldilocks position of just right. But one question that we're going to ask in these three cases, at least in the third case, is there ever a reason to continue once equipoise has been disturbed? So to go beyond, even though you already know that arm A is better than arm B. So let me now look at the three cases. This first case is known for the area in which it took place, in Gadchiroli, Maharashtra, and I apologize, I'm sure I'm pronouncing this awfully, India, and it was based on a home-based neonatal care project that was organized by Dr. Bang and his wife, and they had created an organization in the late 1980s called SEARCH, or the Society for Education, Action, and Research in Community Health, which was an NGO set up involving actually 100 villages, and in that area they have trained and supported male village health workers as well as traditional birth attendants, as well as doing some treatment in the clinical management of pneumonia in children. They've actually offered other health resources and reproductive health, and they've actually been an incredible resource to this area where they both practice and do research. And in 1993, SEARCH found that the local neonatal mortality rate for the villages it served was around 60 per 1,000, and that, just to give you an idea, compares to 5 in 1,000 in the US. They found that 95% of deliveries occurred in the home despite the relative proximity of public health care facilities, and that household surveys found that over half of newborns needed some kind of help, but that less than 3% received professional medical attention. Now, in India, in 1993, it was clear the guidelines for a sick neonate was hospitalize immediately. If the child looks ill, IV for fluids as well as antibiotic. Dr. Bang, who was working in this area, said the standard of care meant let them die because the parents didn't bring the children to the hospital. And just to give you an idea, in 2009, still over a quarter of the annual global newborn deaths, over 1 million per year, occur in India. And despite some improvement, their neonatal mortality rate is still at 43 to 1,000. So in 1993, SEARCH decided they were going to do this ongoing child health program. They had these two areas. They had an active arm approach where they had been conducting research in the area, and there were 47 control villages where they were actually collecting epidemiological research, but they actually didn't put a lot of resources into those 43. This was just picked because of access. All the 43 weren't sort of left out to dry. They actually had government health care services, but they offered some additional services in these 53 action villages. And one of the things to note about these 100 villages is they actually were very similar geographically, economically, and socially. And so what the SEARCH group did was they developed this home-based neonatal care, so that if a child was born who looked sick, that they would train female healthcare workers who would then go to the house. First line was to tell them you should go to the hospital. When the parents refused, then they were going to offer them some home-based sepsis treatment with oral antibiotics as well as 1 dose of an IM antibiotic, which was known to be substandard. So that was going to be the active control arm, right? Everybody knew the standard of care in India was hospitalized and IV antibiotics. Interestingly, of the 53 villages, which they called their action area, they got community consent for this project. They trained women who had at least 5 to 10 years of schooling, and they were only able to do that in 39 of the 53 villages because in 14 villages, the population was either too small or there was no appropriate woman to train to be a female healthcare worker, meaning that none of the women in the community had at least 5 years of schooling. And then in these areas, how they did the research was they spent 5 years. In the first 2 years, they collect epidemiological research from both the active arm and the control arm area, and then they started training. So the first thing was they had to get the the families to actually accept having a female healthcare worker come in. And then in the second year, they started getting more involved. And then finally, in the third year, they even went beyond just doing this sepsis treatment. They were also doing education of pregnant women and grandmothers about breastfeeding and about other minor health care issues that they should be taken care of at home. So even their intervention still left these families at substandard health care. And they made no referral apart from what was already available at government hospitals, although every family was told in the consent process and in the community consent process that they were free to seek care from other sources. In the control cluster, SEARCH did not provide any training. In fact, they didn't observe any home births. All they did was collect, in a sense, birth and death records from the community. But it's not exactly a placebo arm, as Bang has subsequently argued, because in some ways he could say that prior to collecting the data, there were numerous health interventions given at the village level that were being done by the government healthcare workers. It's just these additional resources were only being offered in their active arm. But they got no consent for this because all they were collecting were epidemiological data, how many children were born this week, how many children died. So the study design was what we call a cluster non-randomized. He picked the arms where he already had his resources and staff in place. The argument that he gave was that the clusters could not randomize individuals, as it would have placed the female health workers in an ethically problematic situation. They were of low health literacy, trained to actually provide resources when the child met the criteria they had been taught, and to ask them to sometimes withhold it they didn't feel that they would do. They also did non-randomized because they realized that if they did two communities and the women heard about what was going on, that women would just move from one community to the other in order to get these additional resources. So they selected them en bloc. And yet, as they said, while there were biases, these were all, in a sense, at least at the introductory phase, that all of these communities looked very similar. So one question that everyone has to ask is, was it ethical not to offer any interventions to the control units, given that a known treatment existed? Well, remember what the known treatment is. The known treatment is go to the hospital and get IV antibiotics. And that was actually offered to everyone. The fact that less than 3% of parents did it, again, like Norm has said, really wasn't the responsibility of the researchers. But remember then what the trial is offering is substandard. And so what actually happened, they published their data in 1999, and they demonstrated with their substandard treatment that they got a 62% decline in neonatal mortality rate in rural communities using this home-based neonatal care approach. They published it in The Lancet. In 2001, they gave some more data in a journal called Indian Pediatrics, where they described the burdens of morbidity among neonates in these communities. And in 2005, they actually got an entire supplement of the Journal of Perinatology, where they went through this study in really elaborate detail. So that's where we are in 2005. But you should know, from an ethics perspective, the only mention of this study was in 2002, that there was a discussion of ethical research in the international community. And Dr. Buddha, who is the chair of pediatrics and child health in Pakistan, actually wrote in support of this study, thinking that it was very much an ethical research. But in 2007, Ethical Issues in the International Biomedical Research, a casebook, was published by many of the NIH ethicists, Lavery, Grady, Wall, and Emanuel. And in it, they included a description of the study that I just gave you. They asked Dr. Buddha, who defended the study, and then they had Marcia Angel, who we've already heard her opinion about the HIV studies. She also was asked, and she was very seriously criticizing this study. Interestingly, the book gets reviewed in The Lancet, the same journal where the original study was published, where they criticized the use of this case without fully understanding the context, and sort of saying, ethicists, if you're going to use studies, you really need to understand the facts. A debate then ensued, because that was the only way that people even in India even knew that this study was being criticized. And between 2009 and 2011, a number of articles discussing the ethics were published in the journal called the Indian Journal of Medical Ethics. Nothing ever again appears in the American literature or the British literature. So what were Angel's criticisms? She criticized the science because it was non-randomized. She criticized the need for the study because she said, quote, "We know the standard of care." She criticized the study design, withholding effective treatment from the control group. she suggested a study that would have compared outcomes from female health workers and more highly trained medical personnel. Again, a resource issue that was obviously not realizable in this community. And then she accused the researchers of self-interest. She said there is knee-jerk tendency to respond to the lack of medical services with clinical trials. Partly this is a matter of researchers responding by doing what they know how and are paid to do. So really accusing them of self-interest and conflict of interest, and she accused the researchers of exploiting the poor. So Angel's criticisms, first of all, ignores the fact this study was approved by National Ethical Review process of the Indian Academy of Pediatrics, was locally developed. This isn't like the Americans were coming in and imposing this research. It was developed by Indians for Indians. The trial was actually part of a national priority setting mechanism. The protocol was developed with full community consent and participation. It did fail to provide acknowledged standard of care, but it also realized that that was not feasible and not sustainable. And it did not have government commitment to implement. So one of the interesting things was that Angel also said, well, you know, maybe it would have made sense to do this type of research if you knew the government was then going to implement all of this. So Dr. Bang, and sort of denying the fact that we did see this huge decrease in mortality, and that despite the fact that the study ended, that Bang was able to get resources in order to maintain the female health workers and this whole process for many years after the study had been completed. And in fact, as Bang wrote, he and his wife, we have strived to influence policy at state and national levels to incorporate home-based newborn care in rural areas. We have done this by including publications in medical journals, by using the media, by judicial activism and political lobbying. In fact, they had the Mumbai High Court initiated public interest litigation, citing our 13-site study report on child mortality. This was a court case that's saying that the Indian government wasn't doing enough to protect its own children, and the High Court ordered the government to introduce the Gachiroli model of newborn and child care in 5 districts that were even worse off than the ones that Dr. Bang had been working in. And to the criticism of the fact that he had conflict of interest, he likes to point out he continues to live and strive in Gachiroli, trying to help the community that he serves. So here was one of those cases where the ethicist sort of looked over. Oh, wait, my references were left out. But in your handout, you'll see that there are references, and what's really interesting about this study is that there's, well, you can take a look at some of the essays which look at it, but it's really, in my mind, a sad commentary that we're making comments without having all the medical facts. And I think we're going to see that in a lot of our international studies, that it's easy to criticize until you really go down and see what they're doing. So no, nobody got standard of care, and yet we did get a 2/3 decrease in mortality. In the next study, we have placebo-controlled trials of the Hib vaccine for the prevention of pneumonia in the Gambia. Just want to thank Skip Nelson for pointing this case to me. The background is that they actually had done a surveillance study of Hib back in August 85 to 87, and they found that Hib meningitis was more frequent in the Gambia than in industrialized countries, and it also affected younger children, which, if you were going to implement a vaccine, would be important to know both when you need to be vaccinating. And they had actually a case fatality rate in the Gambia of about 30%. Hib pneumonia was also much more common in the Gambia, but it was difficult to diagnose because it's very insensitive to blood cultures, and the way they were able to diagnose it during their surveillance study was pretty aggressively to actually do lung biopsies. And at that time, they thought that Hib caused about 7% of pneumonia. As we'll see throughout the study, it probably caused about 25% of the serious pneumonia leading to hospitalization in the Gambia. One of the interesting things that they learned from this background study was that the epidemiology of Hib disease is different, that it's mainly pneumonia in the developing world compared to meningitis here in the US. But one of the things is that unlike meningitis, Hib pneumonia can result from direct spread, so it was actually not known how effective the Hib vaccine would be in preventing pneumonia. It was really, in a sense, when the studies were done here in the US and in the Western world, really the focus was, can we prevent meningitis? So, since 1989, as Hib vaccine has been available and known to be efficacious in Europe and North America for the prevention of meningitis. And as I mentioned, it not known if it would be effective against pneumonia. So, in the Gambia, they decided to start placebo-controlled trials of Hib vaccine in 1993. And so again, the question comes, well, we already have a standard of care. How can we be doing it? And the answer was, in part, that they were going to argue the ethics of it, that one, we didn't know how effective it would be in different populations, and number two, again, because you were going to have to change the timing of the dosage because of when the kids got sick. Interestingly, the U.S. government, because it was funding the study, did get involved and was very adamant about the consent issues. And I'm really going to leave that aside, although in the references for this, you'll see that they actually did a whole study about the consent issues, which is actually quite interesting. But I'm going to skip that for the purposes of this talk. They also, though, had a data safety monitoring committee. There were two international bodies who oversaw the trial. One was a 4-person steering committee with 2 international experts, representatives of the funding agency and a representative of the Gambian government. And then they also had a 2-person safety monitoring group. And so here was their study. 42,800 Gambian infants were either, when they presented for their first DTP, yes, not DTaP, not acellular pertussis, too expensive, for their first DTP vaccine at 20 health centers in a certain region, they were either randomized to get DTP or DTP Hib. The vaccine was meant to be given at 2, 3, and 4 months, and what they were going to collect were cases of meningitis, pneumonia, and other invasive Hib diseases were going to be investigated at 23 hospitals, and pneumonia was going to be investigated at least at 2 hospitals where they had X-ray facilities. And the protocol said it was supposed to be given, as I said, at 8, 12, and 16 weeks. In practice, actually, the vaccine was more likely given at 11, 18, and 24 weeks, and 17% of the children failed to receive all 3 doses, which also tells us one thing, that when we think about how research is done in the international world, you know, it's a lot easier when everybody has cell phones and cars to be able to get to clinic appointments on exactly the right, within a 3-day window. Wasn't going to happen here as the study was being done. But as the study was going, they got interim data in February 1995. They've had 39 episodes of culture-proven invasive H. flu disease, 12 cases in children who had received 3 doses of study drug, 6 Hib pneumonia in children who had received 2 or 3 doses of study drug, not knowing because they had not unblinded the study. So they actually had one DSMC member look at the data for the H. flu pneumonia, because that's what they were most interested in. And they found that 5 of the cases were in the control arm, 1 in the study arm. And he told the team, we don't have adequate power regarding pneumonia. And so even though we had adequate proof in the meningitis arm, all the children who got meningitis were in the no Hib, in the placebo arm. So despite the fact that they had plenty of data to show that the H. flu vaccine prevented meningitis, they said our goal is to prove that it prevents pneumonia. And the reason they needed to prove pneumonia was they said the Gambian government is not interested in funding this unless we can reduce the amount of pneumonia. So they recommended to continue the study. Again, so here's a real interesting issue about stopping. Should they have stopped when they reached a point where we would have stopped here in the United States? They continued, and when they actually finished in March of 1996, they actually now had 50 cases of invasive pneumonia, Hib disease, 17 pneumonia, 28 meningitis. Remember, they can only diagnose the pneumonia in the 2 hospitals with X-rays because of the insensitivity of the blood cultures. They also found 5 other Hib disease cases. Interestingly, the efficacy for those who had received 2 or 3 doses was actually 100%. Remember when I showed the slide, I said that 5 were in the vaccine arm and 1 were in the placebo arm and 1 was in the vaccine arm. It turned out that after they kept studying the result, it turned out that the 1 person who had gotten the Hib vaccine did have Hib, but a different form than was actually protected by the vaccine, and so he was excluded from analysis after the code was broken. Hib was also to be found much more common than the original data suggested. It was much closer to 20% versus 7%. So given that the vaccine was effective and given how important they were able to prove that the Hib disease was in the community, I'm going to skip this because that just goes how important it was. This was their finding, was of the finding of a high degree of efficacy for the prevention of meningitis and pneumonia caused by Hib in African infants was expected by many. However, the significant impact on overall rates of severe pneumonia and the demonstration of the true contribution to Hib to the vaccine trial proved to be a very powerful instrument for the estimation of disease burden attributable to the pathogen. And what that led to was how now were we going to move from having this data to getting the vaccine available. Before I get to answering that question, I just want to say, so the two ethical questions that the case raised was it ethical to perform a placebo-controlled trial of HIV when it was already standard of care in developed countries, and was it ethical to delay stopping the trial to determine the efficacy of the vaccine against pneumonia? And so at the time of the study, the HIV was known to be efficacious in Europe and North America, but it's actually interesting that first we know that the epidemiology of HIV was different in the Gambia, that they had much higher pneumonias than we do, and it wasn't clear whether the vaccine would be effective against pneumonia. But it also should be pointed out that studies here in the U.S. found that the HIV vaccine was not efficacious in Alaskan natives. And therefore, because of possibly genetic reasons, the feeling was, how do we know it's actually even going to be at all effective in the Gambian population? And so that was another reason they justified doing a placebo, despite the fact it was known to be effective here. The researchers also argued that it was ethical because otherwise Gambia wasn't going to pay for it. And the government really wanted to know that it was effective against pneumonia. The stopping rules is interesting. When you look at all the literature of stopping rules, it's always about when should you stop early, and don't stop too early because you might be seeing a trend that's actually a false trend. And nothing is written about stopping late. And why not? Because the answer is it would mean that equipoise had already been disturbed, right? We knew this vaccine was effective for meningitis. It was effective for meningitis in the US. It was effective for meningitis in the Gambia. And so we would say, our ethics rules say, once you know that equipoise has been disturbed, stop the study. But they felt that had they stopped the study, they would have never gotten the support that they needed in order to be able to roll this out throughout the whole country in a resource-limited country. And since the completion of the trial, the HIV vaccine is now recommended for use in developing countries by the World Health Organization, although they didn't have, and that's a criticism that was made by ethicists, was that they did not have a promise that the vaccine would be made accessible to Gambia at the time. They had actually gone through the same experience in the Gambia for hepatitis B in a study in the mid-1980s, and were able to actually implement using hepatitis B because the price of the vaccine was much cheaper by the end of the study, although there were some gaps. And here, after a 17-month delay, they were able to get both help from a donation from industry as well as from other organizations in order to be able to get funding to have the HIV vaccine. And so the Gambia was the first of the developing world to get the HIV vaccine. It's now spread through much of Africa, but still there are parts that don't have it. I point out the references only to note that if you look, you'll see that the ethics has actually been mostly studied by the researchers themselves. The second article by Mulholland actually was an examination of all the ethical issues in the study. You'll also see the last study was by Leach et al. Because the U.S. was so adamant about the consent process in this study, they decided to do a supplemental study about the consent process, which it's an interesting read, suggests that there was lots of misunderstandings, and yet some of those same misunderstandings about randomization and placebos we find in the U.S. studies as well. The third case that I want to look at is the Bucharest Early Intervention Project, which is known as BEEP. It's the Romanian, also known as the Romanian Orphan Study, and this study was brought to my attention by a Hastings Center blog post by Joe Finns in October 2013. So just a historical overview. In 1966, when Ceausescu banned birth control and abortion, leaving many parents feeling the need to leave their children in state institutions, and so 23 years later, there were 170,000 children living in these facilities. Even after the dictator was overthrown, children were still being institutionalized through 2005. There had been some small descriptive studies of institutionalization in the West between 1940s and 1960s, which showed that institutionalized children did poorly. Actually, some of those studies impacted the way we organized and raised children in institutions here in the U.S. So there was concern then with this study that the children who were removed from institutions to foster care or adoption were less impaired, and so they wanted to do a randomized trial to look at whether children who were first placed in institutions, some of whom remained in the institutions versus those who went to foster care, who did better. And the U.S. researchers, 3 of them, approached Romanian officials to study the adverse impact of early life in an orphanage. The project was launched in 2000, and the inclusion criteria were that infants abandoned to institutions, the infants had to be abandoned in the first weeks of life, and then they were enrolled if they were between 5 months to 31 months, having spent at least half of their life in an institution. They had to be evaluated to be free of neurological, genetic, and other birth defects, so that as they looked at development, they could argue that this was whether institutions versus foster care were better. So the randomization trial was to leave half the children in the orphanage and place half into foster care. They actually had a third arm. They took typically developing children who live with their families, never institutionalized. They did that in part to prove that all of the surveys and all the instruments that they were using got equivalent results in Romania as they did in the U.S. children. And that was actually quite true, that all the children who were typically developing, who were living with biological families, did as well as U.S. children on all the instruments they used. So they recruited 136 infants. Average age was 22 months. They studied them at 30 months, 40, and 52 months. They showed that the average IQ of the institutionalized children was lower. They found that the best results occurred if you placed children in foster care before 2 years of age. And as soon as these results became available, the findings were communicated to the Romanian government, and the study continued. In their second assessment done at 42 months, they found that the children in foster care displayed improvements in making emotional attachments. Again, looking at subsets, the children placed before 2 years of age did better than the older children. The research team stated clearly that they did not interfere with government decisions about changes in placement when children were either adopted, returned to biological parents, or later placed in government-sponsored foster care, which they point out didn't exist at the start of their study. And in fact, at 42-month assessment, less than half of the institutionalized children remained in the institutions. And so they collected their data then as an intention to treat, intending for these kids to remain in institutions. But there was a sea change going on even as the study was starting that people were questioning. And one of the things we have to remember is when we're talking about Romanian institutions, we're not just talking about orphanages. We're talking about, orphanages that were described by Dickens. I mean, there was a huge media when Ceausescu gets deposed and the U.S. media goes into some of these orphanages. The conditions were absolutely horrific. And so in a sense, one of the things we have to be thinking about is horrific orphanages do worse than Cadillac foster cares. And why do I call them Cadillac foster care? Because not only were these children placed into foster homes, but there was a social worker who worked with the foster care families, educating them about how to care for these children, offering them support groups, and things of that sort. And in fact, we'll look at the data as the study starts going away and as these children start going into Romanian foster care, the difference between those children who were left in the institutions for longer and the children who are in foster care becomes much smaller. So again, by 8 years, in fact, only half the children originally randomized to foster care was still in the BEEP Cadillac foster care. Many of them had already been moved to the Romanian foster care system. And as I mentioned, the data showed that the gains that they had compared to those children who were institutionalized were much smaller as they moved away from these Cadillac programs into what would now be offered in Romania. And more data keeps showing that the kids who were removed earlier did better. We got that. So here are the 7 questions that have to be asked about the study. Was the study design ethical? Did the study have social value? Or were the results already known as it was accused? Was there equipoise between the 2 arms of the study? Was there adequate ethical and regulatory protections in place? Was there a data safety monitoring committee? Right, at 2 years, we already knew that the children who had been removed from foster care were doing better than those in the orphanages, but there were no stopping rules as sort of the end point there, and so no changes were specifically made. Then we have to look at the question of what are the post-study obligations and what role did ethics play in the study. So first is the question of the ethics of methodology. Was it ethical to randomize children to remain in the Romanian institutions? And could the study be done in the U.S.? And the answer is clearly no. It was neither ethical and no, it could not be done in the U.S. The Romanian institutions, which, as I said, were played out in the media for the U.S. in 1993, showed how horrible these facilities were. The researchers said, well, we don't want to fix the institutions because what we want to prove is that foster care is better than institutions. Well, but they're comparing apples and oranges because they're comparing an over-the-top foster care to one of the horrendous scenarios of Romanian orphanages. And so one question, was it ethical to do in Romania? And they wanted to argue yes, because Romanians were sort of divided about which would be better. But again, I don't think any Romanian was divided about whether an orphanage from Charles Dickens or an orphanage that could have been improved. I think the concern here was that we were creating a straw man by comparing anything to these horrific conditions that we allow these children to remain in. There were two alternate study designs that could have easily been done. The first was enhanced institutional care, bring them up to the standard that we already learned in the 40s through 60s from the data we collected from American orphanages of the need for children to be able to create, in a sense, a primary caregiver and to have emotional attachment and things of that sort. And so then we would have had, what does a good orphanage look like versus a good foster care system? And that's probably a much more important question, particularly, that's a much more important question. The other way of designing it was, since they were enrolling kids who had been there, they could have compared children who had been left in the orphanage, who had only been in there up to under a year of age, and those who had actually remained in the orphanage. If you remember, they were enrolling kids between 6 and 21 months of age. And what we know is that the younger you remove children from orphanages, the better they do. And so we could have used, in a sense, not left anybody in the horrible scenario, the horrible orphanages in which they were living. We could have just looked at who does better, and children who spent the first year of life in an orphanage versus those who spent much shorter periods of time. And we would have been able to prove that foster care was much better than if they were moved earlier. But that wasn't the study that was done, and the American researchers were defending their research. And so one of the big questions is, didn't we already know the results? We knew that children who lived in horrible institutional care did poorly. And Frank Miller, an ethicist from the NIH, actually says, critics might contend, since the answer to the research question was already known based on prior observational research, that there's no social value in conducting the research. And he disagreed. He said the research question is not asking whether foster care is superior to institutionalized care, but rather whether young children initially placed within institutions in Romania had better outcomes after transfer to foster care. And I would just want to tinker with that statement and say, and at what age should they have been removed? And if you go at what age did they benefit, then you could have had the second design study and didn't need to leave anybody in the institutions. The next question was, Miller said, even if some experts claim to know based on observational evidence or experience that a particular intervention is effective in producing a given outcome or is better than an alternative, positive results from a well-designed randomized trial may be necessary to persuade policymakers to change standard practice. So his point here was, even if it wasn't ethical to do it in the US, if this was the only way to convince the Romanian government that their orphanages were awful, then maybe that makes this study ethical. And again, I would point out, as Joe Finns did in his essay in the Hastings Center, those changes were already coming into effect at the time the study was being done. And so in a sense, we were answering a question that really was already known. So that raises the question of, were we in equipoise, right? So there were early data that showed that foster care was better than institutions. It's the data that these three American researchers showed. But they actually argued that none of the studies were done in randomized fashion, so they need to do a randomized study, otherwise we couldn't prove it to the Romanian government. And Xenia and colleagues argued, but the Romanians were divided about which was better, foster care or orphanages. And again, I would contest that while there might have been a question which is better, and it's a reasonable question to ask whether orphanages are better than foster care, clearly the worst orphanages are going to be worse than good or, in a sense, Cadillac-type foster care. So I don't think they were actually asking the question that really needed to be answered in the first place. The next issue was, did it have ethics and regulatory oversight? Interestingly, when we think about international research, we want research to be approved both in the U.S., if it's funded by the U.S. as well as in the country where it's being done. They didn't have any Romanian IRBs at the time. They did get approval by the local Commission on Child Protection in Bucharest as well as by the Ministry of Health. The Romanian partners required that the study be conducted within the principles outlined by the UN Convention for the Rights of the Child, which is sort of a smack on our face since we're one of 3 countries that have not signed the Declaration of the Convention for the Rights of the Child. It's United States, Somalia, and South Sudan. We got permission from biological parents to place their children in foster care, and this does go into the fact that there was some degree of equipoise within the community in Romania about which would be better, placing your child in foster care or leaving them in an institution. There was no DSMB and no stopping rule, so even after they found, after their first data collection, that children who had been removed from the orphanages did much better, they didn't, in a sense, stop the trial and move all the children into foster care. They decided they would just keep collecting data. So what about post-trial obligations and benefits? After the early data showed that children do better, what obligations? There were no stopping rules, and so nothing was really done. Now, to the researchers' credit, they point out that no child that they put into foster care was ever placed back into an orphanage. Some of them were placed into state-run Romanian foster care, which, as I pointed out, really didn't do well, or not nearly as well as those children who were in the BEEP foster care system. The researchers claim that the foster care system was catalyzed by their study, although Joe Fins has pointed out correctly that the changes had begun before even their first data were collected. And again, I'm just going to keep harping on this. I found the study really unethical, but for different reasons than Fins did, because we really didn't have 2 arms that really were addressing the issue for the Romanian government. If the Romanian government really wanted to know, could we maintain foster orphanages, the question is clearly not the orphanages from the Ceausescu era. We really needed to look at what would be high-quality orphanages. And so I put in here 3 pages of timeline so that you can see that although Fins points out like this was his moment, his Reverby moment, that he discovered a problem that nobody had been thinking about, it turns out that with every single publication, an ethicist or somebody was asked to comment on the ethics of this study. And it went on and on over the whole course that the study was being done. After reading this whole debate then, realizing that ethicists had been commenting and were not outraged like Fins was, one of the questions I asked myself was, I went and reviewed the data about abandoned children. And here are some facts that never get published in any of those articles, which, first of all, there are 143 million orphans and millions more abandoned children worldwide. And so the idea that maybe that we can actually create 143 million foster care systems might not be realistic. We have 53,000 children who've just come across the border, as Norm reminded me this morning, and we're talking about whether we're going to be placing them in foster care or orphanages as well. Orphanages are still actually quite common around the world, and their outcomes are often as good, if not better, than foster care. And that's a surprising data. I point out there's an article by Wetton and al., which was done in 2009, and the researchers themselves said, we were surprised to find this, but that what they found was that in communities in which orphanages were designed to create continuity of care and to have children create, in a sense, a primary caregiver, that they actually had quite good results. And then there are some data from Richard McKenzie here in the US, which talks about after the 40s and 50s and the horrific stories about orphanages as we improved our own orphanages here in the United States, how successful some of these orphanages were as well. So this primary assumption that was made that orphanages are always terrible, yeah, when you go to a Dickens-type orphanage in Romania, they are, but maybe we need to look around the world and to see how it could have been done better. So I think that the study, this one was unethical in contrast to the first 2 studies, where I think that despite the fact that we didn't meet standard of care, that we might have failed to act after we hit equipoise, totally legitimate, and I think that we need to be thinking about the fact that we're asking different questions when we do international research ethics. So in summary, the Gacciaroli and Search studies, we've actually, when you think about post-research success, the home-based neonatal care is now standard of care in rural areas, despite the fact that it's actually below the quote national standard of care, which still remains IV antibiotics and hospitalization. The Gambia-Hib study did lead to funding by Gavi, not just for the Gambia, but throughout the developing world. And the Romanian BEEP studies showed that foster care is better than institutions, well, at least Cadillac foster care to bad institutions. But one of their biggest ethical problems with the design was that they failed to minimize harms. They either had to remove all the children and just do it on a time basis, or if they weren't going to remove all the children, they had to improve those institutions, which really were horrific. So one of my final comments is that why has there been so little discussion of these issues, cases in mainstream U.S. ethics circles? And one thought is this notion of called hidden research ethics by Jim Dubois. And he says, how are cases hidden? One, if they're not published in a journal that ethicists read regularly. If they don't include keywords that would get us to actually skim those articles, if we just got a table of contents from many of our journals. And when the authors of the study themselves either do not recognize or do not explicitly discuss the ethical significance of their findings. To the credit of all these international researchers, they were discussing the ethics of it, but then the U.S. researchers came in with a holier-than-thou approach that we have the shibboleths, as Norm presented in the first set of lectures, and therefore condemned all three of these sets of studies. Rather, I think when we think about international research, we need to think about it in a concept of reflective equilibrium, which would be a bidirectional examination of case studies and ethics principles. Are ethics principles and how are they fitting with this ethics case? I think Norm is right that the ethics principles are the same, but some of the differences that we're seeing is we actually have different contexts, but we're also in a sense then asking different questions because of the resource limitations that the researchers really aren't responsible for. And so, thank you very much.
Thank you, Lainey. It was really great to get your very creative perspective on all three of those cases. Before the break, I have a few important announcements. First, the restrooms are both to the left and the right of the auditorium. When you exit, you can find them on either side. There are evaluation forms in your materials. Please complete those and return those at the end of the conference. That's very helpful to us and important for us. The UW bookstore has a booth out in front, and they're available both today and tomorrow. Additionally, there will be a book signing by Eva Kor, our afternoon speaker, both at the afternoon break, before her talk, as well as after the talk. And from having heard her speak before, usually people are lining up, so I would encourage you to try to even go in the first break. Parking validation, if you parked at the Art Institute parking lot, check out our registration desk. We can validate your parking. For CME credit, make sure that you sign in both days. Twitter, hashtag #PedBioethics10, for those of you who are into Twitter. We are running a little late. We will keep our break on time, though. So what we'll do is it's now 10:24 on my watch, and so that means that we will reconvene at, I guess, 15 minutes later, which is 10:39. So we'll see you back then. Is that right? Yeah, that's right. Oh, no, it's a half-hour break. So it's a half-hour break. So it's, no, we're going to go past it. We're going to get an extra 5 minutes. All right. Forget math. See ya.
Why don't we get started again? If everybody can get settled. Welcome back from the break, and hopefully you enjoyed the first part of the morning. My name is Doug Diekema. I work with Ben and the rest of the faculty at the Truman Catt Center. And it's my privilege to be able to moderate this session. Now, for those of you who haven't attended one of our conferences in the last few years, this has become one of the highlights of our conference. What we do is we bring up several of our speakers from the 2 days, and we basically have a conversation. And I'm going to start that off the first 45 minutes, hour or so. I have a number of topics that I would like them to address. My experience in general has been that they are never in full agreement on anything. So we often get some lively debate and some interesting discussion out of that. This is also what we found is an opportunity for us to explore some topics that we didn't have time to put into the agenda, because obviously when you set up a conference like this, there's a lot more to cover than you actually can have the speakers address. When I'm tired or bored of doing what I'm doing, we will open it up to the audience, and we will let you continue the conversation, and that will be a time for you to pose issues you might like the panel to address, or questions. There may be things that have been triggered by the talks this morning or the discussion we have here. So at that point in time, we'll have some microphones in the aisles, and we'll have you all engage the speakers for 30 or 45 minutes. So just Norm and Lainey have already been introduced, and you have the bios of the other 4 in your packets, but just to briefly let you know who we're dealing with here, Alex Capron, who is directly to my left, is a professor at the University of Southern California and occupies the Scott H. Bice Chair in Healthcare Law. Dr. Capron, or Healthcare Law Policy and Ethics at the Gould School of Law, where he teaches public health law and torts. And Dr. Capron has been working in the field of ethics and worked related to research ethics and human rights for a long time. Let's just leave it at that. Steve Jaffe, who is on the other side of Dr. Fost, is the Emanuel and Robert Hart Associate Professor of Medical Ethics and Health Policy at the University of Pennsylvania, Perelman School of Medicine, where he also serves as the Vice Chair of the department and directs the Fellowship in Advanced Biomedical Ethics. And in addition to his work at Penn, Steve also has done quite a bit of policy work, both at the national level and with the Children's Oncology Group, and so brings a lot of sort of real-world policy experience to these discussions. And then next to Steve, we have Nancy Cass, and Nancy is the Phoebe R. Berman Professor of Bioethics and Public Health in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, and she also serves as the Deputy Director for Public Health in the Berman Institute of Bioethics. And Nancy also has done extensive work in the research ethics realm. I've been reading her work and papers for maybe not quite as long a time as Dr. Capron, but nonetheless a long time. And then next to Nancy is Pearl O'Rourke. Pearl is currently the Director of Human Research Affairs at Partners Healthcare Systems in Boston and an Associate Professor of Pediatrics at Harvard Medical School. I still think of Pearl as a peds ICU attending at Seattle Children's Hospital back when it was Children's Hospital and Regional Medical Center, or maybe Children's Orthopedic. I don't remember how long ago you left. But Pearl was a much beloved pediatric ICU physician here in Seattle until she decided to do a health policy fellowship with, I think you ended up doing a time with Ted Kennedy, and then has spent much of the last part of her career doing research ethics policy. So that's our panel. It's about as impressive a group as you can put together, and we're going to jump right in here. 10 years ago, when we did our first bioethics conference, we decided to do it on research ethics, and that's part of the reason we've circled back to this topic now on our 10th year anniversary. But one of the things that when Jim Hendricks and I sort of sat down to talk about that first conference, we actually gave it sort of the subtitle Current Controversies, and what Jim and I both agreed on was that we wanted this conference to be one where there weren't a lot of shibboleths, that people, we could actually talk about issues that seemingly everybody agreed on, but maybe they didn't. And we've sort of removed the current controversies part from our titles, but nonetheless it remains sort of part of our planning. And in an effort to get to the current part of that, I wanted to have the panel talk a little bit about what is probably the most current controversy in research ethics, which many of you have read about in the newspaper, and that is the Facebook study that was recently published in the Proceedings of the National Academy of Sciences. Now, to just sort of briefly let the audience know what this study involved, if you haven't already heard, and some of you may actually have been subjects in this study, there's a good chance. The title of the article that was published in Proceedings of PNAS a few weeks ago is Experimental Evidence of Massive Scale Emotional Contagion Through Social Networks. The authors of that paper were from Facebook as well as Cornell University. The study did not receive any kind of IRB review, in part because as a private corporation, Facebook is not held to the federal regulations, and the IRB at Cornell decided that they did not have jurisdiction over the study. Essentially what Facebook does, now for those of you who are Facebook users, you know that sort of your most common sort of interaction with Facebook is to look at something called a news feed. And you can go to your friends' pages and get sort of more complete updates, but this news feed, and what you may not know is that this news feed is sort of algorithmic, that not everything your friends are posting ends up on the news feed, but there's an algorithm that sort of decides what you're going to see on that news feed. And so you get these sort of tidbits from people you have friended on Facebook. Well, what they did in this study was they decided to slightly alter the algorithm for people who they identified as being in this study. And ultimately there were almost 700,000 people that were subjects in this study, including a control group. But the intervention group was a group of people for whom the algorithm would identify positive and negative words and linguistics in posts and either slightly decrease the negativity of the posts that you were receiving by about 10% or slightly increase the positivity. And what they found was that when the positive content in your news feed was decreased by 10%, a greater percentage of words in your status updates were negative. In other words, your mood sort of reflected the decrease in positivity in the posts you were seeing on your news feed, that your posts became more negative. And they also found the opposite, that if you were seeing fewer negative posts, your status updates became more positive. So the obvious conclusion of the study was that not only are we sort of impacted by personal interactions with people, but actually with these social network interactions we have, our moods are altered by what we see. Well, when people found out about this study, they realized that this had all been done sort of without anybody knowing it was being done. People felt manipulated, not surprisingly. Nobody had asked for consent. Nobody had given anybody the option to opt out. And so, by and large, most of the criticism I've seen has been quite negative. Facebook has been put on the defensive and so on. And I think the first question I would like to pose to the panel is, was there really anything wrong with sort of what Facebook did here? So it looks like Alex and Norm are ready to jump in. I'll let you guys duke it out.
Okay, I want to suggest that there are three initial questions. Some of them may have answers.
That is to say, someone may have some additional information. The way the study rolled out, they ended up with something which qualified as a scientific finding, a contribution to the understanding of this social contagion issue as you've just described it. And so this seems to be a matter of interest to academics. There were 2 academics who were the authors and were involved in the design of the study and the writing up of the study, but not the collection of the data. And then a scientist who was at Facebook. It's also of interest, apparently, to Facebook because they want to avoid what they call abandonments, that is to say, people who leave their page. That's an abandonment. For those of you in medicine, the term has a little more power when it's used if a physician abandons a patient, but this is what they call it. So they're constantly wanting to know what makes people like being on Facebook. And the theory that apparently had existed at the time is seeing your friends having the wonderful lives that they have actually depresses you and makes you not want to be on Facebook because you look at your own crappy life and think, yeah. So the first question is this something that is of mixed interest? Is it a scientific study? Is it simply a marketing issue for Facebook? And then the question is, so let's look at it in the 2 ways. If it's simply a Facebook matter, I guess my sense about it is we would not have an ethical objection about it the way we would about research conducted by an academic, because we, in fact, accept this in lots of our interactions, and we approach people who have things to sell to us with a caveat emptor rule. If we don't do that, we pay a price for failing to do it. And one of the things that is in that long set of provisions in the terms of service that you click to, most of us click without ever scrolling down, but if you scroll down, you say you will allow them to examine and look at your interaction with their site, and that's what they say they were doing here. When you have academics involved, the objection that has been raised to all of this concern, and one of the times when you want to lay all those ethicists end to end, as Norm was saying, is when they raise objections and want to make it much more difficult to do this kind of examination if you happen to have an academic appointment. They say, well, why should it be all right to do it if you're in a corporation and not all right to do it if you're an academic researcher? And I go back to thinking about all the studies that have been done through time by non-physicians. It seems to me with physicians, we would have an easy answer, that we have a relationship which is based on a particular set of obligations. But we don't have that, and those obligations would limit you doing research without consent. And Frank Miller has just had an interesting piece in the Kennedy Institute of Ethics Journal that you should look at if you haven't yet, talking about what used to be the pattern before 1966, when a lot of research was done by clinicians without consent. But now, for the last 50 years, our basic view has been that that relationship requires consent. So do we not require it of corporations? And if we don't, are we biasing things and making it hard for social scientists who don't have that clinical relationship to start off with? But I do think that even in the non-clinical relationship, there is a different set of expectations for people who have an academic scientific interest, and it isn't based solely on the risk that they're exposing you to. It's asking you to, in this case, be randomized into these 2 groups and to have your life changed by them. I don't go as far as some people who have been critics and say that they were messing with the minds of all these people. It's an overstatement. It's almost a dignitary issue. And it seems to me that in this case, a review could have asked some questions. Maybe there were some people in the subject group who would not be good people to have there, people who are prone to depression or so forth? Is there any way to know that? Is there any way to screen them out and so forth? These would have been questions that I think would have been asked by the IRB at Cornell if they hadn't stepped away from this. So I think they should have had a review.
There's a letter in the current issue of Nature by Michelle Meyer and signed by a long group of distinguished ethicists, including Steve Joffe, so I'm sure he'll comment, and criticizing the critics of the Facebook study. And I agree, I wasn't a signatory, but I agree with the letter. But I think it didn't go far enough. This claim, this is unequivocally research, what Facebook did, but the claim that everything in the public and private sphere that's research must be done under the common rule and should go through IRBs and have informed consent is crazy. I've heard, for example, you may not believe this, that the tobacco companies have done research based on testing the hypothesis of whether showing beautiful people smoking will lead other people to smoke. And it turns out it does. And it's resulted in roughly 400,000 deaths a year, millions of deaths. I heard that President Bush did a study. The hypothesis was that if he invaded Iraq, that the Iraqi people would be better off and the American people would be safer. And it resulted in millions of lives, and it's not clear that anybody's better off. So the notion that these pretty horrible experiments that resulted in far more harm than this Facebook thing should have gone through an IRB, or that we could construct the world that way, it's crazy to me.
So I first want to actually start by asking Alex, you mentioned scrolling down on the Facebook terms of service. I'm sure most of us in the room don't scroll down, but do lawyers scroll down on those terms of service every time they sign up for something like Facebook? Okay, just wanted to be sure. It would be.
That's why their claim in the published study that there had been this consent because it's in the terms of service is laughable. I mean, that if we needed consent, that wouldn't be it. So the real question is, do you not need it?
So the thing I want to point out, this study with Adam Kramer, who's the first author of the study, is a member of Facebook's core data science team. And if you read the article, there's an acknowledgement, and the authors thank 4 or 5 other members of the core data science team. And my sense is that the core data science team is a group of statisticians and experimentalists and social scientists who study ways to get you to use Facebook more and get you to abandon Facebook less and increase your advertising revenue and that sort of thing. And I have no doubt that for those of you who are Facebook users, you have been the subjects of lots of little randomized trial that Facebook embeds into everything it does in order to maximize its business case. And the fact that this one study happened to be published, happened to have some involvement of a couple of people who are academics, I struggle to find what's different about that makes it different than all those other randomized trials that Facebook is undoubtedly doing that we don't know about, that are all about Facebook's business case. So, Alex, you asserted that the involvement of academics makes this different, or that in some way academics have some sort of professional...
Could I ask you a question about that, Steve? The reason I raised, and I don't know the answer to this question, would you feel differently if scientists at the 2 co-authors on the paper at Cornell had been talking about the theory of social contagion, and they'd done work on it, and they knew it worked face-to-face, and they said, you know, there's so many people are in touch with each other through Facebook, I wonder if it works there too. And they had gone to Facebook, which, let's just suppose, hadn't had a commercial interest in this before, but they said that's an interesting question, and it would let us know more about the power of this instrument we have, Facebook. So we'll collaborate with you and make our roles of subscribers available to you. Would that change your view as to whether or not the Cornell people should have treated this as something that was reviewable by Cornell?
So, I mean, I think there's no, as I understand the study, and I'm sure there are details we don't know, as I understand it, there's no regulatory reason why they must have gotten IRB review. If there was federal funding or something like that in it, then they would have...
Well, if Cornell says when our faculty are involved in research, we check the box, in other words. We're an institution that applies our processes to non-funded research. And so I'm asking, would it be different if the Cornell scientists had initiated the research?
I
and
think
had
that-
gone to Facebook and gotten Facebook to collaborate as though they had come to Seattle Children's Hospital and said, would you collaborate? Or as many people go to Uganda and say to people there, we have a study we'd like to done, we need collaborators. And
So-
part of it is you provide the subjects as well as being our colleagues in the
Right, I
study.
mean, if Cornell has a policy, I mean, if they check the box and say, we're going to apply this not just to federally funded research, but to all research at Cornell, and it was Cornell investigator-initiated and all of that, then I think to be consistent with their own policies, one would have expected that they do that. So yes, in that case, I
But it
agree
would
with
have been
that.
foolish the way Norm suggested. I mean, just be silly. That's, Norm said it, just be silly. It'd be ridiculous to apply the common rule to this.
Can I
Do you wanna jump in?
Can I jump in here? Is this on?
Yeah.
So I think we often conflate what's required in terms of regulations and what we think is sort of the right thing to do ethically. And I agree with Steve, there's lots of details that certainly I don't know that would answer the question, even if it were initiated by Cornell, whether it fits with their regulatory FWA about whether they would need to, in terms of being in compliance with the regulations, submit this kind of study if they require, not only if they require all of their research that is not federally funded to go through, but whether for the Cornell investigators, any identifiable data that's not otherwise public was going to be something that they were going to analyze. I mean, I think it's very possible that at least as far as the Cornell, I could understand a scenario in which the Cornell researchers would have no access to anything that was not publicly available, and their IRB might have said that they don't have to, it doesn't need to be further reviewed for those kinds of reasons. I think since we all know that businesses, not only Facebook, are doing metrics constantly, and it's part of what they're supposed to be doing, and sometimes they do randomized studies, and we probably all know of other anecdotes beyond the Facebook one where we learn that we've been randomized to a variety of interventions for marketing purposes, et cetera. And that's the norm, and as public policy, we've decided that's okay, and we've decided that there's something very special about health research, about research with patients, about research with people who might feel exploited. There are things like that that have led to this very separate path of regulatory requirements, which gets to the foundational ethics behind those very special and sort of bracketed requirements. It seems to me that it's much more what I'll call a judgment call on the part of Cornell, whether it wants to be conservative for what I'll call reputational and trust purposes, that it wants to be able to say, anytime our people are involved with anything, we look at it. Not because Facebook owed it to anybody, not because we think there's something wrong with what they're doing, but just we want to be able to say that reputationally. That to me is a very different kind of judgment call than whether I think there was something ethically off base here. It's almost like a political judgment call, and I don't mean that in a negative sense. I mean it in a thoughtful sense.
Go ahead, Pearl.
Yeah, I mean, I agree that I think this is a reputational thing, and regardless of whether or not we were to vote and say, yes, an IRB should have or should not have, I think this has huge implications. I think there were a couple third rails here. One was the word randomization. That gives everybody the heebie-jeebies. The second, I'll tell you what heebie-jeebies are later. I'm not sure I know.
They're related to shibboleths.
Yeah.
And you have a treatment for the heebie-jeebies.
But they itch, yeah. But I think one thing is that word. I think secondly, we are at a different place in public's perception of data is so readily available, it's so easy to paw through it and do research. And I think we are all seeing this incredible demand of people of, if not control over use of their data, notification. And I think the type of user agreement in Facebook is one of those ones you just say yes if you want to go there anyway. You're never going to read that stuff. But I think we are at a very different social time right now. People do want to control. And I think, unfortunately, because you can say this was behavioral, it kind of is somewhere between marketing and medicine in I think a lot of people's minds. And my concern is the ripple effect of this. Particularly as we're talking, I know Steve Later's talking about like PCORI stuff and patient outcomes research where we are constantly looking at people's medical records without their knowledge, and I think those days may be coming to a close. And I think so. I fear about the implications of this, whether or not it should have been reviewed or not. And I think you need to watch that.
Give it one more, Alex.
Okay. I want to suggest that in what we're going to hear later from Steve and so forth, that we have an opportunity right now to have a conversation, not just in this room, but more broadly, about what are our expectations. Because what I'm really talking about are those expectations. And I have the expectation, as does Norm and Steve, that companies are constantly trying to figure out how to entice me to buy things. And as you say, the cigarette companies with the beautiful people smoking, the way shop windows are arranged, the way produce is arranged in the grocery store, everything, they're trying out different things. I have no problem at all with that. And if it is research in which they're changing the environment and then watching what happens to the bottom line and so forth. What I wonder is, let me do a thought experiment. So, when I go to a movie, I know I'm going to be emotionally manipulated by the director and the actors. That's what the writer of the story and the producer and so they all want to do that. But I would not, and I accept that that notion, and assume a good artist does that intentionally and carefully and skillfully. I would feel very differently if I went to a movie and the film had been filmed in 2 or 3 different ways in order to change my belief about something or my actions, and I was going to be randomly assigned at showing in a multiplex, and I'm being randomly assigned to one multiplex or another.
How do you feel about supermarkets that very deliberately manipulate what you're going to buy by putting soda on the ends of the aisles?
Absolutely. That's when they are selling the soda. I'm saying if they wanted to see if people have a happier life when they've been manipulated, when they've been shown one version or another, and they have a way, because I've used it, let me just finish. They have a way, I used a credit card, they can follow up with me, they'll send a survey. My credit card's attached to an email account. When I gave it to the guy to pay for the cab the other day, I got a receipt, and he said, "This is the right email?" I said, "Yes." I hadn't given it to him. He knew it. So if I get a survey a few days later from a survey firm, they don't say that they're connected to the people who were manipulating me to see the happy version of the movie or the sad version of the movie. What other things are going on in my life, and do I respond? I would not feel that that was within the parameters of what I was agreeing to when I went into the theater and they pumped the popcorn smell in to try to get me to buy the popcorn and all the other manipulations. I am now the subject of an experiment looking at something else. It's not simply, am I giving in to the blandishments in the way that they advertise their products and so forth. I think that is different. And as to the difference with the researchers who come from academia, all of us in academia, when we're pursuing knowledge, expect a special dispensation from society because we are producing a public good. We're doing something for the public good. Facebook isn't doing that. There's no pretense that they're doing that in trying to keep more eyes on their page. And everybody knows that about Facebook. That's part of a commercial relationship. But we put scientists on a different plane, and we say what is special about them is that they're contributing to knowledge. That's why IRBs let people go into studies. They say, is the study well enough designed that it will contribute to knowledge? And if it is, then it's okay to ask people to take on whatever risks and so forth are in the study because it will contribute. If it's badly designed, bad science is bad ethics. You don't want to let that study go forward. So those folks from Cornell who were involved here were wearing that hat, as far as I can tell. Now, I don't know, Steve, maybe they were just brought in as consultants, and then their names were on there because Adam Kramer thought it was more likely to get it published in the proceedings if it had their imprimatur on it. But if they were the originators, if this was a scientific study, it was done for the reason all science is done, to contribute to generalized knowledge. And the participants who were brought into it were brought in for that reason. Are they brought in without anyone saying either you need consent or not? You don't have to always have consent, but you have a process by which that judgment is reached because it is a special activity for which we ask society to give us all sorts of privileges to do that.
So Alex, and by the way, in the interest of time, we should assume that all comments are preceded by "listen, you ignorant slut."
But in this case, you want to say it to make it.
So Alex, I infer from your comments that if R.J. Reynolds wants to do a randomized study of beautiful men or beautiful women or athletes, that that doesn't have to go through an IRB. But if they call somebody on this USC Business School faculty who's an expert in marketing and pay him or her to help them figure out how to design these ads, and he or she is what NIH would, or OHRB would call key personnel, then the whole thing has to go through an IRB, and we have to ask whether people should be able to consent and opt out and all of that. Is that your
And or
position?
being published. I can't tell what Alex is saying is maybe in part because this was published.
And no, it's not just, because do you want people to do research and then keep it secret? That wouldn't,
Well, the problem would never have existed if they hadn't published it.
no, we wouldn't have known about the problem if they
Well,
hadn't published
let's
it.
say that
But-
it would be in the company of the thousands of other activities just like it currently going on. And right now we're focusing on the Facebook.
And so, but although I think Pearl was making light when she said the heebie-jeebies with the randomization word, how much of the marketing research that goes on is actually randomized as opposed to longitudinal studies in which they try out putting soda at the end of the aisles or putting it near the checkout counter and so forth. When the behavioral economists, the academic behavioral economists like Thaler and Sunstein and so forth, went to companies and said, you guys, tell us what are your theories that you use in all of this? They said, we don't have any theories. We just try one thing out after another and see what sticks. And there's a lot of that goes on. Now, as I say, to me, that is part of my normal expectation of a relationship with a business. They're trying to sell something. They will try to make it attractive. If I go by the store window one day, they have one display, no one's going in, they change the display,
But if they do it well, then they need to do it.
No, they can do, that is one set of relationships. When people say, what I'm doing is trying to develop knowledge about something, I'm not just...
Can I give you one other example?
Of course.
I have a neighbor. I live in a big neighborhood, so it's going to be really anonymous. I have a neighbor who is a physician with a private insurance company, and at some point when he was over and we were having dinner and we were chatting, he was describing to me, because he has some responsibility for chronic disease as well as for the bottom line, and he cares about the people there and he cares about their bottom line. They have randomized covered lives to getting different kind of preventive approaches to their chronic diseases. They have randomized the people who are insured to saying, you're now part of, there's a new benefit for you. You're going to have a nurse call you every 3 months to give you coaching in your asthma care. There's a health education program that you can go to for your asthma care. And I was wide-eyed listening to the fact that they were randomizing.
Why were you wide-eyed?
Randomizing.
Why were you wide-eyed? That was the heebie-jeebies coming in?
It wasn't heebie-jeebies, although I appreciate the gotcha approach. I just wanted to point out that it's not only in marketing of sodas or Facebook or a storefront where people are trying to get, I would argue in this insurance example, not only improvement of economics, but genuinely improvement in the management of diseases, right? They're trying to do something that I think is laudable, coupled with thinking about economics. I asked a few questions about whether anybody has to approve it, whether they ever publish it, because I actually think other people would benefit from that. But the point is, for better or worse, we do live in an environment where people who don't, where there's this view about what's covered by the regulations has to be subject to those kinds of norms, and other things not only are not covered by the regulations but aren't covered by the norms. We can decide that that's the same or not, but I do want to point out that what we say we're used to in our, if part of the argument being made is that Facebook went beyond what happens in our normal lives with which we're comfortable. I just want to point out that our normal lives have a lot of this kind of stuff going on, and we're just less aware of it.
Well, I would hope that that company, if it thinks it's doing something legitimate, would share that as a general matter with its subscribers. And if people don't like that, they should buy from another company. And the company should be able to say, as I suspect they would have a good case in saying, we think at the end of the day, your insurance dollars will go further if we can figure out how to most effectively deliver care for you. And in that process, we will be making variations of this sort and be very upfront. And, you know, if along the way you have ideas, we'd like to hear from you. If you have concerns, we'll answer them. If you're really unhappy with this, there are competitors in the marketplace who we don't think are as forward-looking as we are. I would like to have that conversation. I would like to have the conversation that Pearl and I'm sure Stephen will provoke about the use of records for the learning health systems. I think it's a terrific idea, but I think we ought to be aware that this is part of our new relationship with our caregivers, that these information, these data should be used, and that we expect them to be used, and we know that certain protections are built in, that the use will not be harmful to us, but not have it happen without anybody being aware.
Can I just say very quickly to connect this to two larger debates that I think are very live in the world of research ethics right now. One is this, the question of a learning healthcare system, and this will come up later today, where part of the issue there is we have been in a situation of unsystematically trying this and trying that sort of along the lines of what Alex suggested, and now there's a question of can we actually systematically answer questions about what works in the everyday practice of healthcare through a sort of systematic approach to quality improvement and learning, and the use of randomization, I think, plays an important role in that. So this is very connected to that discussion. The other is the question of the boundaries of IRB review, and there's an article in Science probably 5 years ago now by a group of social scientists arguing that there's been a real problem with mission creep of IRBs out to things like history and oral history and research on literature and that sort of thing, and just where should the boundaries of IRB review be. And, you know, clearly this Facebook study is somewhere around that boundary because people are seeing are taking different perspectives on it. But I think there's a very live debate right now on where do the boundaries of IRB review belong.
So, Steve, so that sort of leads nicely into my next question, which is that if we sort of move away from what Facebook did here, but think more broadly about social networks, they provide a very rich source of data. And it's a rich source of data that actually does have application to some of what we do in the healthcare arena. I mean, the adolescent medicine people, for example, are very interested in mining Facebook data to look at everything from depression to substance abuse to the way social support networks develop. Some of that work can be done without ever friending people because many of these, I mean, if you're on Facebook, many of these accounts are open, in other words, publicly available. So it's presenting challenges for IRBs, how to think about social network research as, you know, adolescent people in adolescent health in particular start wanting to use blogs or Facebook or Twitter to examine behaviors or examine certain aspects of adolescence. So how should IRBs be thinking about, I mean, is it just another form of a medical record? What about the fact that they're publicly available? Does that mean IRBs can just simply sign off on that and say we don't regulate that? Any thoughts about that?
I guess my first response, and I agree, this is a very sort of unsettled area. My first response is as a general matter. Well, first let me first endorse something that Alex said, which is that transparency is important. So if the use of a social network sort of opens you up to the use of your data in certain ways, and if you don't want them used in that ways, you have to take certain steps to control that, then I think transparency about that and setting clear expectations is important. So I endorse what Alex said along those lines. My second point is, my personal view is that public data are public data. So anything that I put, let's say if I make my Facebook page completely open, then my data are public, and then they can be used for whatever purposes anybody who has public access to them would like to use them. Obviously, we're not going to endorse academics using them for malicious purposes, and we're going to expect certain kinds of sort of control over the data that the academic then has in hand. But public data are public data. The one caveat I want to put around that is I certainly feel that way for adults. I have some concerns about that with respect to kids because of the judgment of kids and the ability of kids to exercise good judgment around the use of their data, and the fact that we want to be more protective of kids than I think we do of adults. So I think there are some particular issues when we're talking about the use of social network data for research with children. I'm frankly a lot less concerned about it with respect to adults. I do strongly believe in the value of transparency and setting clear expectations and then adhering to those expectations.
Yeah, Lainey.
I want to echo what Steve said. I mean, particularly with regards to adolescents and even the topic that you picked on depression. I mean, pediatricians are mandatory reporters. Many of us in the healthcare world are mandatory reporters. And so all of a sudden you're getting into a case where you're lurking and you're now concerned about this child's health. And now who are you going to approach in order to get to the next step? And so I think, therefore, it does need some type of plan, which is often helped by actually having gone through some IRB review and getting help and thinking about how to approach it.
Pearl?
Yeah, I agree with the previous comments. I think one thing that we're finding on a lot of social network pages is that up front it's just, this is just a chat room, feel free, and then as you proceed, they'll say, oh, now this part is research. And it's really difficult to figure out when you've gone over the bridge to research. And so my concern there is even when you try transparency, it's a difficult message to get across. Secondly, as soon as it is research, there is this responsibility, as you talked about kids, but it could easily be an adult who's showing suicidal ideation. In other studies where you are doing survey stuff, we always ask, what are you going to do if that happens? Suddenly it's this wild, broad world, and in many cases you don't even know who the person is. It could be 5 people who are signing on as a single, person. So I think this is an area I think we also need for research and use of social networks. We also need to talk to clinicians in terms of how they are using social networks. There's a growing literature on psychiatrists who, if a patient who's had suicidal thoughts in the past doesn't show up for 3 appointments, well, I'm going to go on Facebook and see, if they're posting, negative thoughts to Alex or not, and, go from there. So I think we need to also follow what's happening clinically to, I think, inform how we use it in research. It scares the pants off me.
Yeah, I just want to pick up on something that Pearl was just saying. I think when we have these really appropriate reactions, that there are certain areas, like when you start to think about looking at Facebook with regard to what's just up there with adolescence and depression, that the stakes are a lot higher, and it's ethically and in terms of well-being much dicier. It seems to me that doesn't necessarily, I'm not sure that the only right reaction to that is putting additional cautions around research. That may be one really appropriate reaction, but it seems to me that there are broader policy things there, like maybe Facebook ought to have a really different policy about what the default is for people under 18. And maybe what happens clinically or for anybody, some of the default, maybe Facebook ought to be mining for certain kinds of suicidal ideation. I mean, I don't mean to sound silly here, but the fact that we say researchers can be finding something, can be walking into dicier territory, they have to be careful, I think comes from a really appropriate place. But I think it somehow is, usually the tradition of research ethics is identifying a place where research is causing the harm. And this is different. This is researchers encountering a dangerous or harmful or risky situation. And if that's the case, it seems to me that the right reaction from the big picture is not only boundaries for research, but how can we think about this situation?
Norm?
3 short comments. First, I just want to add to Nancy's comment that minors on Facebook is different versus adults. That is, adults is, like Alex says, it's a public place. You understand it's not private, and you can hurt yourself by doing, just like getting drunk in a bar, you can hurt your career and so on. And so I think there'd be different criteria for research involving minors. Second point, that doesn't mean there should be no research on minors using Facebook, even without their consent, following the criteria for waived consent in the regs. So, for example, doing epidemiologic studies of how many minors are engaging and exposing themselves with photographs and so on. So Megan Moreno, I don't know if Megan's here, but Megan's, who's a wonderful pediatrician, formerly of the University of Wisconsin, on the faculty here, who's very famous nationally for research she does on Facebook, minors, adolescent behavior, very valuable research, but doesn't expose any of them to harm. So I think there's research that can be done on minors that's of zero risk and advances the cause. Third, just because you're doing something in the public place doesn't mean you have an expectation of exposure by a researcher. There was a book by a Wisconsin sociologist many years ago called Blue Collar Aristocrats. This guy hung out in a bar in Middleton, Wisconsin, where I lived, and everyone knew he was a faculty member, but they didn't realize that he was doing research for this book. He hung out there over a period of years during happy hour and wrote this book about these blue-collar aristocrats in this bar. And, you know, it was just incredibly identifiable. So Red is a 6'4" electrician who works for the phone company and has been sleeping with the boss's wife. And here's how he talks about it. So, you know, Red knows when he's in a bar and starts talking about this stuff, he's going to be in some sort of risk for trouble, but not from having a book that gets on the New York Times bestseller list and makes him quite identifiable. So just being in the public sphere doesn't mean you automatically give up your... I thought this sociologist behaved badly by essentially deceiving these people into thinking he was just another bar guy and had the same level of trustworthiness, whatever it was, that everybody else in the bar had.
So I want to move to a different topic now in the interest of doing something more controversial. Norm, you raised the provocative issue about payment for research studies, and I have a number of questions I'd like to ask the panel about that. But let's start with adults, because you mentioned $13,000 to have...
Proud of it.
have something put in every orifice in your body. Is there any limit on what you can offer adults? Does anybody think there's a limit? And as a side to that, the common objection to this is, well, no amount of money is going to get Bill Gates to participate in this study, but what you're going to do is pull in people who are disenfranchised, who don't have resources, and who are desperate, and that's not fair. So I guess the first question is, are there limits? And secondly, is that second objection valid?
Yeah, the second one's easier. Bill Gates isn't going to work in a coal mine either, and he's not going to work on a highway construction job. That is, blue-collar jobs are taken mainly by people who don't decide, well, should I go to Harvard Law School or should I work in a coal mine? Blue-collar jobs are taken by people, some people do it because they love working in a coal mine because their father worked in a coal mine. But for most people, it's because it's the only work that's available. And the injustice is not that poor people take blue-collar jobs. The injustice is that they get paid so little for it, not that they get paid too much. It's just completely backwards to say, well, it's okay to induce impoverished people to work in risky jobs as long as we don't pay them very much, lest they do it just for the money. God forbid. So it's always, as long as we're going to allow blue-collar work, and, we try to make it as safe as we can and make sure there are medical benefits and try to do all those things. I think the injustice is that the pay is so low. And just this national debate we're having about what the minimum, should it be $8 an hour or $10, both of which are poverty wages. That's the injustice. It should be $50 an hour and spread the wealth around. The first question, is any amount too much? There was a famous spoof published in Science on a parachute study in which people would be paid to jump out of airplanes to test how low could you go before you open the parachute. That is, the Army was interested in developing a parachute that you could open at 10 feet to avoid enemy detection. It's not just that there would be some amount of money that would be too much money. Any amount of money would be too much money. There's some studies that are prima facie ethically problematic. But the mere fact...
And presumably, so one parameter here is that the IRB is doing its job. In other words, any IRB should look at a study like that parachute study and say, this isn't acceptable. aside from the money.
Yeah, but I think we have to understand that people are going to die from allowing research. You know, the current dysregulation of research that we have is largely due to a handful of studies in the 70s and 80s. You know, the study at Rochester of a woman who volunteered for a bronchoscopy study and died on the table due to mistreatment. The woman at Hopkins who inhaled hexamethonium and died. Jesse Gelsinger. In my view, and the view of a lot of other people, to take Gelsinger, which is the most famous one, there was nothing wrong with that study. And the fact that Wilson, the investigator, had a conflict of interest was beside the point. Even if he did not have a conflict of interest, the study still would have gone forward and it would have been appropriately accepted. So if you're going to have research, people are going to die. Not just in therapeutic studies with risky drugs, but non-therapeutic studies such as the hexamethonium study, which was a study about the pathogenesis of asthma. A research nurse who knew all about it and understood it, volunteered and had some bizarre idiosyncratic reaction. So death has got to be an acceptable cost of having a research enterprise. If we're going to aim for zero risk, which is what the aftermath of those cases were, that somehow the system is out of whack because we had 4 deaths in a 10-year period, at least 4 that we know about. That's not a tenable position also. So you have to accept some degree of risk, and risk means including death. But, you know, parachutes that open at 10 feet is too high. How high a risk is too much? I don't have any algorithm for deciding when that is, but something that induces people to the parachute study would be a bad study, not because of the money, though.
Right. Laney?
Yeah, so I can't let Norm get away with that. So the hexamethonium study used industrial-grade hexamethonium, nothing that should have gone into any human being, and there was no way the research nurse could have known that. The research nurse was also in the next lab, and when the report came out, it showed that each of the labs were being told by their supervisors, you help them and they'll help us. So I actually find that absolutely atrocious. And the Gelsinger study, it had been approved by the IRB and the RAC, the Recombinant DNA Advisory Committee, that the medicine would be given through a peripheral vein, and instead it was placed directly into the hepatic artery. They actually violated 3 different things that they had promised in the IRB and to the RAC. And the fact is that Jesse Gelsinger had failed the inclusion criteria on the day that he was enrolled. And the fact was that because it was being supervised by the RAC, any adverse events were supposed to be reported within 48 hours. The one thing that came out of this study was the RAC actually went out and said, if anyone else has people who had adverse events that you didn't report within 48 hours, we're going to give you for like the next week sort of permission to do it, and we won't get you in trouble. And over 750 adverse events came in. So I think those are 2 horrible examples, Norm, and I think we needed greater protection for those, and I could keep going, but in the respect of time, I'm just going to say, be careful the examples you're using.
Pearl? Go ahead, Nora.
Is slut a gender word or not? I'm a little concerned here. I'm going to use it more often now. I think going back to is anything too much, I think the problem with the discussion of this is it's one issue with multiple contextual other things that have to be considered. I think they've already alluded to, if the risk is too high, the 10-foot parachute thing, no is the answer to that. And I think also looking, what are your eligibility and ineligibility criteria? If you're going to go to the homeless shelter and give $10,000 for the 10-foot parachute drop, it's very different than going, to Microsoft. So I think you have to include all of those together. On a very practical level, my concern is equity. Research funding is going down the toilet. And I think the problem I have with this is that rich studies will be able to pay more. I think you will get more people into them. And I'm just not sure how you're going to, figure out how to do that equitably. And, all the things we're being asked to do, it's the budgets are just not there. So, practical issues.
So I want to add a couple of things to what Norm said. I think there are a lot of ways in which I agree with his view that our primary responsibility in the ethics world and the IRB world is to evaluate its study for its acceptability with regard to risk. And if a study is too risky to be done, it doesn't matter how much money. If the study is acceptable, then why should we be as concerned about money? It seems to me that the one other piece here that would be important to look at, I think more than we have yet empirically, is whether the amount of money that is given affects participants' understanding. And that's an empirical question. It's easy to evaluate. And again, I just don't think that we've done that. And again, there could be a really cool randomized study where people get different amounts to participate and their understanding is systematically evaluated, and we could see whether giving people a lot more money almost makes them ignore. They're so interested, it's like, wow, I can get $13,000, that they stop even paying attention to the risks and benefits. And informed consent is intended to be the second layer of protection for individuals beyond what the IRB evaluates, because we all have different threshold levels. So I do want to sort of put that caveat around it, that I think that's important empirical work. I don't think that if the answer is yes, greater amounts of money are associated with decreases in understanding, that necessarily the take-home message from that is that we we pay everybody less to be in research. There are lots of other ways that we help to assess systematically what people's understanding is, and we figure out creative ways to improve that, which is a responsibility we should be paying more attention to anyway. I'll stop at that.
So, Steve, I'll let you go next, but let me open this up, broaden it a little bit to bring children into the equation, because Nancy, your comments sort of segue to that, which is when you're now enrolling children in a trial, and any payment you make is obviously going to be controlled by the parents, regardless of whether you designate it to go to the child or not. You now have the decision maker, the person who's supposed to be focusing on the informed consent, protecting their child, with an incentive to accept money. So I guess I can't assume anything with this group, but I certainly have come to the conclusion that whereas I don't care how much you want to offer an adult to participate in a trial, I get very anxious about large amounts of money being offered to parents to enroll their children in trials. So, Steve, do you want to start with that? And you can.
Let me just quickly say two other things that are more general, and then I'll address this question. So the first thing I wanted to say, just in terms of your concern about people with limited other options, people who are poor, being sort of differentially recruited into studies. To me, it strikes me as extremely paternalistic to say these are people who, because they have limited options in their lives, can't make the sorts of decisions that we might let other people who have more means at their disposal make. So maybe I worry about the inequity thing a bit, but I worry a lot more about being paternalistic and saying to people, well, you can't really make these decisions because your your options are so limited. Second thing I wanted to say, just to flag the fact that there's a tradition of paying people in, quote, non-therapeutic or no potential for direct benefit studies, and a tradition of not paying people who take part in studies where there is a potential for direct benefit, except maybe for the expenses of parking and an extra meal or something like that, that we don't want people to lose money, but we don't pay people. And I find that practice or that distinction very hard to defend. So I want to raise the issue of whether we should be sort of more forthright with paying people for participation in studies that do have a potential for direct benefit. Finally, let me come to your question about children. So framed by the same limitations that we discuss with respect to adults, which is that these are studies that are appropriate to invite children to participate in any way. They are consistent with one of the paragraphs of Subpart D, which is the section of regulations that governs children. We think it's an ethically appropriate study to invite a child into, period. I have trouble seeing why the offer of money to the child or to the parents on behalf of the child should change that. So your stance is that with adults and children, if the IRB is doing its job, applying the regulations, making a careful assessment of risks and benefits, the payment really is irrelevant. Yeah, and I think the particular issue with respect to kids is we do think it's important that kids in an age-appropriate and developmentally appropriate way have a chance to assent to be in a study, to agree to be in the study, and if they say, no, I don't want to be in the study, then we have to take that seriously, and in most cases, that's going to mean that they can't be in the study. Again, assuming it's developmentally appropriate and all of that. And so the one thing I would want to avoid is a situation where the parents are putting extraordinary pressure on their kid to be in the study because the parent is looking for the money from the study, where the kid is trying to say, no, I don't want to be in the study. And we would have to be very alert to those kinds of situations. So that's one place I worry about it. You also, I don't know if you were sort of thinking about this when you asked the question, Doug, but the issue of payments directly to children, of course, there's the issue of the payments to the parents, but what about the payments to kids? There was a policy from the American Academy of Pediatrics some years ago. I actually don't know if they've changed their policies.
They have.
So the one about retrospective payment?
Committee on Drugs, yes, that
Good.
has been
So
over.
update us on the current policy.
So, well, to explain what Steve Jaffe is pointing out, there was a Committee on Drugs had done a statement which was on ethical issues enrolling children in research. And one of the things it suggested was maybe we shouldn't talk about how much money we would pay children until after they had actually enrolled, so this way it would not be an inducement.
Kind
Of course,
party favor.
of course, what people then realized was that your party favor would then be your entire school's inducement to come and follow you. And so that was a problem. It was also clearly against the Fed regs, which said that you have to deal with all of this up front. And so that has been that no longer exists in the policy statements.
Revised.
But that was from the 1994.
Okay.
But since I have the floor, I'm going to keep it.
Okay.
So I actually want to emphasize something that Steve just said, which was by paying people for participating in research might actually have a real value in the sense that when you go to your clinician, he doesn't walk out and say, thank you for letting me do a rectal exam, here's $20. But if the researcher...
Maybe he should, though.
Well, that's... But when the researcher hands you $20, all of a sudden the confusion between clinician and researcher may become very clear. This is particularly true, for example, in phase 1 trials, where we know that many people who enroll really don't fully understand that this isn't being done for their direct benefit. And so I actually think that's a really important point, that maybe we should be paying more people to participate in research. On that note, I just want to make two other totally random points, but related, which is one is that there are good data to show that surrogates, whether it's parents enrolling their children or adults enrolling their elderly parents, are much more likely to enroll others in research than they will be willing to enroll themselves. So I do think that when we start talking about payment and there is a third party involved, whether it's a parent giving permission for their child's enrollment or even a child enrolling their elder, that we do need to put in some additional protections. Now, that's not to deny that children, it's an opportunity cost. I can enroll in research or I could work at Burger King, so it's not that it's wrong to pay, but when you make the payment excessive, I think it might be an undue inducement. My last point, though, as the hour is wearing down, I'm actually sort of saddened that we're going to end on this note. So I want to sort of remind us of Paul Ramsey, the Christian theologian professor at Princeton University and not the UW dean, who said that, when we talk about enrolling participants in research, that we need to think of them as co-adventurers. And so this whole notion that people are only doing research for the money, then we sort of lost the bigger picture, which was that we want this to be an activity in which we as a society share and value the importance of this research. That doesn't mean that we have to go to no payment, because the researchers are being paid as well. But I just want to put it on that note that we need to think about that if we're not engaging the community to agree the importance of this research and that people are only doing it for the money, that we've really lost the moral high ground in all of our research, and we really need to think how we're doing it.
Can I add a positive empirical point to that? We did do a research project many years ago with people who join healthy volunteer studies essentially for money. And we asked them a lot of questions about why they have joined, and many of these people have joined many, many, many studies. And an overwhelming response was, yeah, I joined the first time for the money. And then I came back, sure, I wanted the money, but I really enjoyed it. I appreciated it. I thought I was making a contribution. And there were a lot of comments that people made spontaneously, not in response to a multiple choice question, that had to do with their feeling so good about themselves to be part of this important effort. So I think there's empirical data to support that.
If any of you in the audience would like to jump in and go to the mics, we can certainly engage you at this point. Otherwise, I have a list that we have barely tapped. So yes, over here.
on severe skin diseases in children. I'm involved in a trial with the children with a severe genetic disease, and this is a note I got from the, the company yesterday in a trial we're doing. It has come to our attention that some subjects may not fully understand that when participating in a clinical trial, they are not to disclose any information about the trial on social media or to anyone outside the study. Please inform all your participant subjects that if it is not acceptable to make a statement or to put pictures on social media. All subjects who will be identified as such will be discontinued from the study.
So you're okay with that, Pearl?
No, I just wanted to give a little context here. We have also faced the same issue, and from the sponsors, what they're finding is virtually impossible to complete studies. In that on social media, it's like, hey, you know, I have whatever your skin disease is, and the medication they've given me, if you lick it, it's salty, here are my side effects, you know, what does your placebo pill taste like? And like, so industries are basically finding that it's impossible to finish a lot of studies. I think that's just the context of it.
So that's where that's coming from.
Yeah.
So, you know, I actually I'm rereading the book And the Band Played On by Randy Schultz. And, you know, I mean, we didn't need social media. The community was talking and they realized that some were getting placebos and some weren't. So they all, you know, combined their medicines in order to make sure that everyone got at least some. So this is a perennial problem. And I think the solution that's being recommended is really problematic because it's just going to go underground. They're going to have to figure out a new way, whether they make the placebo to taste salty or something of that sort.
Over here?
I'm not exactly sure how to phrase this. I'm not sure if it's a question or a comment, but I know when haven't heard about the Facebook study before. I thought it was very interesting. And a lot of times when I'm trying to figure things out, I go back to basic ethical principles, one of which is respect for persons. And it sounds like the respect for persons was where people were upset at Facebook. And I also enjoy the comments about, well, with marketing, we've got a different sense of respect for persons than we do for research. And so that may be the question is that basic principle, respect for persons, different in some arenas than in others?
Well, it was certainly a part of the Belmont report, so I think, at least in the history of U.S. regulations, it was a core component. So I don't think it's supposed to be different.
3 components.
I suspect that companies that treat their customers in a respectful way discover, as Nancy Cass was describing to us about the research participants, that it's a principle which, when applied, has beneficial results. It's just that in the research area, we think it's obligatory, not supererogatory.
If I can go back to the dermatologist
Yes, yeah.
comment, because I think I'm in disagreement with my panelists.
First time ever.
I will not take the prerogative of having the mic to rebut the numerous mistaken comments that Lainey made about the Hopkins and the Penn study. It seems to me it is a critical element, as Pearl suggested, for clinical trials to have results be kept secret, certainly from investigators. And the reason they don't want the investigators to know interim results is so that they don't unwittingly reveal them to their patients, either patients in the trial or other patients, and screw up the whole thing. And it seems to me a necessary and an appropriate part of the contract if somebody's going to join a trial to maintain the confidentiality of what's happening to them. I mean, Facebook creates new possibilities for screwing that up, and therefore maybe that needs to be explicit also. And I agree, it's hard to enforce, but it seems to me people joining a trial need to understand that if the reason they're joining it is to advance scientific knowledge, which is the main reason for doing a study, they're hurting the chance of that happening by spilling their information on Facebook or anywhere else, and that there's a high expectation of maintaining that confidentiality. So it seems to me it's entirely appropriate for the sponsor to ask to make all reasonable efforts to stop patients or research subjects from doing that.
Could I add to that?
Either one.
Maybe we're going to say the same thing. It seems to me that the really critical piece of that is explaining why. Because it's the partnership in the research that is really the point. Sort of and I can only assume that the patients going into this study are so interested in there being a better solution. And so it seems that in saying together, thank you for being part of this so that we can figure out whether this new thing is helpful or not. A way we figure out whether this new thing is helpful or not is that some people get it, some people don't. We don't let anybody know which ones do. That way we can, in a really sophisticated way, figure out if it's helpful or not. If you're willing to be a partner in this, we want you, as much as possible, to be willing to be a partner sort of all the way, which means sort of helping to keep it private and secret. I don't even know which one you get. If you can help with that, it really helps us figure out whether it's right. And that, to me, is really different than if you join the study, you're not allowed to tell anybody, which comes across as this really strange and suspicious thing, in my view. So I think it's the explanation behind it that makes a big difference.
Go ahead, Alex.
Yes, Nancy, that was what I was going to say, but let me just add.
Sorry, would you credit that to Alex?
Yeah. I totally agree with that approach, that it's a matter of getting someone on board and recognizing that some people aren't going to come on board. And that's what I wanted to address in light of the example that Lainey had given. If the reason that a person is joining the trial is not to contribute to science, but because they think it is their only way of getting a treatment, which is very important to them, which obviously in the HIV/AIDS case was of the greatest importance, life and death, maybe with some skin condition it's not, and there might be a wider variation of people's reasons for going in. It may not be possible always to have the assumption that Norm operated with, and that's that people are coming in because they want to have an answer to this question. No, they may be coming in because they want to have access to a drug which is only available in the trial. And then having that conversation becomes more important, but it is also possible that there will be some people who won't really have that as their reason, even though they will agree, and they will have what seems to them morally as strong a reason to have a different view towards their participation.
I agree with that completely, although I think it's also important to include Chapter 2 of the HIV/AIDS history, which was the more patients who were absolutely understandably desperate for something that might help, understood about the scientific process, the more they started to
Absolutely.
advocate for placebo-controlled trials.
Didn't just advocate, but they were a major force in any of that
So I think that
happening.
will be relevant to all of
Right, it's still a partnership.
Yes, my wife was a speechwriter for David Kessler, the commissioner of the FDA during this era, and Larry Kramer, the head of ACT UP, had a sit-in his office at the beginning of the first AZT trials, demanding that there be fast tracking and that the drugs be, we're dying, we're desperate, we have nothing to gain from being in a placebo-controlled trial. And Kessler caved in and allowed this fast tracking, which greatly delayed advancing knowledge. And 5 years later, Kramer came back and essentially said, I was wrong, you were right. We're not learning as fast as we need to, and we need to go back to scientifically well-designed trials.
Go ahead, Steve.
I just want to, while we're comparing HIV to the pediatric derm cases, I actually think it's a really good comparison because while the HIV trials were talking about life and death, I think we have to put pediatric dermatology in perspective. From a teenager's perspective, acne the night before the prom is like a disaster. And so that from their perspective, how their skin looks is really, really important. And I think we just need to understand why they're doing this, just like we needed to understand why the HIV folks were interrupting the research. So I think we just need to also, as researchers, as people who are observing and trying to judge the ethics of it, put it into the context, into the participants' lives.
Steve?
I want to address both questioners' comments. First, to this issue of non-disclosure by participants in studies. I think there's another potential reason why companies may be concerned about disclosures that hasn't been mentioned here, which is the issue of moving markets and moving financials. So we expect investigators not to disclose information that they may have about studies because they may have an influence on companies' funding and stock prices and those sorts of things, and there may even be legal insider trading issues with some of that. And I don't know, and there's clear research that happens and has been a problem, and there have been a number of cases where people have been indicted for insider trading. I haven't yet seen any research, although maybe it exists, on patients or study participants' disclosures affecting stock prices, but I have no doubt that somebody disclosing that they were on a study and they had either some fantastic benefit or some huge toxicity might actually have an impact on companies' funding prospects. So I think that's another reason why companies are very concerned about this. To the comment about respect for persons, so first of all, in the early documents about respect for persons, what it translated to very quickly, and I completely agree that there's much more to it, but what it translated to very quickly in the Belmont report, at least for competent adults, was the requirement to attain somebody's voluntary informed consent. And we all agree that that is often or usually appropriate, but that there are times when that may be waived or is not necessary under various circumstances. And so the question is, when is, what does respect for persons, both in its narrow frame, which is the requirement to obtain somebody's informed consent, and in its much broader frame of all of the ways in which we respect people and we respect each other, what does it require in particular circumstances? And I think it's hard to talk about respect for persons generally without thinking about the context and what it demands in those circumstances. And finally, can I just say one last thing, which is I now understand why you invite Lainey and Norm back every year, because it's incredibly good theater, and I'm really enjoying it, and I hope you all are too.
Steve, the fact is that respect for persons in the Belmont report didn't just go to informed consent. It also stated very clearly, and for those who could not consent for themselves, that the principle of respect for persons was about protecting the vulnerable. And so let's give credit. The Belmont report people got it right. It was much broader than merely informed consent, even if that's the way we've been applying it.
I did say for competent adults, Lainey.
Go ahead, Pearl.
Yeah, I think I'm loving this Durham study now. I may sign up. But I think the discussion we've had is really important in terms of partnership, participants participating in it. But the one big thing, I think, if we could change anything, is bringing up the not only health literacy, but research literacy of the population. I mean, the informed consent process is broken. I have a horrible rash on my face. I'm going to the prom tomorrow with one of the sluts to my right. And and I'm not going to read the consent form anyway, and I'm going to then listen to the importance of blindness in a study. I just think I wish we could do it, but we can't deliver on that. So my fear is you're going to still get these things. It's like, what do you mean I can't tell anyone anything? Well, let me tell you about scientific design. I mean, there's a yawner right there. So I think, I don't know how to fix it, but I think we're stuck in a bad place.
Go ahead, Norm.
I can't resist the reference to Paul Ramsey. I knew Paul Ramsey. Paul Ramsey was a friend of mine. I don't want to say, Lainey, you're no Paul Ramsey.
She didn't like him.
I also took classes with Paul Ramsey. Sorry, I'm that old.
But it's to bring this full circle. This respect for persons thing can become a shibboleth and carried too far, as Ramsey did, because he extended it to children and said for most of his life that there can be no non-therapeutic research on children. Had this raging debate with Richard McCormick. Very late in his life, he realized that was not a good place to be. It was not in the interest of children to ban all non-therapeutic research, and he backed off and came up with this rationale for allowing it, calling it sinning bravely. But it's just that this principle of respect for persons can be carried too far.
I think it's lunchtime. Okay, so we'll take one more, but we only have 1 minute, and we do have to get to lunch because we've only got an hour for that. So let's.
Oh, great! Because I really want to see the panel answer this.
Yeah.
I'd like to extend the Facebook question by presenting this hypothetical. Say it's a four-arm study and it's super positive news, somewhat positive news, depressing news, and super depressing news. And we all know that all kinds of teenagers are on Facebook, and but they often may have presented themselves as being an adult. We don't know really who's an adult and who's a minor. And say it goes on for 6 months, and if the super depressed group, a subset, spends an excessive amount of time on Facebook, gets very depressed, and some of them take their lives. So have fun with that hypothetical.
that some of them, that you basically, you do this study, but in a much more extreme way to the point where some people commit suicide.
As I pointed out with my tobacco example, yeah, industry does stuff.
Yeah.
That leads to hundreds of thousands of deaths, and I'm not happy about that, but I don't think the solution to it is to have it all go through an IRB.
And most people conducting scientific research really do not want the Federal Trade Commission passing on their research. And so when we, no, seriously, so when we consider the notion of talking to your friends on the IRB and having them ask some questions that make you rethink what you're doing slightly and tweaking it, versus the people with whom businesses deal with, the Federal Communications Commission, the Federal Trade Commission, I'm not sure that you are doing favors to researchers by saying, well, they're just like business, and we could let them, by analogy to tobacco companies. That's the reputation we want for researchers? I don't think so.
So we'll continue this conversation over lunch. Let's thank our panelists for and Bell Harbor's prepared a buffet lunch that's in the Harbor Dining Room. So as you exit the auditorium, if you go to your right, you will head to the Harbor Auditorium and go through the line and enjoy lunch. Be back here at 1:15. Wow, that was fun.
Yeah, thank you.
You did it. I was so proud of you for getting past the first question.
Gives you, and it probably isn't
Yep.
connected.
Okay, we're ready to go ahead and get started again. I hope all of you have enjoyed your lunch. And there will be snacks out during the rest of the time as well. What's going to happen next is that we are going to have two speakers and then have a panel. They'll be a little larger. The focus of these two talks are on a more contemporaneous issue in bioethics, the whole question about doing research on standard medical practices and how that looks different from research on clinical trials. And we're very fortunate to have two people who have been thinking about these issues probably longer than anybody else. And so it's really terrific to have them with us. Our first speaker is Nancy Cass. Doug introduced her before, so I may repeat a few things that have already been said, but that Nancy's at Johns Hopkins in the School of Public Health with the Berman Center for Berman Bioethics Institute. And Nancy has been thinking about research ethics issues for years, as Doug said, and it's really a pleasure to have us here. She has written a series of articles on these topics related to comparative effectiveness research, as has Steve Jaffe, and having both of them here is terrific. So Nancy.
Thank you, Ben, and thank you to everyone who has organized this conference so beautifully. It's really a pleasure to take part in something that's so well organized and, at least for me so far, has been really interesting. So what I was asked to do is spend a fair amount of time giving an introduction to a very particular case study, and it's a little bit complex, so I actually am going to spend a fair amount of time going through the background. To quote my dear friend and colleague Norm Fost, good ethics begins with good facts, and I want to take us through that so that we can get into a discussion about it together. I then end with questions that I think this particular case study raises, not only in the context of the specific case, but starting to broaden it for comparative effectiveness studies, or what some people are calling research and learning that takes place in a learning healthcare system more broadly, that I hope will feed in nicely to Steve going next. So let me give you two little disclosures here. The first is that a few of my slides about the support study were given to me by Michelle Russell Einhorn, so thanks to Michelle for sharing a couple of her slides. And secondly, I want to make clear, if it wasn't already obvious from my intro, that I'm not a pediatrician, and this is a study that took place in neonatal intensive care units. Steve is a pediatrician, Norm's a pediatrician, Ben's a pediatrician, and there will be some questions that people may have later that may be best answered by them. With that, let me go through how I plan to spend my time. So I first want to take us through what was the problem, what was the clinical problem that the support study was trying to address, how was the study itself designed, and then by the end, what were the ethics questions raised by this study, and then how does the study inform our thinking about ethics and learning healthcare more broadly. So this is the background problem. This was essentially the context when this study was planned and why the people in charge of it. And by the way, this was a study that was conducted as part of one of the NIH big networks. So therefore, there were probably, it's fair to say, hundreds of pediatricians and research staff involved in the planning of the study and the execution of the study. So here's the problem they were trying to address. Retinopathy of prematurity is a significant problem for premature babies. It's a problem that can lead to blindness or just a lot of eye damage. In the 1950s, it was found that giving premature babies higher levels of oxygen, which was at the time thought to be this really sensible idea, because premature babies are also born with some compromised lung function, and what could be bad about giving babies oxygen. It turned out that Arnold Patz, actually, somebody who was at the time, who then spent most of his career at Johns Hopkins and is credited with doing one of maybe the first randomized trial in ophthalmology, discovered back in the 50s that when you give babies more oxygen, it actually can increase the chance of these eye problems happening. So the eye problems are in and of themselves a risk of prematurity, and then giving a lot of oxygen was found in the 50s to increase that risk. By the year 2000, NICUs across the country were giving a range of oxygen to premature babies. So oxygen obviously was still being given, but there was really a wide range about how different NICUs, sometimes individual pediatricians or neonatologists, thought was the right oxygen level to give to premature babies in, I hope it goes without saying, really great NICUs with really great and experienced physicians. There were observational studies and a few smaller studies that were starting to suggest, and led to a particular hypothesis with this study, that babies were at babies at the higher end range of oxygen, who were getting a higher saturation of oxygen, were having more eye problems, and some thought that the higher oxygen was also creating other problems. So that led to a study hypothesis about whether lower levels of oxygen could decrease retinopathy of prematurity and decrease some other problems with no effect on survival. So if you look through the protocols themselves, the key study protocol and the IRB documents associated with this support study, they were essentially saying, we have a hypothesis that lower oxygen is going to be better. There's so much variation in the oxygen saturations that are given across the country, and we want to really figure out whether we can decrease these eye problems without having any other adverse impacts. So here's the way they designed the study. The kids who were eligible for the study were very premature babies. So again, if you can imagine this context, there's a woman who has been pregnant for 6 months, expecting to be pregnant for 9 months, and suddenly goes into premature labor. And these are babies who are 24 to 7 weeks old in gestation. And again, I said this is part of a national NIH-sponsored network, so there were 22 sites across the country who participated in this particular study. There were 2 studies that were actually being done. It was, for those of you study design types, a 2x2 design. I'm going to focus more on the first piece, but I'll tell you what both of these were. One of the comparisons being examined in this support study was the oxygen comparison. So the premature babies were randomized to either being in the lower saturation of oxygen group or the higher saturation of oxygen group. Again, both of these oxygen saturation levels were levels that were seen across the country, were being given across the country, but as happens in clinical trials, it was a systematic way to really study if half the babies are given one or half the babies are given another, what happens. The other piece of the study, which I'm not going to really talk about, had to do with another piece of care for babies, comparing CPAP, a mask approach to intubation and extubation versus the standard of care, which was early intubation and surfactant treatment. Coincidentally, Norm had talked about surfactant in another study earlier. So again, I'm going to spend the rest of my time really talking about the oxygen study where babies were either given the higher range or the lower range of oxygen. So the infants were randomly assigned to this lower range of oxygen saturation, 85 to 89% saturation, or the higher range, 91 to 95%. The primary outcomes were threefold, even though the first one was a combination one. So one primary outcome was what percentage of babies in these different groups get any bad outcome of these types versus not having one of the bad outcomes. In other words, how many babies get either retinopathy of prematurity or death? They also looked independently at how many babies in the 2 oxygen groups end up with retinopathy of prematurity and how many babies in each group end up dying before discharge from the hospital. The oxygen saturation levels were measured by a pulse oximeter, which is part of usual care anyway, and the physicians who participated in the study, the neonatologists who were caring for these babies and agreed to take part in the study, were told that the pulse oximeters were going to be deliberately miscalibrated up to 3%. And I'll give you a couple slides that start to illustrate that, to mask the physicians from essentially seeing that the baby was at a particular oxygen saturation, and by usual accustomed care, moving the baby to what that physician had usually done. Many physicians, my understanding, and again, the pediatricians here can correct me if I'm wrong, practiced according to a certain standard of practice. It's not unusual. And the concern was that if a pediatrician saw that a baby was at 84% and tended to often do their own babies at 92%, they would start to switch it, and the study really could never happen. So part of what the neonatologists had to agree to was an awareness that there would be some masking, again, up to 3%. So let me show you what that means. If in the study, the pulse oximeter said that the baby's saturation was 88%, the physician, if thinking about it, would know that the baby's saturation really was anywhere from 85 to 91%. Part of what that meant was that the pediatricians would not be able to determine which group the babies were in, because the groups in certain ways at the 6% level were close enough together. So that baby could have been anywhere in that range. And just as another example, if the machine showed a reading of 90%, that baby might have been in the low group with, for example, a saturation of 87%, or might have been in the higher group with a saturation of 93%. Okay, so that's the really, really brief background. What I'm now going to move to is the background. So again, we have a shared understanding on what were the issues that were raised. Because for those of you who have not been following this study, this is another one of these studies that ended up becoming a big debate with New England Journal articles, with Public Citizen, the same group that had raised the AZT, perinatal transmission challenges that Norm raised earlier, bringing some concerns about this study to the public eye as well. So what were the nature of these concerns? I want to group them into two categories, because I think they're really quite distinct from each other, and I think important to our conversation going forward. The first set of issues had to do with the adequacy of the consent form. Were parents told the right kinds of information or adequate amounts of information about the study when parents were making a decision about whether to enroll their kids? The second set of issues had to do with whether this study should have been done at all, and the ethical acceptability of the study itself. With both of these issues, a lot of questions were raised about what were the risks of the support study. Was being in the support study riskier than being a premature baby getting usual care in a NICU? And again, I guess I'll just say one more time, even though it's really obvious, this is such a high-stakes environment. This is a situation where so many kids do poorly, even though care for premature babies is so much better than it was decades ago. But the stakes are high, everybody's anxious, decisions have to be made pretty quickly, and in the context of that, a research study is being done. Okay, so I want to spend a bunch of time talking about the consent form and the consent issues, which may be arguably, at least in my personal view, are a little bit more straightforward to sort out and maybe draw some conclusions about. So let me first give you some information. So because this is a multi-site study, and this is a typical procedure for any big NIH multi-site study, there's a coordinating center. In this case, it was the University of Alabama. And the coordinating center has a bunch of organizing responsibilities, one of which is to do create a template consent form. Essentially, since the same study is going to be implemented at 22 sites, the University of Alabama was supposed to write the draft consent form that could be used by every other site. If a site wanted to modify it a little bit, that's fine, but basically, in order to make their lives easier and have some consistency, a template consent form is written, which again is typical for multi-center studies. So in the template consent form, it said, sometimes higher ranges of oxygen are used and sometimes lower ranges are used. All of them are acceptable ranges. In this part of the study, we would like to pinpoint the exact range that should be used to help prevent some of the problems that occur with premature babies, such as retinopathy of prematurity, ROP. there was no mention about death being a possible endpoint or a possible risk that the researchers were going to look for as part of the study. In the 22 sites consent forms, 16 of them said, we are trying to, the purpose of the study is to compare low range, 85 to 89% oxygen saturation levels, with high range, 91 to 95% levels, to determine if a lower range results in a decreased amount of these eye problems, with again, none of the forms mentioning death as a risk of outcome. Almost all the forms described the oxygen levels given as standard or normal. The sample form and 21 of the 22 IRB-approved consent forms described the oxygen levels as the levels given as part of standard of care within the normal range, within the range currently used, considered by some units to be the desired or best approach. 13 of the forms said, because all of the treatments proposed in the study are standard of care, there is no predictable increase in risk for your baby, or something very similar to that. And this is part of where I hope our discussion will go, both in this part and maybe in Steve's part coming next, whether this kind of study that compares the kinds of interventions that babies, in this case patients in any context, would be given, expose the participants to any increase in risk over what they would have gotten or not. So here's part of the language about the pulse oximeter. Oxygen saturation is measured on a baby with a machine called a pulse oximeter, was what it said in the consent form. It did not mention to the parents, although it did obviously quite explicitly describe this to the to the neonatologists. It did not mention to the parents that the numbers that the physicians would see was miscalibrated up to 3%. Although the template form didn't do that. 9 of the site consent forms did add that language. The individual IRBs wanted that added for the parents. So the study itself was done across the 22 centers. It was published in the New England Journal, clearly addressing a really important problem with sound methods. It was published in 2010. And here are sort of the snapshot results of the oxygen piece of the study. So as you can see, in terms of the eye damage, which is the first row, the babies in the higher oxygen level, as was hypothesized, did have a greater likelihood of having eye damage if they were in the high oxygen group, 18%, versus the low oxygen group. So low oxygen was protective to some degree against the eye damage. Unfortunately, and not consistent with the investigators' hypothesis, the higher oxygen level also was associated with a lower chance, the lower oxygen level also was associated with a higher chance of death or a lower chance of survival. So it was demonstrating that oxygen was a little protective for life, but led to much greater eye problems, double the number of eye problems, and the lower oxygen did have fewer eye problems, but that did have a little bit of a cost in terms of survival. So that was the study. So OHRP sent what's called a determination letter. A determination letter is not really something that any institution or investigator welcomes. I'm at an institution that would know. And there were 2 such letters sent to the University of Alabama. I've selected a piece that I think is going to be important for the next piece of our conversation here. But OHRP wrote in its letter, at the outset, we wish to emphasize that OHRP does not and has never questioned whether the design of the support study was ethical. It was a study that asked important questions and produced information that promises to advance both scientific knowledge and clinical care. Rather, consistent with OHRP's mission to protect human subjects of research, and this is my bolding, the overarching concern of our determination was with the adequacy of informed consent, a bedrock principle of research involving human subjects. They went on to give a footnote to describe and provide a quote from the consent forms of a comparable study that had been conducted in New Zealand. And in the New Zealand study, the language of the consent form included, the aim of this study is to determine
within the range of oxygen saturation values currently used in the treatment of preterm babies, 85 to 95%, whether targeting the lower end of the range compared to the upper end of this range, beginning within 24 hours of birth, is safe and effective in reducing serious vision and lung problems without increasing mortality or neurodevelopmental disability. OHRP went on to say, had such language been in the University of Alabama consent form, there would likely have been no OHRP finding with regard to non-disclosure of the risks relating to mortality and neurodevelopmental problems. So what OHRP was saying was, we think the study's fine, but you owed it to the families to say that you were looking both at eye problems as an outcome and death as an outcome. Okay, so after this happens, Public Citizen enters the scene. And again, you heard a little bit about Public Citizen's role in raising awareness about the AZT perinatal studies in the 1990s. Public Citizen, again, as they had with the AZT example, did a big press release. Their press release said, oxygen experiment on premature babies is highly unethical. So notice the change in language here from talking about the consent form to talking about the study. In the press release, it said, on April 10, 2013, Public Citizens Health Research Group wrote a scathing letter to Secretary of Health and Human Services, Kathleen Sebelius, condemning a highly unethical government-funded clinical trial involving 16 very premature infants. These babies were exposed to an increased risk of blindness, brain damage, and death. Without their parents being informed through the consent forms they signed of these risks or the true purpose and nature of the research. So obviously the narrative and accusations here are far more deeply reaching than something about the consent form. So I'm going to now just transition to a few of the questions that I think emerge related to this study, but much more broadly when we start to think about comparative effectiveness research, meaning research where two different approaches that are widely endorsed, widely used, widely practiced in ongoing high-quality clinical care are going to be compared to each other. And there are so many examples of comparative effectiveness questions. Some of them, and I have a little bit more on this, some of them are very similar kinds of interventions, like the VA right now is planning this enormous study to compare two widely used hypertension medications, both of which have been FDA approved since the 1960s, but nobody's ever compared blood pressure medicine A to blood pressure medicine B. There are other kinds of trials that compare different interventions for the same health problem, like back surgery to physical therapy, where the stakes are quite different. But in the large sense, there's an extraordinary large new investment in research that's comparing standard of care interventions. Again, comparing interventions that good doctors all endorse, but if you go to one doctor, they might recommend one, and if you go to another good doctor, they'll recommend another. Okay, so here are the kinds of questions that I think the support study highlights for this body of research. One is, how should we explain the risks to parents, to people entering the blood pressure study, to people entering the back pain study? Should we explain the risks of the study and all of the procedures, including the risks of clinical care? Or should we really focus on the risks that are unique to joining the study, the risks of the pieces that are experimental or that are different from what the patient might have received in standard clinical care? And in relation to clinical care, or as if the patient would have been doing the study versus receiving no care. So in other words, do we say to the parents, here are the risks that we think exist in the support study from being randomized to one of these two arms, compared to the risks that your baby faces by being a premature baby and are trying to give him or her the best care that we can in the NICU, that, by the way, also carry a lot of risks? Or do they say, here are the risks of being in the study. The risks of being in the study include blindness and death. And while in certain ways it may sound silly to emphasize it that way, these are actually really important issues for IRBs to take on, and I think IRBs are not unified in the answer to that question. So this is highlighting a little bit more of the same thing. So how do we talk about risk in comparative effectiveness studies more broadly? The additional risk, to some degree, comes through the randomization. There is a view that I think many of us have that individualized care is going to be better and higher quality and more protective for our baby, for ourselves, than being in the study. We carry a view that is a nice view, it's a protective view, it's a trusting view, and is sometimes an accurate view, but often not, that my doctor knows what's best for me more than a computer does. And if we have a couple of options available to us that, again, are widely endorsed in the community but happen to be different, like lower oxygen versus higher oxygen, or again, different medicines, different approaches, etc., most of us go to our doctors with whom we have a relationship, assuming that because the doctor knows our personal medical history or our personal values, they're going to recommend something so that, on average, we're going to do better if we go with the individualized doctor recommendation than if we're in this study that's sort of randomly assigning us in a haphazard way, as if they couldn't care less, to the low oxygen versus the high oxygen. It's a really logical deduction. Unfortunately, it turns out to not be true. And it's not true for all sorts of reasons that I don't really have time to go into here, but a lot of the random variation that happens in medical care, there obviously are many cases where care is very individualized, and that's really important and really protective. But there are also lots of times where the random variation in care is based on where somebody was trained, what medicine they were first told would be the right medicine to go with for hypertension, the way oxygen saturation is done at the place where they did their residency, the norms of other people in their unit. And it turns out that the random variation has more to do with factors associated with the physician than factors associated with the patient. So how do we explain these additional risks of being in the study when there is so much random variation in patient care, in high quality patient care? So again, on the one hand, it's easy and straightforward to say, one thing that's really different about being in this study from being in the care of your individual neonatologist is that the care selected for you is randomly selected by a computer. It's the part where we get to the implications of that that becomes so difficult to figure out. Again, it's easy to say both of the approaches are used standardly. They're used in NICUs across the country. They're probably all used in the 22 NICUs represented in the study. But is it important to then say, and by the way, there's an extraordinary amount of individual random allocation of care that happens in ongoing clinical care. We're really not sure whether the risk to your child is any greater from being in the study or from getting whatever care the neonatologist on duty the day that your baby's born is going to assign it, is going to decide it. The other piece of the discussion that I think is really important to bring into the conversation as we move into a broader discussion about consent and disclosure and randomized comparative effectiveness studies is that we will sometimes have a context like the blood pressure study where it's sort of hard to imagine a patient having what I will call a meaningful preference between blood pressure medicine A and blood pressure medicine B, assuming that they have a similar side effect profile, they're both taken once a day, etc. There are going to be other things where most of us would have a lot of preferences. There are people who are more willing to go to surgery as a first option, people much less willing to go to surgery. I think we all could appreciate on what I'll call a gut intuitive level that if we were being asked to, if there was a randomized comparative effectiveness study of back surgery versus physical therapy, we would want to be involved in that conversation with a lot of information, but other kinds of situations with blood pressure studies might pose a different example. You may still want to know about it, but at least it doesn't rise to the same level of what I'll call a meaningful, important difference to the values of the patient, where discussion becomes particularly important. Does it matter, and how relevant is it to the consent process that clinicians often don't describe these meaningful trade-offs or offer choices in practice? So some people respond by saying, well, that's a problem with clinical care and we need to improve it, and that may be the right answer. But it does become complicated, and the messaging and implication with patients becomes complicated when we start to spend, for example, much more time in a support study, in a study like the support study, talking about the risks of blindness and death than potentially some neonatologists do when they're deciding what oxygen saturation level to give to a baby. So, should research be held to a higher standard of disclosure even when the risks in the aggregate are similar? And then what, if anything, was problematic in this study? I guess I'll maybe just start the conversation by saying that I think most people who have weighed in on this support study, and as I mentioned earlier, there was a letter to the New England Journal essentially more supportive of OHRP's action, and a letter to the New England Journal more concerned about OHRP's action, each of which was signed by probably at least 50 people in the bioethics and pediatrics communities. Nonetheless, I think almost everybody on what I'll call both sides of pieces of the debate agreed that the consent form could have been better, and had the New Zealand consent form been used, it would have been better, et cetera. So I think that piece is not really controversial. I think the pieces that become controversial are much more, what do we say to people about the risks, and how much do we emphasize the risks of the study in general, or how much do we contextualize the risks of the study in relation to what goes on in clinical care and what the baby would have been exposed to in clinical care. So implications for comparative effectiveness research going forward. Millions of dollars are being invested in comparative effectiveness research. It's part of Obamacare. There's this huge new institute in Washington, the Patient-Centered Outcomes Research Institute, whose almost entire mission is to comparative effectiveness research, because it's so important as patients that we learn what treatments work and what treatments don't. Are these trials any riskier than clinical care, or are they not? And in the ethics community, it's our job to think about how we message the risks of clinical research. Some clinical research is really dicey, and it's our job to make sure patients know that. And other clinical research is less dicey, and it's also our job to make sure people can sort of separate the wheat from the chaff. How should they be explained, and what honestly and ethically is the right message? So I'm going to stop with that and then maybe turn it over to Steve. Thanks.
Thank you, Nancy. Again, we'll have a chance for the panel after Steve and Nancy's talks to ask them questions. We'll also be inviting Norm and Lainey back to join them, which will make for a lot of fun as well. But let me introduce Steve Jaffe very briefly. You heard about him this morning. You heard him speak. Steve is the vice chair in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He's also the director of their fellowship program. Steve has been involved in a wide range of issues related to human subjects research, and he's just completing a term on the Secretary's Advisory Committee on Human Research Protection. So let me turn it over to Steve.
Thank you, Ben. This has really been a great morning and early afternoon so far, and I'm looking forward to the rest of the conference. I'm going to sort of picking up or maybe go in a slightly different direction from Nancy's talk, talking a little bit about learning healthcare systems, and then talking about the Children's Oncology Group and more broadly about pediatric oncology as a potential model, both a positive and in some ways a cautionary model for the notion of a learning healthcare system. Let me just mention disclosures, no financial disclosures, no off-label or investigational uses of drugs, but I am, as chair of the Bioethics Committee for the Children's Oncology Group, I do receive some salary support from the COG through my institution for that role. So that's my one relevant disclosure. So what I'm hoping to achieve, as I mentioned, is to talk about pediatric oncology as a model for learning healthcare systems, and then again to talk about the promises and the pitfalls of systemically or systematically integrating research into clinical care. The vision of the learning healthcare system, as I will describe, envisions the systematic integration of research with care And that is touted as something that we should be seeking, and I'm going to endorse that as something we should be seeking, but with a couple of cautionary notes. So just to say, you've heard this talk, learning healthcare system. What do we mean by a learning healthcare system? Well, this really got started or maybe got catapulted forward as a notion and a vision by a committee from the Institute of Medicine at the first workshop publication back in 2007, where they defined a learning healthcare system, or perhaps described it, as a system in which, quote, knowledge generation is so embedded into the core of the practice of medicine that it is a natural outgrowth and product of the healthcare delivery process and leads to continual improvement in care. And what I want you to notice in this definition is that there's a certain virtuous circle to this, right? So knowledge is an outgrowth and product of delivering healthcare. Care leads to knowledge, and knowledge leads to improved care. So we're constantly improving care, learning, and using that knowledge to further improve care. What are the desiderata? And again, this comes from the Institute of Medicine Committee. What are the things we look for in an ideal learning healthcare system? And they, I'm paraphrasing their language here a little bit, but they outlined 12 things, most of which are really implicit in the definition or means to get to the definition that you saw on the last slide. So continuous learning, of course, that follows. Coordination of efforts related to the generation, assessment, and use of new knowledge. Who in the room thinks that efforts related to the generation, assessment, and use of new knowledge are well coordinated in the American healthcare system today? All right. Nobody's raising their hands. I didn't expect you to. So the vision is we can do better. We can coordinate things in a way that gets us to where we want to go, that gets us to improve care much more quickly. A vision of much broader engagement of stakeholders in a culture of a shared responsibility for improved care, shared responsibility for expanded and enhanced knowledge. And stakeholders here means everybody you can think of who's got a stake in it, all of us as patients, those of us who are clinicians and healthcare providers, who are involved in research, who are involved in the administration of healthcare, et cetera. Integration of research with the practice environment. So let's not think of research as this thing that happens over here, practice as the thing that happens over here. Let's integrate them in the same setting. Let's do them together. Let's bring them together. Clinical decision support systems. This is now thinking more in terms of what healthcare systems can do. The idea is that individual providers and clinicians can't have all the facts at their fingertips to make good decisions, and in fact, to align people to do things consistently and coherently, you need electronic decision support in order to motivate that. Much of this vision, by the way, is made possible by the tremendous advances in information technology, and that's a theme that you will see through here. Universal electronic healthcare records as a way of capturing the data that we need to learn, tools for linking, mining, and using those data. The vision, and this is less technical and more a vision of clinical data as a public good. I think very often we think of clinical data as a private good, and there I mean private in the sense of belonging to the healthcare system or the individual provider on the one hand, and on the other hand, obviously belonging to the patient. And if these are private data, then they can't be used for public goods, for public purposes. So this is not to say that everybody's identified healthcare records should be available on the web for anybody to download, but the vision that these data should be used for public good purposes. We should be encouraging both the development of evidence in practice and the use of evidence in practice. As you all know, our practice is not nearly as evidence-based now as it could be. Engaging the public about the nature of evidence, the development of evidence, and the roles of the various parties in that development and use of evidence. And you heard from the panel this morning that public engagement, greater transparency, greater shared understanding of how data are used, how evidence is developed is something that we all should be seeking. Vision of the learning healthcare system as a trusted scientific broker, and then of course leadership to both outline the vision where we want to go and then define the strategies for how we're going to get there. So these are some blue sky ideas of what we should be seeking as we try to develop and implement learning healthcare systems. So can pediatric oncology serve as a model for the learning healthcare system? So you haven't, Nancy didn't talk explicitly about the very important work that she and her colleagues at Hopkins and elsewhere did with a couple of seminal publications in the Hastings Center report early last year, but they advocated in one publication the development of a learning healthcare system and the development of a set of ethics and norms for learning activities within learning healthcare systems, and then separately talked about the question of whether we should be so clearly separating research from practice as we, at least some people conceptually do today. And they held in this publication pediatric oncology as a paradigmatic example of a learning healthcare system that might provide a model for where we might want to go. And I'm going to spend the rest of my time talking about that notion. So quoting from their paper, consider the example of pediatric oncology in which virtually all patients are enrolled in clinical trials, and enrollment in the trial is considered to be a standard of care. The practice context is constructed to bring the most pertinent forms of scientific understanding to bear on clinical care. Think again of that virtuous circle that I mentioned. Bring scientific understanding to bear on clinical care, and clinical care generates new knowledge, again, the other half of the circle. Generating and using generalizable knowledge can be a deliberate and integrated aspect or part of practice, not a set of maneuvers logically distinct from it. And their view is that pediatric oncology is an example or a role model that the rest of healthcare can follow in developing a learning healthcare system. So this is the website of the Children's Oncology Group. Much of it is publicly available. You can go to it, you can look around. There's the citation down at the bottom, or the web address. It's a group. This just shows the continental US and a few of the Canadian sites. It's actually in a number of other countries as well: Australia, New Zealand, the Netherlands, I think Switzerland. There's some sites in Switzerland, a number of sites in Canada that aren't shown here. So there are about 220 sites in the Children's Oncology Group. Small to read that. The Children's Oncology Group is the world's largest organization developing, too small from here to read it, but COG unites more than 8,000 experts in childhood cancer at more than 220 leading centers in the fight against childhood cancer. Today, more than 90% of 14,000 children and adolescents diagnosed with cancer each year in the United States are cared for at Children's Oncology Group member institutions. It's not to say that they are cared for on trials or that they enroll on trials, but they are taken care of at those institutions where the trials are offered and where the clinicians are members of the COG. The history of the group goes way back to the 1950s. So the chemotherapy for cancer, with childhood leukemia being one of the first examples, goes back to the late 1940s. By 1955, Sidney Farber, working with Mary Lasker, who later had a really important role in encouraging Richard Nixon to declare war on cancer, started something called the Children's Cancer Group. And this was the precursor to not just pediatric oncology groups, but really all of the cooperative groups that have really transformed cancer care in the United States. This first publication was in 1960, comparison of 6-MP, a drug that's still widely used for pediatric leukemia, with a combination of 6-MP and another drug in the treatment of acute leukemia in children. So within just a few years, they had their first publications out. If I remember correctly, there were about 12 sites involved in this study and a couple of hundred kids. I just had to show this. This is the main results figure from the paper, and what is so striking about this is it's hand-drawn. When was the last time you saw a hand-drawn paper or hand-drawn figure in a major medical journal? It's just gorgeous, and look at the quality of the writing there at the bottom. You just would not see that kind of penmanship today. Yeah, right, like what doctor writes like that? By the late 1960s, a second group had sprung up. This one focused on kidney cancer, Wilms tumor, National Wilms Tumor Study Group, NWTSG, or affectionately known by those in the field as NITWITS. A couple of years later, another disease-focused group, the Rhabdomyosarcoma Study Group. In 1978, another group got started. This was a pediatric spin-off of an adult group, now called the Pediatric Oncology Group. And then in 2000, all four of these groups merged into a single group, which figured it could have economies of scale and many other reasons for synergy in collapsing into a single group. And so since about 2000, we've had just the Children's Oncology Group. How is this group supported? Well, it's supported with substantial funds, mostly from federal dollars. So there's a little over $50 million, I think these were 2013 numbers, in NCI funds. And this is just to build the infrastructure to carry out the studies. Two main grants, one, the CHAIRS grant. The CHAIR is currently at Children's Hospital of Philadelphia for about $25 million a year, and then the Operations Center grant, which pays for the data management, the IT, the statisticians, the analytic capability, those sorts of things, at about $24 million a year. There's a separate grant for the Phase 1 Trials Consortium, which involves a subset of COG sites. That's about $2 million a year. I was actually surprised that it was that small when I learned that. And then in the last year that was reported, there were about $6 million a year in foundation support from a particular foundation that has dedicated its fundraising to the COG. And then there's lots of other smaller funding that comes in for specific projects, for things that supplement the activities of the COG. So it's a substantial operation, at least $60 million a year to keep it going. So I want you to think about how it affects the experience and the care of a child who's diagnosed with cancer. First, you've already seen that about 90% of US children receive care at a COG site. So already there's sort of COG in the air and in the water at the places where they're getting care. One of the first things that will happen when a child comes to one of these institutions with a new diagnosis of cancer is that they and their family will be invited to participate in something called the Childhood Cancer Research Network, which is a registry. And if they agree to this, there are two components to this, which they can agree to one or both. The first is they will agree to provide their name and social security number to the COG. Or if they don't agree to this, then the name and social security number are kept at the institution, and the COG only gets a study ID number. They never know the identifiers. But if they agree, then their name and social security number will be provided to the COG, which creates a registry which now has something like 50,000 kids over the past 7 or 8 years who have been treated at COG institutions and whose families have agreed to provide this information. And then the second thing that they can agree to is future recontact, so that, for example, if an epidemiologist wants to do a study on the causation of childhood cancer, the epidemiologist can contact their family directly without having to go through the COG member institution. Again, of course, if they've given permission. And I don't have updated numbers, but from a pilot study that they did through 2006, you can see that virtually all families, 96% of families, agreed to provide their contact information and to future contact. So that gives you a sense that there's a fairly substantial amount of support, at least for these observational and registry functions of the COG. Second, depending upon the eligibility of the child, their final diagnosis, what studies are available, they may be invited actually to participate in a number of different studies. They may be invited to participate in a biology study where a residual piece of their tumor is given to a research lab to better understand biology. They may be invited to participate in an intervention study, a clinical trial. There may be supportive care studies either at the time or later. And then there are often studies of various psychosocial outcomes. So there may be not just a single clinical trial, but a number of studies, and families will have choices about what to participate in. And one of the things I want to suggest, and I'll say more about this later, is that the COG, the fact that COG exists and helps transform these institutions or the pediatric oncology programs within these institutions into learning healthcare systems really transforms the care and experience, not just of those children who participate in the trials, but also those who don't participate in the trials. And this is one of the most important ways, I think, where COG helps to turn pediatric oncology into a learning healthcare system. So what have the groups accomplished over their almost 60-year history? Well, let me just to orient you to this slide. This is focusing on the black line. This is mortality from childhood cancer from 1975 to 2010 in a publication that just came out a couple of months ago. And what you can see is that mortality has basically dropped in half over that 35-year period. Now, so from 5 deaths per 100,000 children, this is age adjusted, to about under 2.5. Now, I don't want to suggest for a moment that COG or its predecessor organizations can claim all the credit for this. There are lots of good things that have happened in the world of care for children with cancer that also share the credit, but I strongly suspect that had there not been cooperative groups, we would not have seen a drop this dramatic. And the red line, axis being here, estimates the number of deaths averted in each year by virtue of these changes in mortality. So the estimates of these authors, Malcolm Smith from NCI and others, suggest that up to about 2,500 deaths of children a year are averted because of these improvements in mortality. Again, it's hard to say how much of that is attributable to the COG and its predecessors, but surely some of it is. Here's the story for acute lymphoblastic leukemia for those of you who are used to looking at survival curves. The bottom survival curve shows survival for kids who were diagnosed in the late 1960s, almost essentially uniformly a fatal disease at that point. Up here are the survival curves. This is even in the 1990s, so almost 20 years ago. And you can see that the vast majority of kids are survivors, although there is still some work to be done even today. So I want you to think about if at least some of these changes that I've shown you on the last 2 slides are due to the Children's Oncology Group, in what ways might something like the group improve outcomes for children with cancer? And I want to suggest that there's a number of potential pathways we need to think about. The first of them is we do trials, we do biology studies, we do other kinds of experiments to try to understand the biology of cancer, how to treat cancer better. We learn something and we apply that knowledge to the next generation of kids, and over time, treatment gets better, outcomes get better. I think that's uncontroversial. I won't say more about it because it seems obvious that at least part of the improvements that we've seen must have been due to that kind of, you learn something and you carry it forward. So that's got to be one of the pathways. Second pathway, and this I think is more controversial, I'll say more about it, is the possibility that actually just being in a trial is associated with an improved outcome, what has been called the trial effect. This is actually widely endorsed or believed by leaders in the oncology field. What I'm showing you here is from the National Comprehensive Cancer Network, the NCCN. It's an organization that brings together major cancer centers, mostly with an adult focus, but with a little bit of a pediatric focus as well. This happens to be their breast cancer brochure available for patients on the web, but the same language is repeated in every patient-oriented brochure and actually even every clinician-oriented practice guideline. Joining a clinical trial has benefits. First, you'll have access to the most current cancer care. Second, you will receive the best management of care. So not the most straightforward statement of the trial effect you'll ever see, but implicitly there's the idea that the optimal treatment for you is being in a clinical trial. And this is widely held among leaders in oncology. I actually think it's not quite so clear that this is the case. I'm certainly not suggesting that clinical trials are, in the aggregate, associated with worse outcomes. I'm quite confident that they are not, but I'm not so sure that they're actually associated with better outcomes. So this is actually an article from investigators here at Seattle Children's, published in Archives of Pediatrics and Adolescent Medicine just a few years ago. And what they did was they looked back at kids with acute lymphoblastic leukemia, the most common type of childhood cancer, treated at Seattle Children, about 320 kids, about half of whom, if I remember correctly, had been treated on a COG or predecessor organization trial, about half of whom had not. And they compared their outcomes. And of course, this is not a randomized trial, and so there's the potential for selection biases that might affect the results one way or the other. But here's the survival curves of the two groups. And if you can see a difference between them, you've got much better eyes than I do. Really very comparable survivals. And there are studies out there that suggest that there may be improvements or better outcomes among kids or patients in general on clinical trials. There are studies out there that suggest that there are no differences. In the aggregate, I think this is a very hard literature to read because it's so difficult to compare outcomes when you've got non-randomized groups. And so there may be all kinds of selection biases that make those in trials different from those out of trials. But this is one article, at least in the Pediatric Oncology Group, fairly recent, that suggests that there may not be differences. Again, outcomes not worse. The most interesting one to think about, I think, is the possibility that there may be benefits of the infrastructure that the COG puts in place at all of these institutions that accrue to children whether they're on a trial or whether they're at the institution but not on a trial. And so I want to think about how this might happen. So one may be that by virtue of having a research organization, a research infrastructure embedded in the practice, we help to create a culture of evidence-based medicine. Think back to the desiderata that I mentioned earlier for a learning healthcare system. So we might be able to use this as a way to standardize practice in accordance with the evidence. In a letter to the editors of the Journal of National Cancer Institute about 10 years ago, a group of leaders in pediatric oncology wrote, "The state-of-the-art treatment for a child with cancer derives from the best therapy identified in prior clinical trials. The standard arms of clinical research protocols serve as de facto practice guidelines, and newly diagnosed children can receive the state-of-the-art standard therapy whether or not they enroll in a clinical trial." The idea here is we have these practice guidelines out there. They happen to sit within research protocols, but if for some reason a child does not enroll, if their family decides not to enroll, or if there's some other reason, that practice guideline, that standard arm as described in that protocol, is still available to guide their treatment, and that turns out to be a good thing, sort of allowing practice to coalesce around evidence-based standard care. Another way, more than beyond the fact that the standard arms are out there as described in protocols, is that they might raise the standards of practice, the standards of quality, the standards of adherence to sort of practice guidelines across the board by encouraging adherence to protocols and to treatment plans. Remember that if you're an investigator and you have a patient on a clinical trial, that patient's, the care that you provided that patient is going to be audited by the trial group. And this is true, frankly, whether it's COG or industry or any other group. And so you're used to practicing in a way that you realize that your practice may be scrutinized. And so you're going to practice in a certain way, and it's unlikely that you're only going to practice in that way for the patients on the trial, and you're going to be much more sloppy for the patients who are off the trial. So encouraging this kind of adherence, this kind of accountability for the details and the quality of your practice may be something that groups do that then spills over to the care that individual clinicians provide to patients even outside of trials. I think these groups also educate clinicians about disease and treatment. The protocols really kind of double as educational interventions. When I was a fellow in pediatric oncology, and I was seeing a patient with a disease that I hadn't seen before, often my attendings would say to me, well, if you want a sort of quick way of understanding the history of the disease, its treatment, its biology, the history of trials, go to the protocol and read the background section, right? I see a pediatric oncology fellow here nodding in the third row. So this is, the evidence is there, and I think it's not just for fellows, but for experienced attending physicians who can read these background sections of the protocols and read the protocols and really learn a great deal about the therapies and about the disease. So these play an educational role. Also, of course, the communication among clinicians at the national meetings, through trial groups, in lots of ways, facilitates a kind of interaction and sharing of information that you might not get without this. And this is true, I think, not only within the discipline of pediatric oncology, but also across disciplines. If you think about what you need to take care of a kid with cancer, you need more than just pediatric oncologists. You need surgeons, you need radiation oncologists, neurologists, particularly for kids with brain tumors, pathologists, radiologists. You're dependent upon all these other specialties in order to take good multidisciplinary care of these kids. And then, of course, you're dependent upon really good nursing, upon really good and specialized pharmacy, on psychology and social work, and just a whole range of disciplines that are needed to take care of these kids. And the group is a way of facilitating interaction, communication, mutual education, et cetera. And finally, the group actually turns out to be a really good way to engage patients and families as advocates and also as teachers for all of us who provide care to these patients. There's a very active patient advocacy, parent advocacy group within the COG, and they really are, they participate in discipline committees, they participate in clinical trials committees, many things about both policy and practice and trials. We seek their input, and I think that makes the whole process and the outcomes better. So it's a way of creating, of bringing patients and families in as stakeholders, as advocates, and as achieving some of the goals of the learning healthcare system that we've talked about. So this is all great, right? I'm telling you this kumbaya story about all of the virtues of the group. Is there a downside? And I want to suggest that we do have to be careful, although mostly I think the news and the message really is a good one. This is an article I published with my mentor, Jane Weeks, near the beginning of my career, looking at how American oncologists think about the purposes of clinical trials, 2002 in the Journal of the National Cancer Institute. What we did in this was we identified a sample, a nationally representative sample of medical, meaning adult, pediatric, and other oncology specialists to assess their views about the purposes of cancer trials. We sent surveys to about 1,100 physicians. We got about half of them back, actually more than half among the pediatric oncology stratum, because pediatric oncologists are so good. And we asked them two questions. One is, when you offer a clinical trial to an individual patient, why do you offer that patient that trial? And we offered a series of closed-ended responses and asked them to rank those responses. And second, now thinking about the main societal purposes of clinical trials, why are clinical trials performed from a societal point of view? And we asked them to think about those two things separately. So when asked the individual patient question, most, here we have in red the pediatric oncologists and in blue the medical oncologists. I'm leaving the third group of other oncologists off the slide. Most of them said to thinking about the pediatric oncologists, most of them, over 60%, said, I offer my patients participation in clinical trials in order to offer them state-of-the-art treatment. And a smaller group, about 35%, said, I offer them enrollment because I'm hoping to improve treatment for future cancer patients. Now, to me, the answer to this question is not straightforward, and I would not want to criticize any clinician who offered a clinical trial to a patient believing that that clinical trial offered state-of-the-art treatment. You might look at one trial and say it's a more reasonable judgment in that case and a less reasonable judgment in that case, but across the board, I wouldn't want to criticize this as a false view among these pediatric oncologists, and actually among about 40% of the adult oncologists as well. Reasonable position to hold in many cases. I think more interesting is when we ask them, what are the main societal purposes of clinical trials? And here, focusing on the pediatric oncologists, about 60% said, I believe the main societal purpose is to improve the treatment of future patients. This is the answer I would give where I asked this question. But about 40% of the pediatric oncologists and about 20% of the adult oncologists said, I believe that the main societal purpose of clinical trials is to ensure that participants get state-of-the-art treatment. And this, I think, is a challenging and problematic answer because, as we've been talking about this morning, my view is that we do clinical trials in order to learn something that we take forward. And any benefits, they may well have benefits for the people who take part, but in some sense, they're side benefits. The purpose of the trial, as expressed in the protocol, as expressed in the specific aims of the study, are to answer whatever the study's question is. So many of you have probably heard the term therapeutic misconceptions, and the cautionary message I want to leave you with is that systematically integrating research with care, while I endorse it completely, and I think we should be doing more of it, may foster therapeutic misconceptions, and we need to be just a little careful about that and a little conscientious about that. What is a therapeutic misconception? Well, my favorite definition comes from the National Bioethics Advisory Commission, which said the therapeutic misconception is the belief that the purpose of a clinical trial is to benefit the individual patient rather than to gather data for the purpose of contributing to scientific knowledge. Now, I think this is much less problematic with observational research. There's not much in the way of negative consequences from this. And maybe, and this gets to Nancy's talk, maybe we should worry about this less when we're talking about comparative effectiveness research. The VA compares two widely used antihypertensives. I don't think the stakes are all that high for avoiding therapeutic misconceptions, although even there, I think in our minds, we should have clarity about what we're doing. But I do think it's a serious concern when you're doing the kind of research that's high risk, the kind of research that tests very novel interventions, the kind of research that incorporates non-therapeutic research procedures like extra scans, biopsies, that sort of thing. And so I think depending upon the kind of research that you're doing, we may have to worry more or less about therapeutic misconceptions. And the kind of research that the Children's Oncology Group or that pediatric oncologists tend to do tends to be more in this latter category. It does incorporate non-therapeutic procedures. It does test novel interventions. It's the kind where I do think we want to avoid therapeutic misconceptions. So in the last few minutes, how well does the COG achieve the aims, the desiderata of a learning healthcare system? Well, the first thing to just be clear about is that it is not a conventional learning healthcare system because it's not a healthcare system, right? It mediates, just to jump to the bottom and then jump back up to the top, its activities are mediated through the healthcare systems at which patients get their care. So the COG, at least as of this date, is not integrated with the electronic medical records of these healthcare systems. The data capture is separate. Obviously, the COG has no authority over the clinician's actions. That authority is held by the institutional representatives, the institutional leaders. And there's very little, although I wouldn't say no, direct interaction between the COG itself and patients and families. It's all mediated through individuals who are on the ground at the healthcare systems where they get their care. And also, as I suggested a moment ago, the COG, if you think about a learning healthcare system as something that is going to focus on comparative effectiveness research and observational research and quality improvement type learning, the COG is not mostly that. It's more an institution that focuses on novel interventions and on understanding the biology of disease, is really its emphasis. So it's not a conventional healthcare system, and it doesn't really have the kind of emphasis that a learning healthcare system would have, but nonetheless, I think it has some lessons for us. So I think it does achieve many of the aims of a learning healthcare system. Learning really is continuous. Studies are done, and what is learned from those studies is fed right back into the next generation of studies and through that vehicle into the care that patients receive. And there's also wide dissemination both within the group and beyond of all of that information. So I think very successful in that regard. Efforts related to the generation, assessment, and use of new knowledge, I think, are quite a bit more coordinated in a setting like the COG than they are in the healthcare system in general. I think the group has done a pretty good job of engaging stakeholders in a culture of shared responsibility, as the Institute of Medicine set out, although there's always room to do better in this regard. Research really is integrated with the practice environment. I think there's almost no specialty in American medicine where clinicians, providers move so fluidly and rapidly between research and the ordinary clinical care that they deliver. Clinical decision support systems, no, but that's because that's not their mission. Universal electronic healthcare records, no. Tools for database linkage, mining, and use. Well, to the extent that the databases are there, I think we could do better with the tools. Clinical data is a public good. We're getting there. I think there's a lot more ability to use these data for more public purposes. Certainly, the group encourages both the development and the use of evidence in practice. The public is engaged, although this is another place where there's room to do more. I don't think there's any doubt that the COG is a trusted scientific broker, and the COG clearly provides leadership in this regard. Now, why have the groups been so successful? My second to last slide. Well, first of all, it helps to have a 60-year history and a 60-year history of success and achievement behind you. Second, the fact that the clinical community is so small really helps to foster cooperation. Third, as I've alluded to, pediatricians are good people. Quite serious about that. That's why they responded so well to my survey. Fourth, virtually all the care in pediatric oncology is provided at academic centers. Fifth, there's very little, pediatric oncology is not a big money field, it's a small market. There's very little incentive either to the providers or to drug companies and other players to encourage variation in care driven by finances. Six, given the rarity of childhood cancer, there's a view that every patient is a precious and critical resource for research, something that in adult oncology with 100 or more times more patients, if this patient doesn't sign up for the study, another one will. And finally, you've seen that the NCI has really committed substantial funding over many years, and none of this would be possible without the kind of money that's been put into making this happen. So to summarize, I think integrating research with care can provide outcomes for both current patients and future patients. The vision of the learning healthcare system is a good one, and we should pursue it. Integrating research with care can also obscure or cause us to forget about some important differences, and we just need to be conscientious about that. And we really should mind the lessons of pediatric oncology as we seek to develop learning healthcare systems, and I think equally important or more important, learning healthcare cultures. Thank you.
Okay, thank you, Steve. We're going to have a panel now, and so I want to invite Nancy Cass as well as Lenny Ross and Norm Fost to come back up here for the panel. And again, we're going to start with questions from the audience, so please find your way to the microphones if you have questions, and if not, I'll start with the first question myself, but we'll... You're allowed to ask questions too. So Norm asked me if he's allowed to ask a question, so what can I say? Of course, Norm. So, so Norm, if you have a question?
Well, I had a comment on Nancy's talk and a question for Steve. I agree with you that pediatricians are good people. I have a conflict of interest. It's the main reason I went into pediatrics. They just seem much more fun people to work with than everybody else. But I'm slightly skeptical about your claim about the lack of financial incentives, or at least career incentives. I mean, pediatricians are humans also, and their careers depend on recruiting oncologists. Their careers depend on recruiting patients in their trials. And I've certainly seen in my own world pressure and distortion and so on, overselling, and a refusal to let go. That is, patients who are recruited into a trial, which it's not going well, particularly I'm thinking of more bone marrow transplant studies, in which the oncologist is almost alone in thinking, oh, success is just around the corner. Do you think I'm off on any of that? And second, I wanted to ask you, there's been a lot of profiteering in adult oncology of selling drugs in offices at an unreasonable profit. Does that not happen at all in pediatrics?
So on the first one, so there certainly are career incentives. I don't doubt that at all. Incentives to enroll in trials, incentives to complete trials, all of that. All of that is to be sort of guarded against or moderated to make sure that in the context of all of that, we do the right thing for patients and for kids. My point is none of that sort of cuts away from the mission of a group like the COG. In other words, in many ways, it's aligned with the mission. Enrolling kids in studies is aligned with the mission of the COG. The point is not to get overzealous about it. I think there are not the financial incentives, and you're right, medical oncology in private practice, most of their income is made from the upcharges on drugs. At least that was historically true. There have been some changes in Medicare that have sort of cut into that a bit. I don't believe that that is an issue in pediatric oncology. I think most of the income is made from the billing for clinician time, procedures, hospital time, those sorts of things. But there may be others in the room who are more savvy about the business of pediatric oncology who can speak to that better than I.
Okay, let me go into the in the center aisle, please.
Hi, I'm Gary Walco from Seattle Children's. This is a question directed principally at Dr. Jaffe. About 10 years ago, we published a study in the Journal of Pediatric Hematology Oncology where we had gone back and interviewed parents of children who were participating in COG studies to better understand their reaction and comprehension of the whole informed consent process. And literally about 85 to 90% of the parents had absolutely no clue that they were giving consent for their child to participate in a clinical trial. They basically thought they were giving consent for treatment. And obviously when somebody sits down and says your child has leukemia, you don't hear too much after that. And there were a lot of recommendations that we made in that paper about how to improve the informed consent process. Just curious to know what COG has done in the past decade to foster that partnership better with parents to really make it more of the kind of model that you're talking about where everybody's moving in the same direction.
Well, I guess the first thing I would say is it's still far from perfect. I think pediatric leukemia in particular, and other diseases where kids present acutely ill in the inpatient setting and decisions have to be made in a very short period of time under an incredible amount of sort of emotional crisis and trauma, is a particularly difficult setting to sort of seek the ideal in informed consent, seek what we're all looking for. I think it's in the same way, if you're a couple or a woman who's just delivered a 24-week preemie, that's not the optimal time to be doing this either. Some of the things that COG has done and that pediatric oncologists have done in general, one, I think there's a much greater consciousness. One of the things I called for in my remarks a few minutes ago is sort of mental consciousness of the research treatment distinction and just an awareness of the complicated role of being an investigator. And my sense, I could be wrong about this, is that what I see today is significantly better than what I saw when I was a fellow 15, 18 years ago. More systematically, none of that is a sort of satisfactory systematic answer to your question. One of the things that the COG has done, and it's turned out to be an incredibly difficult thing to do because of resistance from many local IRBs, is to write consent forms that instead of being 30 pages that just mix up all of the treatment stuff with all of the research stuff, and so you have to be incredibly sophisticated and have a great deal of time on your hands to figure out what's what, is to write a consent form that says, this is what the research is about, these are the risks of the research. Okay, now we're done talking about the research. These are the risks of all of the standard treatment for your leukemia. Here's all the stuff that you should know because you're also consenting for treatment and you also should understand your kid's disease and all of the stuff that even if your kid weren't on a clinical trial, you should know. But we really want to pull out and talk about the stuff that is really about the research because otherwise you're going to have to dig through 30 pages to figure it out yourself when you were just told yesterday that your kid's got a life-threatening disease. So the group has tried to do that and still tries to write their model consent forms in that way. Many IRBs actually give investigators a hard time with that and will say, no, we don't want you to distinguish between the research and the treatment risks, for example, because we think people need to know all of that. So it hasn't been easy, but the group is trying. So I think it's culture, it's consciousness raising, it's discussions at group meetings, and it is writing consent forms in a way that's much easier for people to follow and understand the issues.
Thank you.
But thanks for your questions. Great question.
Yes, sure.
About that too. So I agree with everything Steve said about how much better we all could be with regard to informed consent. I guess the piece I want to pick up on, both from this question and building on what Steve said in his talk, is how to think about explaining this idea of integrated research and care to families. And so much of research ethics and informed consent, and I've very much been part of this narrative, has been built on the importance of separating them and being clear that everybody understands what part is care and what part is research. And there's a lot of that I personally still really believe in and believe in the importance of. But I feel like there's both, that somehow we neglect a really important and honest piece of the picture if we don't expressly also talk about the integration. And I think some of the data you showed about what I'll call some of the empirical facts about the successes in terms of outcomes, I really genuinely believe, and we need more data from other contexts, are a result of the integration. This idea that in standard care, everybody's much more aware of evidence-based care when research is more routinely integrated. That when research is more routinely integrated, the good results that are found are more quickly adopted, which is a big problem in clinical specialties across the country. So there's something about being able to explain to people, when you come here, you are now part of a system that's committed to learning. We're committed to providing good quality care, and we're committed to learning. We're going to ask you to be part of research studies. Our good quality care is based on the fact that patients before you were willing. It's up to you, but we want to let you know that learning and giving care are part of this continuous cycle. And I think somehow describing that is also important, as well as knowing when to separate things.
Thank you. Let's go to on the right here.
Hi, I'm Dahlia Feldman, and I'm a neonatologist in Evanston, Illinois. The support study was very interesting to me, and thank you, Dr. Cass, for talking about clinical effectiveness. Research, definitely in neonatology, I'm sure in other fields, there are a lot of things we do that aren't always evidence-based, and certainly depending on which attending is on service, not only have the parents not chosen that physician because they're at the mercy of the rotation schedule, they're not picking their pediatrician, in the outpatient setting, so they might be exposed to a variety of practices. How do we not further erode public trust in medical care and still be upfront and really take the message to the parents that just because it's not a research study doesn't mean they're going to be getting the standard of care, or even if it's the standard of care, sometimes it's not proven to be the best type of care, and you can't figure that out without some of the things like support or other studies like that.
Yeah, I really appreciate your question, and I actually feel like it's one of the most critical questions for us to be figuring out in order to really be honest about informed consent and ethics with people. So Pearl had mentioned in the last panel about the importance of increasing research literacy, and this to me feels like a big piece of that, that somehow it ought to be acceptable and appropriate to say to families in any kind of context, here's what we know and here's what we don't know. We're going to do the best we can for you. But sometimes we honestly don't know what best means among a bunch of choices that all seem reasonable and different people are doing. And for doctors to only participate in things when they really personally feel like answering that question is important and appropriate, and only to talk to families about it where they really think that for that family it's appropriate. I mean, that's part of the trust that needs to be communicated to families. I wouldn't even be suggesting you enroll in this if I didn't think that this was reasonable. It's still up to you, but I want you to know that a lot of us are really debating what's the right oxygen here. And we all want to do what's best for you guys, and ultimately in the long run we're going to figure that out. So I know people get very anxious about disclosing there's a lot we don't know at really critical times. And I'm not going to be the world's best expert on exactly how it is that we disclose that, but I think it's really critical we figure that out and take that question on squarely, because it's first of all honest, and secondly, I really think it provides the context not only for why the research is important, for why it's not necessarily any riskier, and for why being part of this system of integrated learning ultimately is in our best interest, not only if we care about future people, but for ourselves.
I know, Norm, you have a comment?
I just want to say that a large part of the problem in public trust of research has to do with things like OHRP's reaction to the support study. Nancy didn't have time to cover everything in her talk, but to me, a huge part of the outrage over the support controversy, and the reason 45 of us or so signed this letter to the New England Journal, was not, we thought the study was okay in the way that Nancy said, but we thought what was really outrageous was OHRP going over the top in describing the study as ethically inappropriate, which, I mean, implying that it was ethically inappropriate, even though they said in their content, but threatening Alabama and these other institutions with shutdown. I mean, the letter did not yet get to that point, but OHRP has historically, over the last 20 years, in my view and the view of many others, overreacted to, so this was arguably a problem with the consent form that, as Nancy said, we all agreed could have been better. But to elevate that to a letter, a threatening letter from OHRP, of which a wrong answer could have led to suspension of all research at Alabama, these other institutions, that's what leads to, and by the way, the New York Times swallowed that hook, line, and sinker and wrote an editorial that would have made you think it was Auschwitz. I mean, the words that were used in the editorial were worse than the words that Marcia Angel used in her editorial about the AZT trials, that has just described it as a horrendous, that is, they misread the whole thing as sort of research gone wild. And I think this reaction of research is bad has been fomented by press overreaction, politicians overreaction, when there's just not enough publicity, that research is good, not just for future people, but for present people. As Steve has shown, it's good to be in a place where research goes on, even if being in the trial, you can't prove that that's a benefit in itself. Being in a place where there are people like this is where you want to be. Just one final word. My colleague Dave Demetz, who is an eminent biostatistician and a good friend of mine, and has said to me, if I'm ever sick and I get brought to the emergency room and you know about it, and you find out that I'm there and I'm unconscious, if there's research going on, make sure I'm in it, and second, make sure I'm in the placebo arm.
Okay. Steve.
So very quickly, because I see there's a number of people at the mics. One way, thinking about public trust, one way that you might try to avoid disrupting public trust is to try to keep anything that might disrupt public trust out of the public eye, right? Another way to do it is to sort of let it all hang out. And I think one of the worst things for public trust is when there's a perception, rightly or wrongly, that something was hidden, that something was not shared forthrightly with patients, with families, with the public, et cetera. So there was that perception with support. I don't think that it reflects the reality, but there certainly was the perception that these risks of death and other things were not shared forthrightly, and that's part of what the outrage is about. I'm thinking of a study also published in the New England Journal involving the randomization of different ICUs at different institutions to different infection control measures, and because the whole hospital was randomized to either infection control measure A or infection control measure B, there was no possibility of individual patients consenting, plus they were critically ill patients. But there were very clear notices posted up all over the ICUs explaining what was going on at the institution, letting people know about the fact that this was going on. There was a great deal of effort made to make sure that there was not a lack of transparency and that people had the perception that they were well informed. And so I think part of my answer is let it all hang out. Some of the information that you let hang out in the short run may be uncomfortable, but I think in the long run it's going to be better for public trust.
Okay, thank you. This microphone over here.
Hi, Pearl O'Rourke. This is to anyone on the panel. I think we're in a very interesting place right now on the cusp of all of this, health learning systems, where it needs the involvement not only of patients but also clinicians. And I think, Steve, while the cancer is a great example, most diseases, and certainly health, doesn't have the convening power of a cancer diagnosis, of, buy-in. And I guess I would love to hear some ideas of how are we going to possibly get not only patients, but clinicians to participate. We have tried a research notification concept, just telling people, congratulations, you're getting care at our hospital, and in a very celebratory way say, oh, by the way, we use your information for research and you really don't know about it. Have a nice day. But it's, when I'm saying it obnoxiously, it is what we do. We waive consent all the time. We review medical records. We look at tissue samples. We do it in a thoughtful and hopefully an appropriate way. And our feeling was it would be much better to be upfront about it than to have to be defensive if it's the front page of the Boston Globe article. And as we tried to do this, we got totally nixed by, number one, patients are going to say no, and number two, clinicians saying, we don't do that. There's no way you're pawing through my patients' medical records without their permission. So there's a huge gap, not only, I think, in patients, we all are patients, but the entire healthcare system. And I think if we are going to make a success of CER research, we have an awful lot of work to do. And I'm sort of perplexed as how we take the next step, because we certainly are being pushed down that path.
Great question, Pearl. So if I'm understanding your question correctly, I think I'm really agreeing with you and echoing what Steve said about transparency. I guess all I can say is just my personal view that we could do a significantly better job right now with transparency. For example, I haven't looked into this, but I really know of no hospitals that really do a lot of transparency about the quality improvement that they are required to do to get Medicare coverage, to be accredited by JCAHO. Hospitals have to engage in a wide variety of quality improvement measures. They have to report it to the CDC. And to me, this is something to be proud of. To me, I would like to go to a hospital that's participating in figuring out how many patients fall, how many patients have drug interactions, how they can fix that, how many patients have infections, what they're doing about it, that they're doing hand washing campaigns. And it seems that to even start with a lot more transparency about here are the kinds of things we do in order to continuously improve the care we can provide our patients, and do a lot of the quality improvement stuff, and also talk about some of the medical records things. We do it in terms of providing good quality of care in the delivery side about things like hand washing. We're doing it in terms of seeing through examinations of patients' records, whether these approaches work better than those approaches. I think starting to, maybe echoing what Norm said, right now what people to hear about research sometimes is the negatives. And if we don't do a much better job describing to people the positives that come out of it, we now do X. We now ask you to mark your own leg about which knee is being operated on, because we've learned that makes a big difference. Putting out many more of the positive stories, as well as just describing our commitment, I think starts to communicate the ethos and culture behind this learning, rather than are risking it sounding like it's one project and we're trying to get away with it, and you might get exploited, and it's just for those scientists to learn more and further their own careers.
Any other comments from the panel? Steve or Lainey? Okay. Next, on that side.
Mark Pine, I'm a pediatric pulmonologist and cystic fibrosis doctor from San Diego. And I was intrigued by the comments about how an acute diagnosis of a cancer could cloud judgment. And I'm thinking of that in contrast with the patients and families that I recruit for clinical trials, where by and large it's a very sophisticated group of people who have done a lot of self-study on the disease. And I can tell you from experience that rather than therapeutic misconception being the exception, it's more the rule. And it's not so much a misconception as perhaps hope, perhaps irrational belief that in fact participation in these trials will extend the life of their child. And it doesn't matter how much education you try to do, that's the real motivation behind enrolling their children in these studies. And so my question would be, If that's so, shouldn't we be considering basically all of these people as vulnerable populations and accept the fact that they're not motivated by the same things we think that they ought to be, and how to mitigate the harm from that?
Take a stab at this. So one implication of saying that population is a vulnerable population, one among several implications might be that they can't be their own decision makers, right? If you had an adult, you said this is a vulnerable individual, I'm going to take away their ability to make their own decision and give that to somebody else as a surrogate decision maker. And I certainly think we want to be very careful about, clearly if somebody has significantly compromised cognitive ability or something like that, we may need to do that. But I think we want to be very careful about doing that, because I think at the time when patients are sick or parents have a sick child, we want to really empower them to make decisions. So we wouldn't want to go there with the implication of vulnerability. A second comment is, we clearly don't want people to be under factual misunderstandings about the potential for the outcome that they're seeking, or what the facts are of the study. So we want people to have a good understanding of facts, and I do think that being under really an acute sort of critical diagnosis or not having time to think about something is a real risk factor for factual misunderstandings. I think it's a little bit less clear, at least to me, and I'll be interested to hear what others on the panel have to say, or what you would think, what the right motivation is from a patient or a family's point of view for being in a study. So if a family understands that, parents understand, or a kid understands that we don't know if this drug is effective, that's why we're doing the study. The point of the study is to learn if it works, what its side effects are, et cetera. And yet they enter the trial hoping that it is effective, even believing with some sort of an optimistic bias that although it may not be effective for everybody, they're going to be one of those for whom it is effective. I'm not so sure that that is a problematic motivation for being in a study. I think it is, we've shown in our research that in the phase 1 cancer trial setting where most patients have a very poor prognosis, overwhelmingly the motivation for joining those studies is hope for benefit from being in the study, even though the actual likelihood of benefit is quite small. And I'm not convinced that that's ethically, morally problematic, as long as we as clinicians, as investigators, have been sort of honest and forthright and unbiased in our presentation of the facts, and have not in any way taken advantage of people's propensity by sort of telling them what they want to hear about the likelihood of benefit. So I think our responsibility is to be clear and honest, and to present information in a defensible way. And I'm frankly less worried about the motivations that people bring to bear, as long as they're based upon an understanding of the facts that bears some relationship to reality.
Norm, and then Lainey, and then Nancy.
Yeah, I have some more concerns maybe than Steve does about that. So obviously honesty is required, and let's just stipulate that there's candid disclosure of information. But you have here parents for whom letting go is just got to be a horrendous choice. That is to say no to something that might, even though you're very candid, how remote about how long this is. And we have to remember that this tremendous success in children's cancer over the last 40 years is a millimeter at a time. That is, for anyone, there's no magic bullet, and no one patient in a study lived, a year longer as a result of being in a phase 1 and a phase 2 study in particular. So you have parents with this unavoidable conflict of being unable to lose a child. You have an oncologist who, despite his or her honesty, who not only has career need to not just recruit, but to complete the trial and to succeed in this incrementalism, to see if we can extend the survival curve from 3 months to 6 months, or 1 year to 18 months. And you have children who, especially in the case of small children, you can't claim altruism for a 2-year-old, and nor are you teaching him or her altruism. He's probably not going to survive to. And secondly, and if Annie Janvier is here, she'll be furious at me for saying this, but there's this other issue that just while children are not small adults, infants are not small children. So a 10-year-old or a 15-year-old might very well have a benefit from living another few months, the same that you and I would, of watching television or going to a game or being with your buddies and your family and all that. But for a 6-month-old or a 12-month-old who doesn't have hopes, dreams, aspirations, and doesn't get to do any of them anyway if they're a sick, dying cancer patient, they don't have that. benefit, that upside. So you have, I'm just concerned that honesty doesn't quite solve it with the parent and the oncologist both having these pressures to push on, and the child not having much to gain from it, especially if he or she's very young.
Lainey, then Nancy.
So I agree with Norm, for the record. But I want to go further than that. And I want to go further and say that it's the pediatric oncologists who have the therapeutic misconception. And the reason I say that is that how can we approve a phase 1 study? So we really never went over the Fed regs today, but in order to approve research in pediatrics, you either have to be a minimal risk study, which clearly this isn't. You have to have the prospect of direct benefit, and if we're truly being honest, phase 1 is supposed to be about safety and not about efficacy, so it shouldn't be prospect of direct benefit. The next type of research we can approve is research that involves a minor increase over minimal risk if the child has a disorder or condition. So clearly, children with cancer have a disorder or condition, but if we're going to call poisons merely a minor increase over minimal risk, we're just in denial. So the fact is we actually, under our current Fed regs, really can't approve phase 1 trials. And I've actually written about this, that we really need to, in a sense, rethink our Fed regs to be able to acknowledge it. Because if we're not acknowledging that it doesn't fit in to prospect of direct benefit, then how are the families going to understand that? So I think the first therapeutic misconception is amongst the healthcare providers themselves. I'm going to answer 2 other questions. One was, what's the right motivation? And again, I think it's totally reasonable for a parent to hope against all hope. 3% of phase 1 trials have actually shown some increase. Norm's point being very accurate, that increased survival is often measured in weeks or months. But there's nothing wrong with a parent hoping that, as well as they also understand that they are part of research, right? This keeps going back to that notion that until we've educated our families to be co-adventurers. And Lynn Jansen, who's a professor of philosophy in Oregon, has written a nice article where instead of talking about a therapeutic misconception, she'll also talk about the notion of a therapeutic misestimation, that there is this small chance, and it's just that parents probably think that their chance of their child benefiting from a phase 1 is closer to 50 or 60%, where it's less than 3%. And my last point in response to Steve was how he defined vulnerable. Children are vulnerable because they don't get to consent for themselves. Sick children are more vulnerable because their parents now are as vulnerable or more vulnerable than any other people I can imagine. But vulnerability isn't just about giving consent for oneself. Even, and you know, Steve's point was when we call an adult vulnerable, that means we say they can't consent for themselves. That's actually not true. Prisoners are vulnerable. So sometimes it's our circumstances. Circumstances can include illness. And I think that, as Norm pointed out, the parents of a sick child are just in such a horrific position. So I think they are vulnerable. I think we need to think about how our Fed regs are addressing the issue.
So Steve had a very quick point of anguish, so.
We have a little time. Why don't you take another question instead?
Okay.
I just want to quickly say that the fact that I completely agree that the likelihood of benefit from phase 1 trials is very small, but it's not zero in the aggregate, and that means that in my mind there is a prospect of direct benefit. The fact that the scientific objective of something is primarily to answer a question about safety or a question about appropriate dose to take forward to phase 2 trials has virtually nothing to do with a separate question of what's the estimate of the likelihood of benefit that might come from this trial. Those are really 2 different questions, and I don't think we should say that the fact that there's a safety objective translates into the conclusion that there's no prospect of direct benefit. That does not follow logically.
The first patient enrolled in a phase 1 is getting a dose that we know is not going to be effective. It is an absolute therapeutic misconception on your part as a cancer doctor to suggest that they are.
Let's
Maybe the 10th version or the 12th version.
Okay, let's move on to this question over here on the right-hand side.
I hate to interrupt great theatrics. I'm Brian Carter. I'm a neonatologist, anesthetist, and palliative care physician in Kansas City. My question has probably been all over the map as I've waited to ask it, because I think a lot of these things are so interrelated, but I'm with what I believe is a consensus on the panel that full disclosure, transparency, and efforts to instigate what boils down to a cultural change institutionally as well as professionally with the lay public, our constituents who we're serving in one sense, and whom we partner with in research is what needs to take place. I'd like to think that as bioethicists we can lead and champion that phenomena, even as difficult as it might be when nuanced IRBs particular to single institutions sometimes present problems. And that leads me back to the support trial. Because while UAB had the template, as it were, for the consent form, as Nancy nicely indicated, individual participants in the NRN study nuanced their own consent forms to use language that did not exist in the UAB template, in particular with reference to the inclusion of the possibility of death and disability. So while UAB may have borne the brunt of finger pointing and claims, the individual IRBs at institutions that were participating really bear the responsibility, not the single IRB of UAB, because they could have recommended anything and the other 22 sites decided not to use that particular language. Hence the individuality that really all of this gets back to. And finally, my original question for Nancy was, as she closed, she intimated that there are, let me see, the word was used, meaningful preferences, what I think some of us are familiar with as utilities-based decision-making. What are the utilities about the choices and the options and the outcomes for my making a particular decision? And I would posit as a neonatologist that there are no meaningful preferences with which we can approach parents on the cusp of their newborns, especially the critically ill newborn, with regard to research. We can't really incorporate meaningful preferences if those preferences haven't been substantiated in any evidence base. And the evidence base that existed at the inception of the support trial did not include the 2005 data from the BOOST trial, nor did the evidence include a large enough cohort to know that death was indeed a reasonable expected outcome.
You know, unfortunately, we are past time. So
thanks.
And I haven't heard the question yet, so I apologize, but we have to end.
Here's the question.
Well, no, actually, don't worry about the question because we can't answer it at this point. I'm sorry, but we do need to keep ourselves on time. I want to thank the panel. I do want to say one thing myself, not substantively, but I want to comment, Nancy, on your comment about not being a pediatrician. I think based upon all of your examples of how you describe things, you definitely are an honorary pediatrician. So, but thank you all. A few comments before the break. Three comments. Number one, we'll be meeting again in a half hour and to be hearing Eva Kor's talk. During the break, Eva will also be out signing books. For those of you who want to get a signed book from her, you can do it before the break or after the break. I would encourage some of you to try to go before the break. Second, remember to do your evaluations today. And third, tomorrow the doors open at 7:45 and the program will start at 8:15 and we'll see you back at 3:30. Thank you. Thank you. Okay, we're going to go ahead and get started. Hopefully you enjoyed the break and had some good conversation. And this is our last session, and it's really a privilege and honor for me to welcome and introduce Eva Kor, who will be our next speaker. And I really won't say much about her myself because I think she herself will be telling you her whole story. Both Doug Deacom and I have heard her talk at other conferences, and as we were planning this, we thought it would be really amazing if we could have Eva Kor come and talk with us, telling her story about her experience in Auschwitz as a research subject and her journey through the rest of her life. And I'll stop there and welcome Eva. Thank you.
Thank you very much. Dear friends, I am very pleased and honored to speak here today, and thank you very much for asking me to speak. My presentation is not the result of a well-researched academic paper, but is the fruit of my soul searching and trying to make some sense out of being a human guinea pig. I am trying to explain logically something that defies logic because it deals with feelings. It deals with the innermost of my soul, and many people cannot understand it. I am not a religious person. I am not an angel, nor am I a heroine. I am just a human being who survived many deadly experiments, who was treated as a subhuman, yet remained human, and who was been fortunate to discover the secret of self-empowerment and self-healing, namely forgiveness. In 1944, I was merely a disposable human subject. If I would have died, I would have been replaced by twins arriving on the next transport. I hope you grasp the importance of this event, my speaking to you here. A disposable human guinea pig from Auschwitz who could not be disposed of by the Nazi doctors is here to speak to you, the doctors, the scientists of today, about ethics in medicine. As I look around this room, I realize that I am in the company of many distinguished academic experts in the field of medicine, law, human behavior, medical research, and ethics in medicine. I also realize that you have asked me to speak to you today, not because of my great academic credentials, but because you want to know how does it feel to be a human guinea pig, used and abused in human experimentation. I applaud your efforts. This is the most appropriate tribute to the memory of those who died, including my twin sister, Miriam Moses Zeiger. My speech is divided in 3 parts. 1, how I survived Auschwitz. 2, how does it feel to be a human guinea pig, and the lessons for ethics today. 3, self-liberation and self-healing through forgiveness. In May of 1944, we, the Moses family, my father, Alexander Moses, age 44, my mother, Jaffa Moses, age 38, my older sister, Edith Moses, age 14, my middle sister, Alice Moses, age 12, and Miriam and Eva Moses, identical twins, we were 10. We were loaded onto a cattle car. We came from a tiny village of 100 families called Ports in Transylvania, Romania. In 1940, our village was occupied by the Hungarian army, so we were part of the Hungarian transport that was sent to the Auschwitz death camp. It was the dawn of an early spring day in 1944. Our cattle car train came to a sudden stop. I could hear a lot of men's voices yelling orders outside. We were packed like sardines in the cattle car, and above the, as soon as long my father, an SS trooper, hurried by shouting, "Are they twins?" he asked. It would be the last time that we saw her. This was just 30 minutes from the time we stepped down from the cattle car onto that selection platform, and we were ripped apart from our family forever. I will never forget that little strip of cement called the selection platform. It measures 85 by 35 feet, a strip of land where millions of people were ripped apart from their families forever. I believe that there is no other strip of land part of a group of little girls, all twins, 13 sets of little girls, age 2 to age 16. And one mother was permitted to stay with her 7-year-old daughters. We were marched to a huge building and made to sit naked for the better part of the day. Late in the afternoon, our processing began. We were given short haircuts. The mother's head was shaved. Our clothes were returned with a huge red oil-painted cross on the back because we were identified as human subjects for experiments. To have our own hair and our own clothes was a privilege that we, the twins, were granted. Then we lined up for registration and tattooing. When my turn came, I decided to give them as much trouble as I possibly could. 4 people, 2 Nazis and 2 women prisoners, restrained me with all their strength while they heated a pen-like gadget over the flame of a lamp, and when it got really hot, they dipped it into ink, and then they burned into my left arm, dot by dot, the capital letter A-7063. Miriam became capital A-7064. Auschwitz was the only Nazi camp that tattooed its inmates. Years later, Miriam told me that in addition to creating a general confusion, I bit the Nazi holding my arm. I don't remember biting anyone. I must have blocked it out of my mind. After all, I was raised to be a nice girl. And nice girls and nice boys don't bite. To look back at my childhood is to remember my experiences as a human guinea pig in the Auschwitz, is to relive of horrors of human experimentation where people were used only as subjects to research. I envision the chimneys, the smell of the burning flesh, the medical injections, the endless blood taking, the tests, the dead bodies that were all around us, the hunger and the rats. Nothing that is close to human existence existed in that place. Nothing on the face of this earth can prepare anyone for a place like Auschwitz. At age 10, Miriam and I became part of a very special group of twins, children used as human guinea pigs. 1,500 sets of twins were used by Mengele in his experiments. That first night, when Miriam and I went to the latrine, there on the filthy floor were the scattered corpses of 3 children. This is when I realized that that could happen to Miriam and me unless I did something to prevent it. So I made a silent pledge that I will do whatever is within my power to make sure that Miriam and I shall not end up on that filthy latrine floor. In the barrack, we were children, girls, aged between 2 and 16, huddled in our filthy bunk beds, crawling with lice and rats. We were starved for food. We were starved for human kindness. And we were starved for the love of the mothers and fathers we once had. We had no rights, but we had a fierce determination to live one more day, to survive one more experiment. No one tried to minimize the risk to our lives, and no one showed us any respect or consideration. On the contrary, we knew we were there to be used as guinea pigs at the mercy of Dr. Mengele and the other Nazi doctors. We were used in a variety of experiments. 3 times a week, we would walk to Auschwitz I, where we would be placed naked in a room for up to 8 hours a day. Every part of my body was measured, compared to charts, and compared to my twin sister. These particular experiments were not dangerous, but they were very, very demeaning. And even in Auschwitz, I could not cope with the fact that I was treated like a nobody and nothing. The only way that I could cope with it is by blocking it out of my mind. Even at that young an age, we knew we had to submit to Dr. Mengele's experiments. We were reduced to the lowest form of human existence, just a mass of living, breathing cells. Our families were gone. Our lives depended on being a cooperative mass of living cells. There was no escape from it. Our childhood was gone, snatched away by the Nazis. Our bodies were fodder for Mengele's experiments. All we had were our lives. And I concentrated all my efforts, all my talent, all my being on one single thing: survival. 3 times a week, we were taken to another lab that I call the blood lab. They would tie both of my arms, take a lot of blood from my left arm, and give me a minimum of 5 injections into my right arm. Those were the deadly ones. After one of those injections, I became very ill with a very high fever, a fact I desperately tried to hide, because the rumor was that anyone taken to the hospital never came back. On the next visit to the blood lab, the doctors measured my fever. They never examined me, and I was taken to the hospital, which was filled with people who looked more dead than alive. Next morning, Dr. Mengele and 4 other doctors came to see me. They never examined me, just looked at my fever chart, and Dr. Mengele said, laughing sarcastically, "Too bad, she's so young, she has only 2 weeks to live." I was all alone. The doctors I had did not want to save my life, they wanted me dead. Miriam was not with me, and I missed her so very much. She was the only kind and loving person I could cuddle up with when I was hungry, cold, and ill. Even though I was very sick and all alone, I refused to die and made a second silent pledge that I will do everything within my power to prove Dr. Mengele wrong, survive, and be reunited with Miriam. For the next 2 weeks, I was between life and death. I remember waking up on the barrack floor. I was crawling because I no longer could walk, and I was crawling to reach a faucet with water at the other end of the barrack. This barrack was not allocated any food nor water nor medicine, since people were brought there to die. As I was crawling, I would fade in and out of consciousness, and I kept telling myself, I must survive, I must survive. After 2 weeks, my fever broke, and I immediately felt much better. It took me another 3 weeks before my fever chart showed normal, and I was released and reunited with Miriam. But the happiness of our reunion was short-lived. Miriam looked just like the living dead I left in the barrack. She was sick and lost her desire to fight for her own life. It was very easy to die in Auschwitz. Surviving was a full-time job. The will to live often made the difference between life and death. Next day, I volunteered to carry food from the kitchen to the barrack so I could organize, which in camp language meant stealing from the Nazis. And please forgive me, but I will always call it organizing. I wanted to organize raw potatoes. As I entered the kitchen, I saw a long table with 2 sacks of potatoes underneath it. I hesitated for a moment because the rumor was that anyone caught stealing would be hanged. I finally conquered my fear and bent down. I could feel 2 small potatoes in my hand when somebody grabbed me by my head, pulled me up, and yelled into my face, "It's not nice to steal." I almost burst into laughter because I expected to be dragged to the gallows and hanged. I just learned a very important lesson, that as long as Mengele wanted us alive, no one dared harm us. Next day, I tried my organizing skills again, and I became the happy owner of 3 raw potatoes. We boiled them at night after the supervisors went to sleep, and I became a very good organizer. We had potatoes 3 to 4 times a week. The steady diet of potatoes gave Miriam enough strength to fight for her own life. When I was in Auschwitz, I thought that the whole world was a big concentration camp. Children lose their point of reference very fast. One day in August of 1944, I saw an airplane fly over Auschwitz. It was flying very low. I could see the American flag on one of the wings. That gave me the realization that somebody was trying to free us. That knowledge reinforced my determination to live one more day. Also, it gave me hope, and hope in Auschwitz was in very short supply. The air raids and fighting by the Allied forces continued and increased until liberation. On January 27, 1945, just 4 days before my 11th birthday, Auschwitz was liberated by the Soviet army. We were free. We were alive. We have triumphed over unbelievable evil. The glory of that day will be forever engraved in my heart, and the echoes from Auschwitz will always be part of my life. My silent pledge that first night in the latrine became a reality, and that was an unbelievable experience. Part 2. I, Eva Kor, a survivor of Mengele's Auschwitz experiment, have learned that human rights in human experimentation is an issue that needs to be addressed and taught. Those of you who are physicians and research scientists are to be congratulated. You have chosen a wonderful and difficult profession. Wonderful because you can save human life, and difficult because you're walking a very narrow line. You have been trained to use good judgment and clear logic, but you cannot forget that you are dealing with human beings. The moment you forget and cross that narrow line, you're heading in the direction of the Joseph Mengeles. I hope that what was done to me will never happen to another human being. Those of you who do research must be compelled to obey the international law. Scientists should continue to do research and I have personally benefited from your research. My son, Dr. Eva Kor, in 1987, was diagnosed with an advanced case of testicular cancer that had metastasized in his lungs and lymph nodes. I am so grateful to medical research that found a cure for my son. I want to thank Dr. Lawrence Einhorn from Indiana University Medical Center for saving my son's life. I am personally aware both of the benefits and drawbacks. Medical science can benefit mankind, but it can also be greatly abused. The scientists must make a moral commitment never to violate a person's human right and human dignity. The research scientists must respect the wishes of their subject. Every time you, the scientists, are involved in human experimentation, you should put yourself in the place of your subject and see how you would feel. The scientists of the world, must remember that research is done for the sake of mankind and not for the sake of science. You must never detach yourselves from the subject you serve. If you do not know what to do, just ask yourself a simple question. Would I want to be treated this way if I was one of the research subjects? And if the answer is no, then you are doing something wrong. I hope with all my heart that our sad stories will in some way impel the international community to devise the rules to govern human experimentation. The dignity of all human beings must be respected, preserved, and protected at all costs. Life without it is a mere existence. I experience such loss of dignity every day as a guinea pig in Mengele's lab. These same doctors had taken an oath to save human life, yet they violated it. From 1944 until 1995, for 51 years, I felt deep emotional pain. I was a victim who was angry with the world and who could not be really happy. I was physically liberated from Auschwitz on January 1945 by the Soviet Army. I liberated myself from the emotional pain in January 1995 when I forgave the Nazis, and this is what happened. After liberation, Miriam and I were in refugee camps for about 9 months. We arrived back to our village to find 3 crumbled pictures on a bedroom floor. And that was all that was left of my family. We were taken in by an aunt who lost her family, who married a guy who lost his family. We lived in communist Romania from 1945 until 1950. During that time, I learned that the communists had beautiful slogans, but freedom was still just a dream. We wanted to leave Romania for Israel, but they did not let us leave. For 2 years, we struggled to get our exit visa, and then the Romanian government took away all our land, property, and everything we had, permitting us to take only what we could wear. I wore 3 dresses and a winter coat in the middle of the summer. I stood in line for that coat for 20 hours, and I was not going to leave it behind. In 1950, we arrived in Israel. After 2 years in an agricultural school, we were drafted into the Israeli army. Miriam studied and became a registered nurse. I stayed 8 years in the engineering corps, reaching the rank of sergeant major. In 1960, I met and married an American tourist from Terre Haute, Indiana. He is also a Holocaust survivor who was liberated in Buchenwald by an American colonel from Terre Haute. So, I came from Tel Aviv to Terre Haute, Indiana. Quite a jump. Miriam got married in 1957. In 1960, when she was expecting her first child, she developed severe kidney infections that did not respond to any antibiotic. With a second pregnancy in 1963, her kidney infection got worse, and the doctors found out that Miriam's kidneys never grew larger than the size of a 10-year-old child. After her third pregnancy, her kidneys failed, and in 1987, I had 2 kidneys, 1 sister, so I donated my left kidney. We were a perfect match, but a year after the transplant, she developed cancerous polyps in her bladder, the only one among 2,000 transplantees at that hospital to develop such cancer. The doctors in Israel said if we could find our Auschwitz file, that would help them figure out why Miriam was the only one to develop such a cancer. We never found out what was injected in our body. All the doctors could say that something that was injected in her body combined with an anti-rejection medication to create the cancer. I looked for our Auschwitz file, and I am still looking for them, but we never found them so far. Miriam died on June 6, 1993. I came home from an open house as a realtor on a Sunday afternoon. There was a message on my answering machine from my brother-in-law telling me that Miriam died. I immediately called Israel, telling my brother-in-law that I will catch the first flight to Israel. He told me not to bother since the funeral was in 10 hours. Israel is 7 hours ahead, and there was no way that I could get there in time. I pleaded with him to wait for me. I told him I have never buried any member of my family. A simple human gesture. I wanted to touch her. I wanted to say goodbye to her. And I even wanted to say goodbye to my kidney. But he said no. I was devastated trying to cope with the death of my only sister. 3 weeks after Miriam's death, I received a telephone call from Dr. John Michalczyk, who said to me that he heard me speak at a conference about Nazi medicine, and he wanted me to come to lecture to some doctors. I said to him that I love to lecture to doctors, and I do. He asked me why, and I explained that when I go to the doctor, they tell me that I'm too fat, I don't eat the right food, I don't exercise enough, and then I have to pay them. I would like to tell the good doctors what they do wrong, because in my opinion, doctors do plenty of things wrong too. And after I choose them out, I look forward to them paying me. So Dr. Michalczyk said to me, Eva, when you come to Boston, it would be really, really nice if you could bring with you a Nazi doctor. A Nazi doctor, I asked, stunned. Where on earth do you think I can find one of those guys? Last time I looked, they were not advertising in the yellow pages. He insisted that I think about it, and I promised him that I would. I remember that the last project that Miriam and I worked on together in 1991, and we finished it in 1992, was a documentary on the Mengele twins done by ZDF, a German television network. In the documentary appeared a Nazi doctor by the name of Dr. Hans Munch. He was not my doctor, but I figured he might be still alive, and I immediately faxed a letter to Germany, telling them that Miriam just died, and would they please give me Dr. Munch's telephone number in the memory of Miriam. And they did. We contacted Dr. Munch and asked him to come to Boston, but he said that he could not come to Boston. Instead of that, he was willing to meet with me in Germany. So from that time on, the nightmares have ended, but now I had another nightmare. I was going to go and meet a Nazi doctor. In August of 1993, we arrived in Germany to meet this Nazi doctor. I was very, very nervous. What I remembered about Nazi doctors, I did not want to experience again. But I was also very curious what I might learn about our experiments. And why was this Nazi doctor willing to meet with me? We arrived at Dr. Munch's house, and he treated me with the utmost respect and kindness. It was overwhelming for me to be treated that kindly by a Nazi doctor. Unfortunately, he said he knew nothing about our experiments because Mengele always said it was top secret, and he never shared any of the details. But he gave me a good interview for my Boston conference. I felt very much at ease in Dr. Munch's company. I realized that this might be one of the only times in my life that I could talk to a Nazi face to face. And I wanted to know if he knew anything about the gas chambers in Auschwitz. But this was a question that only popped in my mind at that moment. I have never ever thought about it before. So I asked him, Dr. Munch, do you know anything about the gas chambers? This is a nightmare I live with every single day of my life, was his answer. Then he went on, describing the operation of the gas chamber. People would be told to remember their hangar number. Then they were taken into the shower room, which looked very good, even smelled good because they spread a lot of perfume. Once the shower room was packed, the doors closed hermetically. Dr. Munch went outside. A vent-like hatch opened in the ceiling, in the roof. Zyklon B, which looks like pellets of white gravel and operated like dry ice. The container was opened and dropped from the roof, and it fell to the floor. People were trying to get away from the rising gas, and the strongest ones ended up on the top of the pile. When the people on the top of the pile stopped moving, Dr. Munch knew that everybody was dead. Then he would sign one certificate stating how many people were killed in the gas chamber. This was information I had never heard about it before. I immediately asked Dr. Munch to come with me to Auschwitz on January 1945. Then we would observe 50 years to the liberation of the camp. He immediately said that he would love to. I did not know that it was going to be that easy to convince him. Then I came home from Germany. I was very excited that I would have a document signed by a Nazi. I wanted to give him a gift as my way of thanking him, but I did not know how to thank a Nazi doctor. Where does one go to look for a gift for a Nazi? I didn't want to tell anybody about it because I was afraid that they would convince me not to do it. So I went to the local Hallmark shop, card shop, and I went to the section of thank you cards. I read many cards, but I found no card appropriate for a Nazi doctor. So I went back to my life lesson number one. And my life lesson number one, when I give a lecture, a general topic lecture about survival and forgiveness, is never, ever give up. For the next 10 months, I kept asking myself when I was cooking, cleaning, doing the laundry, or driving the car, when my mind wasn't too busy, how do I thank a Nazi doctor? What can I give this Nazi doctor? All kind of ideas popped into my mind until one day the following idea came to me. A simple letter of forgiveness from me to him. I knew he would like it, but what I discovered for myself was much more important. That I discovered that I had the power to forgive. No one could give me that power, and no one could take it away. It was all mine to use it as I pleased. Victims are always hurt, angry, feel hopeless, feel helpless, and feel powerless. I discovered that I had a power I didn't know before. I began writing my letter to Dr. Munch. I wrote many versions, working through a lot of pain, but I was concerned with my spelling in English, so I contacted my former English professor to correct my spelling. We met about 3 times. Then she said to me one day, Eva, it's nice that you're forgiving Dr. Munch, but you really need to forgive Dr. Mengele. Your problem is with Dr. Mengele. I said that this was just a little letter for Dr. Munch. She asked me when I got home that night to promise her that I would think about forgiving Dr. Mengele. What she wanted me to do, if I could say that I forgive Dr. Mengele, how it would make me feel. I promised her that I would. Then I realized that I had the power to forgive even the angel of death. And I realized that I did have that power. I wasn't hurting anybody. So if I forgave Mengele, the worst of them, I might as well forgive everybody who has ever hurt me. It made me feel really good to have that power in my life. Up to now, I always reacted to what other people have done to me. Now, I was initiating action, and I was not hurting anybody, so I had no reason not to do it. And it really made me feel good. We arrived in Auschwitz on January 27, 1995. Dr. Munch came with his daughter and son and granddaughter. I came with my son, Dr. Alex Kor, and daughter Rina Kor. Dr. Munch signed his document. I read mine and signed it, and immediately felt that all the burden of pain was lifted from my shoulder. I was no longer a victim of Auschwitz, nor was I a prisoner of my tragic past. I was finally free of Auschwitz and free of Mengele. Forgiveness is an act of self-healing and self-empowerment that brings serenity, freedom, and peace. Anger is a seed for war. Forgiveness is a seed for peace. I call forgiveness the modern miracle medicine. You don't need to belong to an HMO. There is no copay. It will not bust your budget. So everybody can afford it because it's free. It has no side effects. It works. You do not need to fill out any informed consent form nor any compliance forms. For those people who are unsure if they will miss their pain, if you don't like the way you feel free, you can always go and take your pain back. In 1984, I founded an organization called Candles. In 1995, I founded Candles Holocaust Museum and Education Center in Terre Haute, Indiana. I like the name because candles are used as a memorial and candles illuminate. Candles is an acronym for Children of Auschwitz Nazi Deadly Lab Experiment Survivors. We wanted to shed some light on the darkest chapter of the Holocaust, the chapter of the children used as human guinea pigs. Somebody said that the light of one single candle can illuminate the darkness of the entire universe. I am asking every single one of you to remember the Nuremberg Code, and as you leave my presentation, wherever life takes you, become a glowing light, an example of caring and ethical behavior, and never use a human being in experiment without informed consent. I hope, in some small way, to send the world a message of hope, a message of healing, a message of forgiveness, and a message of peace. Thank you all, conference organizers, sponsors, and user participants. As I look at you, I can see a powerful beam of light going out of this room, spreading throughout the world to illuminate all the dark corners of human rights and human experimentation across the globe. Before I finish, I would like to share you one more thing. One of my life lessons that I share with other people is give your parents an extra hug and an extra kiss for all of us children who had no parents to hug and kiss. I would like to ask my son, Dr. Alex Kor, who is here with me, to come up so he could give me a hug and a kiss. Congratulations, you have survived my lecture, and so did I.
Well, thank you. That concludes our conference for the day. Eva will be out in the front signing books. Eva, thank you again. I'm so happy you were able to do this. We really very much appreciate it. And we'll see you all tomorrow morning, 7:45, doors open, 8:15 it begins. Thank you.